from painful condition. I once again express my sincere thanks and gratitude and welcome you all for ISPCCON 2023.
Thank you so much, sir, for your introduction. Now I would like to call on Dr. Viren Rastogi, sir, the founding member, ISPC, to throw the light on the of pain medicine.
Good morning. I don't know, is the chairperson?
Sir, I request Professor V.K. Mohan sir and Dr. Pankaj Surange to please chair the session. Now I request Professor Rastogi sir to kindly address and give us the words of wisdom.
when have got some either training or has some diploma or certificate courses, who have done some post-graduation. So this was just to, only problem with the Indian Society for Study was multidisciplinary and multi-professional. So it also includes the nurses, it also includes the, you can say that physiotherapists, neuro and surgeon, etc. So what we have to do, let us focus on the one thing, that this person being clinician. So that's why how we started having the pain medicine as well as a specialist pain clinician. So this I thought is a very, you can say that World Congress on Pain was held in Hamburg in West Germany 1987, and I happened to attend this conference as a secretary ISSP. And this is the time when the International Association for the Study of Pain granted the ISSP as Indian chapter. And now the things start moving from that day, and we were a full-fledged ISP chapter. This is myself, you can see the Dr. Bhatia is there if you remember. And then the ISSP, Indian Society for Study of Pain, it was established in 1984 in Varanasi, was recognized as Indian chapter of International Association for the Study of Pain. Inaugural conference of the ISSP held in Varanasi itself in 1985. Now, I hope that more than 1,000 members all over the country, and with different discipline as well as the different specialty. They are publishing Indian Pain regularly. It is multidisciplinary and multi-professional society. Now we have 40th conference at Pune. It has contributed in creating awareness among the public, caregivers, and it also contributed in education and training pain management. It also helped in establishment of pain medicine as a super specialty of medicine. Still we are trying hard to get it from the National Medical Council. I think future we will read through it. So this is the conference in 1985, and one, you can say that Dr. Stanwas and Dr. Lal, if you is the founder president, and this Dr. Stanwas, actually he was a representative from WHO Cancer Pain Relief Program, and he addressed this, introduced the WHO Pain Relief Program for the first time in India. And you can, Dr. Pandey, Professor Pandey, actually he was first president of Indian Society for Study of Pain. And then after 30 years of that ISSP, we launched another society, which is the Indian Society for Pain Clinician. It was 2015. The inaugural conference held at Varanasi, inaugurated by the UGC secretary. And you can see that Dr. Anil Agarwal is there, Dr. Lal, and Dr. L.D. Mishra. So this is the first conference which held at Varanasi. And we also have a Indian Journal of Indian Society of Pain Clinician. And now more than 100 members at this day. Then the ISP established in Varanasi, Varanasi 2015. Second annual conference at Chandigarh. Third, we had in Mumbai. Fourth, we had in Lucknow. And fifth conference held in Delhi. After that, because of Corona pandemic, we were not having a conference in 2020, 2021, and 2022. Sixth conference at present we are having at Lucknow. the education training in pain medicine. What was the opportunity in pain medicine? So we started with that. Initially, one Cancer Relief India. It is a Chilean from UK, and there is a Macmillan Cancer Relief Fund. They sponsored few doctors and nurses from India. Palliative care at London Export, Oxford. So this is first she wanted that train the Indian doctors and nurses. Then another was a Varun Mahajan Memorial Fellowship, which was from the Sloan Kettering Hospital in New York, USA. And this is a memory of Varun Mahajan. And they gave a 6 weeks fellowship, travel fellowship. Then it was in 2008 when we started a 1-year structured courses, postdoctoral certificate courses in management in India. And at Varanasi we had first and followed by SGPI in Lucknow. Then 2 years PDA course and FND courses. No, at least 2 centers, Chennai, they are running these courses. I hope that which are more and more courses, FND. Then we have pain medicine. This I know that in courses. 20 institutions who are having the DFN courses and only 2 medical colleges having DN. So now the need of the hour is that we should have more and more courses in it. So on this forum, I want to say that the effort should be all these members together, and so that we have more other courses. Now, education 3-year courses, 2-year courses Gangara Hospital, Delhi, and Chennai, PDA courses at AIMS, Delhi, SGPI, Lucknow, and 1-year courses there are more than 20. One in IMS, BHU, RML Institute, KGMU, PDC, and recently Mangal started 1-year PDC. I saw that advertisement. PDF courses, they are from the mostly from the university, and they are from Maharashtra University of Health Sciences, BJ Medical in Pune, KGMU Hospital Mumbai, Lilavati Hospital Mumbai, Bharati Vidyapeeth, DY. There may be more centers and for the future. Whether I don't have that information. If anybody is running these courses, I will be happy to add these links. So now comes the curriculum in payments. What should be the curriculum when we design for 1-year course? What should be curriculum when we design for 2 years course? What should be for a few things like that. You can say that we should at least include DMR, biology, because thing is that if you see that only rheumatologists can write down this DMR, this DMRD. So unless you include it in your curriculum, you are not eligible or you are not prescribing these drugs. Second, I think UN try regarding the endoscopic disposal. So endoscopic this procedure actually this fixed percutaneous number endoscopy is taken. Then PSLD stenotic number disease is taken. So these are the things which I am happy to announce that that now it should be included whenever we plan for that, even for 1 year post PTCC, we have that or PM. So the need of the hour to include these endoscopy these procedures, so that there is a clear message should go that the pain medicine, even from the list of that Ayushman Bharat, they have included these endoscopy procedure for pain medicine. But I don't know why they have withdrawn it. But the pain medicine fellow can do these procedures. So what I need to define what is expected from TM, what should be expected from PTA, FNB course or 1 year course. So another thing what I want to mention regarding what is the current status of pain medicine in various government schemes like PMSSY and TPA. So actually this PMSY, CGH, so this is very important. Unless your pain medicine procedures are not included in this Ayushman Bharat, it is not included in CGHS, it is not included in TPA or third party assurance. So you cannot have these and we are losing a large segment of people because of pain. And they are also deprived of the pain treatment. So actually this is actually I brought from 2022 document. So when they have included few like you can say the nephrectomy and these are the few they have included. But what I heard that in the current status they have withdrawn it, I don't know. So we have to find out. But still some procedures are there. This slide is not very clear, but purposely I brought this a document from the health insurance, Star Health Insurance, and it clearly mentioned that the pain procedures are included. Like that you can say the RMP lottery for the, you can say knee joint with but PRP is not included. Otherwise, other procedures are included, and you can take advantage of this slide or whatever information. Try to pursue your TPA or health insurance as a first patient, and they can take advantage of that. So this purpose is from the Star Health. Then comes the, I acknowledge the contribution of following in developing pain medicine. There's a big list, but few I have selected here, those are the grandfathering period. Like you can say the Professor K. Pandey, you must have heard of, Dr. Bhatia was there, Dr. S. Yagnik, Dr. Sushila Shah from Mumbai, Dr. K. Sharma, he was a physiologist from Delhi. So there is another society which came, Indian Society for Pain. So they have formed Avicii UCMS, Dr. S.S. anesthetists, Dr. S. Surya, already familiar, Dr. Akram Lal, Dr. Gill, Dr. Baheti, Dr. P.N. Jain, Pradeep Jain, Dr. Dr. Anil Agarwal, I may, but next generation, which is now coming, you can say the so this is the generation which is taken over, and I think they can a lot. So take home message. First thing, still I say, still what we are lacking to create awareness, newspaper, to TV and other things, and DM course, then training. What a DM course is, NMC, and they are already under process, and we hope that the curriculum should be, if you are not included, procedure, so that members should not have any. Then of department corporate hospital. So this is important. Despite for the NMC, the moment we have NMC recognition, we can have this department for pain medicine. Then, you know, the medicine is very old. Even after we said pain, but they are good. So that is how we are back, and the pain procedures, all the effort should be particularly in these in ISPCON. Thank you very much.
Thank you, sir. Kindly take your seat on the stage. I would like to invite Dr. Naveen, sir, Professor and newer innovation in pain medicine.
Amy, can you help? Thank you, the organizers of ISPCCON-2023 for the warm invitation. Madam Sarita Singh, Dr. Nish, and all the organizers. It's an honor to have Dr. Rastogi sir on dais and Dr. Virendra Mohan and Dr. Panchal. And it's really more privileged to speak after sir, who is pioneer in the field of pain medicine. And I shall be deliberating on primarily current status, where we are. I know we are all sitting on the laurels of the hard work done by seniors and teachers like Dr. Rastogi sir. And I bring with myself greetings from KGMU, Haryana, where I am currently working. This is our OPD complex, and this is our pain management center, the Dard Nivaran Kendra. And I'm happy to share with you that like any other gynae orthopedic medicine OPD, we have got a very good footfall and around 150 to 175 patients per OPD and around 30 to 40 blocks being done as a daycare procedures in the pain OT of the OPD complex itself. And on Mondays and Thursdays, we have dedicated fluoroscope guided blocks OT, and Wednesdays we have got USG guided blocks OT. And so we are working 6 days exclusively in pain medicine, and we are also catering to the emergency patients on Sundays also. And this is the pain OT of our pain management center, a 6-bedded recovery room where patients recapitulate after the procedures, and big waiting area where we can have around 60 to 70 patients waiting at a time. So dear friends, if you are positive, you will see opportunities instead of obstacles. And over the next 2 days, you will be listening more about the definition and the different types of chronic pain syndrome. I'll focus on the pain physician. Pain physician, we the pain physician are specialists who assess and evaluate pain, classify and rate them, and then treat them effectively. And for that, we need to have in-depth knowledge of pathophysiology, pharmacology, and should be skilled in the MIPSs, the minimally invasive pain and spine interventions. And it is rightly said that the good physician treats the disease, but the great physician treats the patient who has the disease. So that is the motto of pain medicine, that we have to make the patient not only pain-free, but improve his quality of life. So to build a career in pain medicine, we should have a keen interest in chronic pain, and we should be very, very good listener. Listen, listen, and listen to the patients who have got chronic pain. Unfortunately, as anesthesiologists, we are not used to listen to the patients. We usually, if they are in pain, or they are a bit anxious, we sedate them, we anesthetize them, or make them pain-free, and so that they're cool, calm, and quiet. But in chronic pain, you need to have infinite patience to listen to the patients, understand their patient pain, be compassionate, and infinite patience is the hallmark. Why we anesthesiologists should be the pain physicians? Because we are well versed with the art and science of treating pain, and our role as pain physician is a natural extension of our professional work. And it gives an opportunity to shed the behind the curtain image. So the notion that anesthesiologist is behind the curtain force has changed somewhat, but more steps are needed. For that, teaching and training, as sir was highlighting, is important. NMC in September 29 has devised a very nice competency-based PG training program for MD anesthesiology, where there is a full 1.5 page about the pain procedures and pain education at the level of postgraduate. We'll dwell that in the subsequent panel discussion also. But motto is that the curriculum has been designed by NMC. Now it is the imperative duty of the HODs of anesthesia and in charges of pain clinic and pain management centers that they percolate this knowledge and skills to the postgraduates so that they develop interest in pain medicine starting at the PG level itself. As sir has rightly said, all fellowships of 1 year and DM courses and by the associations including Indian Society for Study of Pain, FIPM, they are being continued across the country with good results. And this was one major milestone which we have been able to achieve under the guidance of Dr. Rastogi sir. This is NMC recognized additional qualification, the FNB in pain medicine, and as a convener of Specialist Board of Anesthesiology of National Board of Examination at that time, I was fortunate and lucky enough that our team was able to push through this particular FNB in pain medicine in the year 2020. It is a dedicated 2 years course exclusively for DA, MD and DNB students, right now going at Chennai and Delhi, and Kolkata is the latest edition. Dr. Krishna Podar is running, she is sitting here in the audience. And next, as sir was saying, that we need to start DM pain medicine, and work is going on at rapid pace to have DM in pain medicine, which is an additional qualification by the NMC. But friends, whatever you want to do, appear in the NEET SS exam or fellowship entrance test exam, please do it within the first 2 years of your senior residency, because then more responsibilities come up, especially for the ladies. Marriage, parents' pressure and pregnancy and being antenatal, all those things come. As a husband, I can say it's easy for me to move out of the house, but mother has so many responsibilities. So please complete the training as early as possible. And during this training, you will be exposed to the essential skills of history, examination, very, very important before going for interventions. Pain medicine is not only interventions. You have to have detailed history, do examination, diagnose the pain generator, be very good in investigations, including the radiological one. You need to know the knowledge of reading MRIs and X-rays, and then perform the MIPCs. So the topic given to me is current status. So I'll quickly go through the current status. Right now we are following the multimodal approach, which includes pharmacotherapy, which includes precautions and exercises, also includes psychological support, and then the MIPCs, which we commonly perform day in and day out, which sir was also highlighting. And these are the current pharmacotherapies which we'll be discussing over the next 2 days. Over this, the newer one and the earlier one, including the psychological approaches and the MIPCs. 60% of the patients which come to us are suffering from musculoskeletal pain, and in the musculoskeletal pain are low back pain. This is the incidence all across the world, and you need to, during this teaching and training, you will be exposed to the selective nerve root blocks under fluoroscopic guidance, and the other routes of epidural injections like fluoroscopic guided caudal epidural injection, fluoroscope guided USG guided caudal epidural injections. So you can, nowadays everything is image guided, and you need to be sure where your needle is going, where your drug is going, whether you are reaching at the affected compartment or not. And you need to be thorough with the knowledge of the USG phonoanatomy as well as fluoroanatomy, midline epidural interlaminar approach or the parasagittal approach, depending upon the need of the patients. Similarly, you can perform a cervical epidural, maybe in sitting and prone position, and at times leave the catheter also in situ. The other subset, in addition to PIVD, is the facet joint arthropathy, where you need to perform intra-articular facet joint injections or the medial branch block, diagnostic followed by radiofrequency ablation. Moving further down, patients may come to you with coccygodynia, pain in the tailbone. If not responding to conservative treatment, you have to go for the ganglion impar block, either through the first intercoccygeal approach or the sacrococcygeal approach, and then subsequently do radiofrequency ablation also if need be. And for CA patients, you go for a neurotic block. Moving further down buttocks, you can have a patient suffering from piriformis syndrome, and you need to go for block of the piriformis. Sacroiliac joint, slightly lateral, the largest diarthroidal joint of the body, where you can inject at the lower 1/3 after ruling out caries and neoplastic infiltration and seeing the drug spread all across the joint. And you can do it under fluoroanatomy or under the UAG guidance also. Moving slightly further down, hip joint patients, definitive treatment is THR, but some patients are not affording, some are not medically fit, so we can go for intra-articular injection of the PRP joint, in the hip joint and see the halo sign. Knee joint osteoarthritis is very common, a very challenging condition. We also suffer, patients also suffer, our grandparents, they also suffer, and commonly done procedures are intra-articular injection, whether you want to do PRP injections under image guidance so that you see the drug spread in all the 3 compartments, or injection of local anesthetic and corticosteroid, or injection of, you can do it under UAG guidance also, or high molecular weight viscosupplementation, genicular nerve block diagnostic, as well as radiofrequency ablation of the genicular nerve. Moving further up, shoulder pain, very common condition, either because of bursitis and periarthritis of shoulder. You can go for intra-articular injection of the PRP under UAG guidance or anatomical advanced guidance, better do under UAG guidance, and suprascapular nerve block, patient in sitting position, and you go to the different structures and go below the transverse scapular ligament into the suprascapular notch. Moving from musculoskeletal to the neuropathic component of the pain, trigeminal neuralgia, very common condition, and patients would invariably do well with the first line of treatment of carbamazepine or oxcarbamazepine, often combined with gabapentin and amitriptyline. If they are not responding, you go for radiofrequency ablation of the selected, whichever division is affected, either V2 or V3 or V1. Under fluoroscopic guidance, you can do a pooled RF, conventional RF, or a pulsed RF, depending upon your clinical practice. Complex renal pain syndrome patients with brachial plexus injury, they also come, they want that their upper limb should be amputated. No power is there, only pain is there. And we have got good experience of doing radiofrequency ablation of the brachial plexus with 50 to 60% pain relief under fluoroscopic guidance. For complex regional pain syndrome and the phantom pain, if they are not responding to the conservative treatment, you go for the upper limb, you go for split ganglion block, diagnostic block followed by radiofrequency ablation, and for lower limb, you go for the lumbar-sympathetic block. Diagnostic followed by radiofrequency. We are attached with the paraplegia center also in our institute, so lots of patients with spasticity also comes, and from pediatric cerebral palsy patients also come. So for that we have to go for USG guided and peripheral nerve stimulator guided operator nerve block, diagnostic followed by a neurolytic block. And regional cancer center is also attached to our institute. So we have lots of patients with cancer pain also, and we have to assess them that the pain can be because of chemotherapy or can be because of radiotherapy or the cancer itself, or post-operative patients. And nowadays this step-ladder pattern has changed, that you have to attack depending upon the patient's pain score. If pain score is 10, straight we go to step 4, and opioids, they form the cornerstone, morphine tablets. If the patient is not able to take orally, go for transdermal patches. And then for C pancreas, you go for celiac plexus block, an anterior approach by USG. We commonly use fluoroscope guided under prone position, and if patients having a radicular component, we go for epidural analgesia and keep the catheter in place. For CA breast upper limb pain, we have started doing suprascapular nerve block with fairly good results, and for upper malignancy of the throat and oropharynx, we go for glossopharyngeal nerve block, the extraoral approach. So these all are the current status which we are, the MIPSs which we are doing. There are advanced procedures also, I'll come to that. The other concerns are you have to take care of the for USG, you have to have PCP clearances also, and please do an ethical clinical practice. Never ever speak foul about your colleagues or surgeons. You have given previous MIPSs or operated patients priorly. Do not make hype of side effects or complications of others. Always support your colleagues, and yes, we always avoid unnecessary interventions. There may be revisits, very common in chronic pain. Have patience, don't get disappointed. Don't be too happy if patient is having pain, total pain score is gone down from 8 to 2, and don't be too sad if pain score is from 8 to 7 only. Just try to find out the pain generator, what we are missing, and target that. And right now where we are sitting is that there are patients and physicians and setups where they are doing dedicated pain clinics. I was talking to Dr. Devendra, running dedicated pain clinics, exclusive OPDs and consultations, and even teleconsultation is there. At times if it is required, there are multidisciplinary approach, and then there are near modalities, interventions, and pharmacotherapy. And RF has established now over the last couple of decades, and we've got lots of regenerative biomaterials and reactive oxygen species scavengers, nanomaterials coming up. Botox is now established procedures, and USG and fluoro-guided MIPSs have now become established and accepted by the patients, whether they are endoscopic spinal procedures, augmentation therapies, and neuromodulation. Radiofrequency we will be discussing over the next couple of days in detail, but yes, now with selective selection of the patients, it is an established procedures in lots of pain conditions, whether it is trigeminal neuralgia or whether it is genicular nerve block, or you want to go a medial branch block, and so forth. In regenerative medicines, PRB is now established, and its own protocols are there, and MSc is coming up. Patients are, the physicians are doing both injections, and there are some natural and synthetic polymers also coming up, hyaluronic acid, collagen, and the synthetic ones are polycaprolactone. They are being used more frequently now. And reactive oxygen species scavengers, it is a fairly new technique where scavenging nanomaterial facilitates the elimination of pro-inflammatory cytokines in reactive oxygen species in microglia and ameliorates the allodynia. USG now is in bread and butter for any pain physicians, and please do not feel cumbersome in getting the PCP-NITRI license. You have to go for it, you will get it. If there are some objections, you can always consult your seniors. They will guide you how to go for the PCP-NITRI license. Don't think that why we are to apply for the PCP-NITRI license. We have to have it, and that is the necessity as per the code of law. And endoscopic procedures, Dr. Pankaj is sitting here doing lots and lots day in and day out, and whether it is vertebroplasty and kyphoplasty, and the neuromodulation techniques, the transcranial magnetic stimulation and direct current stimulation, vagus nerve stimulations, spinal cord stimulators, DRG stimulation and peripheral nerve stimulation and DBS, they are all now done in selective indications. And pandemic has definitely helped in establishing telemedicine as another source, especially in patients for follow-up. So maybe when we are redesigning the health services, telemedicine would be another model of care with patients with chronic pain. So dear friends, pain control today means early intervention, functional enablement through pain alleviation, educating patients about pain management, as sir was saying, and minimizing the transition from acute to chronic pain. Now here we are, the burden of chronic pain in Indian scenario at given end point is around 19%. So imagine we are 140 CR population. At any given time, we are having more than 25 crore people who are suffering from chronic pain, and out of them most commonly is musculoskeletal pain. So the fear is that chronic pain might be a new epidemic if held cautiously. And for that, we require pain physicians. India needs lakhs and lakhs of pain physicians, whether they come from DM, whether they come from fellowships, whether they come from society fellowships, whether they come from private fellowships, whether they come from short courses, 6 months, 1 year, 3 months, 2 weeks. But India needs lakhs and lakhs of specialist pain physicians to cater to these patients and to develop pain medicine as a super specialty. And we are poised to take this role as the pain physicians. As I have told you, because we are well versed with the art and science of treating pain, and our role as pain physician is a natural extension of our professional work. And anesthesiologists as such are noble soul. So please focus that we have to fill this big gap so that patients who are not treated, they are treated, and those who are wrongly treated, they are properly managed. And the backbone of pain medicine is the pain physician. And we have to build a team across also. We should work with you from morning to evening, day and night with smiling faces to render the patients pain-free. So this is my pain team. The pictures which I have shown are not all my own. This is the work of whole of the pain team which works with me day in, day out for relieving the patients with chronic pain in the OPD, both boys and girls, just for not for any publicity, but just to show that yes, you can build your chronic pain practice. This is recent list. We had that 62 patients done in a day with 86 blocks. You have your own list like any other surgical specialty in our institute. We put all the names of our SRs and junior consultants there here and established each and every point the chronic pain medicine as a super specialty. So the list running into 4 pages. So this is the collective work of the pain team. We oftenly conduct live workshops on interventional pain management. Recently we did one at the ISPCCON-2023 at Gurugram, and this workshop was done at KGMU only. We had Anurag and other faculty coming from different parts of the country, Siddharth, Dhruv and others who were able to spare their valuable time and teach the patients on live workshop as well as cadaveric hands-on workshop. So dear friends, there are 3 mantras which everybody should follow in life and you will succeed like anything: honesty, sincerity and hard work. I conclude by saying, सामने हो मंजिल तो रास्ता ना मोड़ना, जो मन में हो ख्वाब उसको मत तोड़ना, हर कदम पे मिलेगी कामयाबी तुम्हें, बस सितारों को छूने के लिए कभी जमीन को न छोड़ना, कभी जमीन को न छोड़ना. Thank you very much. I hand it back to the audience.
Sir, please kindly take seat on stage. Thank you, sir, for your such kind words. Now, artificial intelligence is the talk of hour. So I invite Dr. D. Ashok Kumar, sir, Senior Faculty, Department of Pain Medicine, Government Multi-Speciality Hospital, Chennai, to elaborate the significance of artificial intelligence in pain medicine.
Can you close it? Come back. Close it and
Very good morning to everyone here. I'm Dr. Ashok. I'm very privileged to speak in front of a distinguished audience and the dignitaries on stage. So, my topic about the artificial intelligence, it's, to be honest, is very new to me also. So, it is about what I haven't experienced. It is all about searching in Google and whatever little information I can get from my senior colleagues and others in the field, not only in the field of medicine, in the technology field and others. So I will try to pass on what are the information I have to you. I think it will be useful, even though I would sincerely admit that it will be not only a tip of iceberg, maybe we are just licking the tip of iceberg. Okay. So going on to the artificial intelligence. So what is actually the definition? The father of artificial intelligence, Marvin Minsky would say that is a science of making machines do things that would require intelligence if done by men. So it's basically what it means. It is basically to have a machine think like human. That is very simple, to think like human, like analytical reasoning, take a logical decision and everything like that. So we have to make a humanoid. So there are three major subset of artificial intelligence. So the artificial intelligence encompasses that of machine learning and deep learning, and there are even more micro subsets in machine learning, deep learning, and artificial intelligence. But broader classification would be artificial intelligence, which encompasses the machine learning and deep learning. So when I'm trying to understand what artificial intelligence meant, or what is actually the machine learning, which is a subset of artificial intelligence, really means to us. So I just came to my mind, being a married person, just came to my mind, whenever we need to go for some party outside or something, we need to go as an individual. So we need to ask permission from a better off. So actually, during the initial days of my marriage, I used to ask for permission, but the usual answer would be that you can go wherever you want and you can do whatever you want. But that doesn't mean that it actually, the way it means, it may sound that way, but doesn't mean that way. So what is actually, this is what the previous algorithm was meant by. The algorithm is actually, they took the same contextual meaning, but the real meaning is different. So it means you are not supposed to go. So that is what the basic machine learning is all about. The machine learning is actually derives its knowledge from the data is given by whatever the reward or punishment it gets. So by reward and punishment, I used to I learned from that similar episodes that this is not the correct, this is not the permission. So we need to go for further manipulation and other things. So this is what the machine learning. So what is artificial intelligence? Over the time, we have managed, or we have tuned ourselves to even look into the various situation in the house. Entering the house, what is the situation in the house, whether the house is in kind of laughter or there is an eerie silence. So from that we need to, I came to understand that whether you need to open the topic or not. So that comes to the artificial intelligence. So machine learning is all about the rewards and punishment when the data is given as an input. Artificial intelligence, with the data that get collected over the past experience, it determines logical reasoning and analytical reasoning. It determines how to succeed or how to carry out your plan. So this is actually what I meant to say is, like an evolutionary in human evolution, that is how the artificial intelligence evolution is. So the algorithm, what is a simple algorithm? Maybe the first algorithm we have been all introduced is maybe the CPR algorithm. The CPR algorithm are the simple things that we need to follow. From this, if it is yes, then you go to that this branch. If it is no, you go to that branch. So it's a simple algorithm. It doesn't make any decision based on the past experience or no. So from that, the machine learning has come to the existence. So a machine learning is, as the common phrase goes in all technological field, data is wealth. So whenever the data is fed, the machine, it learns from the data and tries to implement. And it also tries to learn by itself, whether through the reward or punishment, it learns by itself whether how to do it successfully. So it is done without any human intervention. So as you know, the artificial intelligence is an extent of analytical reasoning and logical reasoning. So from the artificial intelligence, we have a basic thing, and now they are talking about the advanced artificial intelligence, and that may, I'm not very aware of that, but that may sound scary because whatever the article I have read is the advanced artificial intelligence may even, they say that they may even surpass our human brain. So what are these tools that the artificial intelligence use? Like what I can say is from the deep learning, you have a predictive analytics where analysis can be taken place, or we can have a text to speech or speak to text. This is mainly meant for extracting the data from the electronic records or the whatever the data we get from the patients, like video images or photographic images or something like that. And another one is that image recognition. That is what the CV is all about. That is the computer vision. The computer vision sees like our human eyes and it captures the images, but in very intricate details. So it means even it captures the very smaller amount of variation that takes place in the body posture, your facial images, and so on. So what is language processing? Language processing is more of extracting data for the electronic things like your text or something. So going from that, then you have planning and optimization, and it also leads to the robotics. So these are the subsets. So we have a lot of things that is being AI empowered or AI enabled in the field of medicine. But I thought, being a time constraint, I think I will go in detail. But one very important thing that we are all may use in very maybe in a recent, maybe we'll be going in very few years or so, is the autonomous pain assessment. So traditionally what you do, our pain assessment consists of taking history, clinical history, and seeing the patients and eliciting some tests. So these are, so what is autonomous pain assessment? The autonomous pain assessment basically means a system or a computer sees the patient without the help of the human being or a clinician, and itself it identifies some data sets points, and it gives us a diagnosis and a treatment plan and what kind of pain the patient is suffering from. So there are two broadly based behaviors. One is broadly based approaches. One is behavioral based and one is neurological assessment based. So behavioral based, you have a spontaneous facial behavior. As you will all know, whenever there is a pain, the patient usually brings the pain out in the form of facial grimaces and the contraction of the facial muscles. So there are a lot of tools which capture the, like what I said before, the computer vision captures that so intricate details of the facial muscles, and then it analytically reason out which kind of muscle is straining too much and what kind of pain that patient may be going through. So that is being done by that image classification and feature extraction tool. So what is there? Another thing is the body posture. Whenever there is a pain, the patient may crouch, or may lie in a prone position, or whichever is the comfortable position. So these are most of the times what the researchers say is that they try to bend their neck and they try to go in for a fetal position. So these kind of body posture are being studied and being evaluated, and these are converted into data set points, and these are fed into the computers for the computers to learn and relearn from the rewards and punishment. So another thing, as you all know, the respiratory derived elements like increase in respiratory rate and others. So what is neurophysiology based? As you all know, the EEG can be used, and as you know, there is whenever there is a pain, there is a lot of changes going on at the level of the brain, where it can be made out from the ECG, but it is more of done in a more research way. And we also have electromyography, as also there is a twitching of the muscles that we can make out. Electrodermal, where we can make out what is the skin temperature is, or what is the kind of sympathetic stimulation or the other sweat pattern that can be made out, and we have also biosignals. So these are whenever go for a behavior method, that there are the tools or the subsets of the AI that can be used here is we can say that here they use the conventional neural network. what the conventional neural network is a technology. What it does is, it develops an image classification model. What it simply means is, it develops a set of images and set of patterns that can be recognized by the computer itself, and say that this kind of grimaces or this kind of facial patterns correlates with this kind of pain. So this is the image classification. This model can be fed into for any research or even to our day-to-day practice. So this is only one type of notes, but we can have another that is CNN, the conventional neural network, where you have image analysis and spatiotemporal pain recognition. And one very commonly used thing is where the technology of CNN and RNN, recurrent neural network, can be used is they say that VGG face set data set. This is one of the most common data set that is being imbibed into the autonomous autonomous pain technology. So what is that? You also have the language processing, like from the clinical notes, the system can extract the whatever the points that we have written as a clinical notes about the pain. So these are also can be extracted, and these all can be fed. So a system can be fed with multiple data sets, like VGG face sets, like your extraction of your clinical notes, and everything. Everything can be integrated, and they will come out with an pain scoring or diagnosis about the pain. So this is the actually one of the tools that has been designed of the body posture. So there has been various actors posed various body postures to depict pain, and the 20 observers selected the most effective image which correlates with the pain. So after validation, a set of 144. These are all the things that goes into the making of an autonomous pain assessment system. So they have found out that head erected, gaze down, and forward were the common body postures. Okay. Then coming to the respiratory features, we have a lot of tools that extract the respiratory elements that correlate with the pain. So in the neurophysiologically based is better, what I said is the EEG is better suited for the experimental settings. Electrodermal is good sensitivity but poor specificity, and heart rate variability has got a poor reliability. So what I have told before, this is actually about the data set that has been used into making of an autonomous pain pain plan. So we have VGG face set, and we have BioVid heat pain database, and we have shoulder pain set. Why I am telling this, these are the only data set that has been fed into getting a good app for pain assessment, or evolving a new autonomous pain modality. So coming to that, what actually the advantage and disadvantages of using the facial expression and the language analysis sets. So facial expression is most commonly used. Why? Because it is consistent across ages, and even in a patient with dementia or an infant patient where they are non-communicative, they can correlate well with pain. But it involves a complex processing, like capturing the image, like processing the image, and then the processed image is fed into that already having data set and correlating the images with the data set and coming out with a pain assessment. Okay, the language analysis can be used for text extraction. This is also a highly complex procedure. So the tech at work is you have ML algorithms, support vector machines, decision trees, and these are the technical terms that they use to extract the data set points. So this is one of the studies that has been done. The AI pain recognition system is, you can see that more than 1 lakh facial images and 115 pain episodes and 115 non-pain episodes, and were fed into that system. And the system identify the patterns correlating with the pain, and we have heat maps to detect facial expressions also. So what is the result? It aligned with the results of 88% of the CPOT and VAS 66% at any point of time. Okay. So we have our own studies that has been done. What I've been talking is more of an American-based studies. So this is the one been done by the Indian Institute of Science. They have developed a model that's pain V, that is tracing the pain position of the nose over time in mice, which has been triggered with some thermal pain. So they studied that painful temperature, their machine algorithm, and studied that they came out with a pattern saying that by extracting the facial images, that we can make out what kind of pain that the mice may going through. So pain check is one of the things that is being also in current use. So there is it is like a smart camera which looks at the patient face, analyze the image like what I said with the previously fed data images, and it comes out to the pain assessment. So the pain check is actually it's a hem health, that is a medical health based solution that artificial intelligence to detect pain and intensity. So it is also actually been this has been the assessment has been done in infants also, where the pain assessment cannot be done in a conventional method. So it was found to be very good working in non-verbal candidates also. So it is also a regulatory cleared tool for assessing procedural pain in infants. So what AI-based interventions will finally give us is improve the brain recognition patterns. The prediction is very effective, but to say most of the studies are pilot studies. So they have done with an data which are not that comprehensive, and it has been done with a pilot studies, but hopefully we can get a larger studies in near future. So it is also another one of the drawback of this AI-based research is they are using a same database, like what I said, that 4 or 5 database that has been repeatedly used and repeatedly being researched. So I would say that the database might be an American model, but that doesn't suit our Indian subcontinent or for that matter for the European. So we need to have a data set, or we need to have a data that correlates or that has been taken from our continent or from our people. So what is the major thing that data-driven AI models can give us is we all conventional pain, it is always a subjective one, so it bypasses the limitations of the subjective pain evaluation. So that is all about the autonomous pain assessment, and few more things I can cover is that CBT, the cognitive behavioral therapy that is being done to reduce the opioid usage, that has been actually researched by the research in some American papers, and they say that they give the same results as the conventional CBT. The AI-driven CBT gives us the same results as CBT, but with the less clinician time, and the patients are more accessible, because in a conventional CBT there are a lot of over the phone or a telemedicine kind of thing is happening, and they need to go to a psychiatrist or a clinician to have a CBT therapy. But it reduces the clinician time. It also it is non-inferior to the outcomes of the conventional CPT, and effectively targeting the clinical resources like clinician time or waiting for the psychiatrist. So another one thing is that the ALML can identify the probability of severe pain. So whenever there is a severe pain, there are 3-4 things that the researchers do, like the higher body mass index, or a patient having previous pain, having previous opioid usage. So these data are taken from the these data points are taken from the previously fed data. So the AI-driven model predicts whether this patient will go in for a severe pain or this patient will go in for a chronic pain. So by AI-driven model, we can predict that which kind of patient can go into that, and we can effectively intervene for that patient so that they don't go for a chronic pain, or they don't go for a higher opioid usage or higher analgesic usage. So they have given 3 models, and they have succeeded by like 81% for the logical reasoning and random forest method, and 80% for the ANN. So they conclude that it is effectively working in predicting the predicting the pain score. So what is another research kind of thing that is happening in AAA is to even though we know the pain pathways are there is a lot of things that can be done to even kind of correctly have that pain pathway. So the AA enabled thing with the optogenetic technology, what it means is switching on the light stimulus, with an AA tools, they are trying to see what kind of neurons are getting excited. So by seeing what kind of neurons are excited, the research can be done to block that kind of neuron, that specific neurons at the brain level itself, so that the molecules can be developed which can be cut the pain at the specific neuron itself, so that we can have a lesser side effects. So in that way, the newer drugs can manipulate these neurons, and it is very useful for the study pathways to regulate pain. So the AA embedded drugs collectively it have a positive effect on pain management, reduce pain level, and reduce the usage of other interventions and assisting therapeutic days. Okay. So the chronic pain phase also can be treated. There is one app that is being developed by the Medical Motions app, which actually have an individual recommendation for the neuromuscular skeletal disease, what kind of exercise you have to do. This is like what we go to a physiotherapist, or what to go to a clinician to have that exercise. This is the AA powered that caters to the patient, like what kind of BMI the patient is having, what kind of the pathology the patient is having, or what kind of conditioning system that needs to be given to the patient. So these are all the AA can take it out from the data that is the patient data that is being given, and it can deliver. So one thing is the AA can dynamically adapt to changes. That is a very important thing, because even with the single even with that static data that can be provided, it can relearn from the patient experience. So this is one of the Knox care algorithm, where it actually generates the overdose risk for the opioids from the patient information, like prescription drugs monitoring program. That is what we have in countries abroad. So from that, it can generate whether this patient have some overdose problem, or the patient is having adequate pain relief. From that, it will generate a score. That score will help the clinician to tailor-made the opioid doses. So computational support system is actually facilitate the optimum physician utilization, recommending dose submission, aid decision making. Okay. So the pain prediction and clinical decision support can be also empowered by the AI. But the problem with that these kind of tools is that the bias includes many patients will have a different duration of pain treatment and different pain assessment tools. So only if there is a uniform pain assessment tool that will come, then these kind of clinical decision support AA can be we can trust it. Okay. So what is the problem? Okay. So just a problem about that. So what was the mechanics? Whatever is said and done, these are the things that has been told by that researcher or other things. So we have to directly believe. We don't know the mechanics that is behind the formulas, and they are not shared by the bias and accuracy. And government regulation can also be kept up with the rapid technology. Okay, it's so the updation of system has to be done. So to end with, I would say that once a new technology rolls over, if you are not part of the stream loader, you are part of the road. So I think this is one of the slide I have used it some 10 years back when 10 years or 7 years back when the USG was used in pain medicine. So I used to reiterate the point, and I thank the organizer for giving me the opportunity. And I also have 2 points one message to deliver, that we at the Tamil Nadu Multi Super Speciality Hospital, Omandura, Chennai, we are privileged to have 2 F&B courses, F&B pain medicine courses. Already 2 students have joined, we have achieved this with the support of our mentors. As Sir has already told, that's a platform that has been made, and we have been harnessing, and we have been harvesting that, reaping that fruit. So thank you, sir. Keep supporting us, and thank you very much, and thank you all.
Thank you, sir. Now I would like to call Dr. Pankaj sir to felicitate Dr. V.K. Mohan sir, Dr. Sarita Singh ma'am to felicitate Dr. Virendra Rastogi sir.
Sir.
Dr. Pankaj sir again to felicitate Dr. Naveen Malhotra sir, and Sarita ma'am to felicitate Dr. D. Ashok Kumar sir. We have such eminent personalities among us, brimming with knowledge. So I would like to invite Dr. Anurag Agarwal sir, Professor, Department of Anesthesiology, Lucknow, to start our first discussion on career opportunities for pain physician in India.
Good morning, everybody. First of all, a lot of thanks to all the delegates who have come from the different part of the world to attend this 6th National and 1st International Conference of Indian Society of Pain Physicians, ISPCCON at KGMU, World Famous Institute again of Lucknow, Uttar Pradesh, Bharat. And here, thanks to our faculties who have again travelled from far off places to enlighten us with the new and recent developments in the field of pain medicine. And lastly, a lot of thanks from all the sponsors for helping us organizing this conference, and a lot of thanks for the very, very hard work done by the organizing team of the ISPCCON-2023, led by Professor Sarita Singh, supported by Professor Shivani Rastogi ma'am of RML Institute, Dr. Sandeep Kuba, and dear Dr. Manish Singh as a co-organizing secretary, and the whole team for having this wonderful conference for the benefit of our not only the population but the future generation of the anesthesiology, so that they can pick a choice as a pain medicine, as a pain physician in their future career. So this is again, no branch can survive without thinking of the business part, without thinking of the economics part. So that is also important for our residents who are the newbies in the field of pain medicine, that how will they break into the system, how will they break and they will earn their livelihood from the field of pain medicine. So we have got a very eminent panel. One is a leader as an educator. He has been the Secretary General of Indian Society of Anesthesiologists, our mother branch, just in the recent past. He is also a very able educator and a motivator and a very competent pain physician who is having separate pain medicine block in the PGI-MER Rohtak. Professor Naveen Malhotra, I welcome you, sir, here. Second, we have someone who has actually broken the glass ceiling in the field of pain medicine as an entrepreneur. It sounds very new for all of us because most of us are having our anesthesia background where we do not invest, we do not dare to venture into the business part of the medicine. Dr. Sujit, please come over. And so Dr. Pankaj Surange, sir, अभी अरे बैठे sir, we need अभी please sir लोग, तो we need his idea. He has established not only a single hospital actually, he has opened a chain of pain medicine hospitals. Can you believe it? So let's have a big round of applause for him. He has shown us a path. I certainly believe that our residents, our future generation, all of us will be motivated by his ideas. Then we have Professor V.K. Mohan sir, our Honorable President of ISPC, Indian Society of Pain Clinicians, a very competent and an innovator pain physician at All India Institute of Medical Sciences, Delhi. Sir has been very kind in supporting and guiding us throughout our journey of pain medicine as well as in the organization of this conference. So welcome, sir. Then we have Dr. Sujit Gautam, who is again a very able pain physician, also a thinker, also an educator, and with the blessings of Professor Anil Agarwal, sir, he is now leading the team of pain medicine at SGPGI-MS Lucknow. So I welcome you all, and let's start with the first. This is an informal discussion. Please feel free to pitch in whenever you want. Dr. Sujit, what do you think that what are the things which can be added during fellowship and training, which may help in securing a job as a pain physician later for our students? And sir, I will request Mohan sir. After Sujit, please you also.
So, good morning everyone. I see it as a continuous.
Yes. Oh.
I see it as a continuous process that when a young mind of an MD student, like most of the students who are coming to the pain fellowships have done their MD or having a 1 or 2 year experience of senior residency. So when they are entering to a pain fellowship, they have in their mind that they are going to learn some new procedures in the few coming 1 or 2 years. It is something like that they have in their mind. So if we look at pain medicine as a specialty which is coming up, and the kind of patients they are going to deal is that they are going to be converted into the form of a clinician. So now from the background of an anesthesiologist, where they have got minimal patient interaction and also minimal interaction after the procedure. So this is kind of a transformation which we have to do in the process of 1 or 2 years, which we basically plan when these young minds are coming to us. For example, like sitting in a pain clinic, how they are going to talk to a patient, how they are going to explain the different clinical conditions to the patient, and when these patients are going to be planned for a procedure, what is going to be the outcome of the procedure, because when they are going to be out there in the field, what is going to matter is that how they are talking to their patients, how they are convincing to the patients that what is going to be their outcome, and when these patients are going to be posted for a procedure, what is going to be the outcome. These all things are going to matter a lot, because they are coming from a background where patient interaction is going to be minimal. Then smaller things like when the patient is going to be admitted in the ward, how they are going to put their basic notes on a daily basis, because all these things are going to be very important when things are not going to be in a very favorable manner. Then consent is a very important part. So these things may sound that these are very trivial issues, but all these things are going to matter a lot when this thing is going to be taken in a very holistic manner. Then comes the logistic issues, because our branch is something like that, where we have to arrange different instruments and different facilities which are available in the OT on our own. So those things like a C-arm, availability of a C-arm, availability of radio frequency generator, and ultrasound machine. So all these things, how they are going to arrange financial part for this thing. Then Dr. Mohan, you would like to add something?
So basically, Dr. Sujit, you are saying that a change of mindset is required from the supporting role to the main lead role, to think like a clinician. It is very important to understand by all of the future pain physicians. Sir, please.
Apart from Dr. Sujit, what I was said, and developing skills, proper education, proper patient care, one has to have a proper record keeping. They should know the record keeping is very important, apart from especially on medical aspects, and documentation is very important, and you should always convey the patient, and you should always ask the patient what is his or her expectation. That is very important. The patient interview and disseminating the proper information regarding your pain management or pain procedure, that is very important. One has to do this.
It's very important. I believe that what sir is trying to say, that in anesthesiology, that is perhaps the only branch of allopathic medicine where all-on-one phenomena works. But in pain medicine, there is no all-on-one phenomena. Your patient is not going to be 100% all right after 30 years of suffering. So this needs to be understood by a pain physician as well as the patient.
What I would like to add upon here is that we always tell our students, and our students are maintaining a beautiful logbook where they are maintaining a record of whatever kind of patients they are seeing during their training, whatever procedures they are performing, whether the procedures are being done at the level of the OPD as a daycare procedure or in the theater. So at the end of a 2 year, they have got this thick book of thick pages where they have a record of all the patients they have seen during their course and whatever procedures they have done.
That will help their career.
Exactly,
Yeah.
exactly.
Very good. Thank you. We'll shift to the next question. So this is for the Dr. Pankaj Surane. How to break in the private sector as a pain physician? You have been a long journey. Started as an anesthesiologist, then gradually shifted to pain physician. Now you are an entrepreneur. So we would certainly like to hear your story.
Okay, so when we talk about the private sector, I think we are talking about 3 areas. One is in a private colleges. That is one area where we can enter as a pain physician. Second is in a corporate hospitals, where we can enter again as a pain physician. And third, when you are practicing your own. So these are the 3 areas in the private sector where we can establish ourselves as a pain physician.
We would like you to focus on the private setups and corporate.
Corporates, okay. So when we talk about corporates, let's talk about the corporate hospital. So when we started practicing pain, we all started together 2006, 2008 onwards. 2010 to 2015, there was a lot of talks going on about pain medicine as a specialty is coming up as a specialty, but there was a resistance in the corporate setups. We also struggled a lot. We went to all the corporate hospitals in Delhi, NCR area, and we tried to establish ourselves as a pain physician, but nobody allowed us to enter as a pain specialist. Everywhere there was a request that, okay, you join as an anesthesiologist and you side by side you can do pain practice.
Does that work? That's two-way model work?
Yes. So in a corporate hospital or in a private setup also, this is not going to work.
It's not going to work.
It's not going to work.
It's not going to work. That is something to...
But for the youngsters, one thing what we have to, we must acknowledge this issue is that initially when the youngsters, when they enter into pain medicine, the practice is not that much. So during the initial phases, this is what we also did. Actually, most of us also did this, that we are practicing part-time anesthesiologist and part-time pain physician. But for that also, it is very important that don't keep it as a second alternative pain medicine. I'll give you my example, how I started. Because obviously that time when I started 2007, 2008, obviously you didn't need money also to run your home, right? So what I did was, I was doing 2 days anesthesia practice. Complete 2 days anesthesia practice. Rest 5 days I was doing no anesthesia at all, zero anesthesia. And focusing on the pain medicine only pain practice. Then when I started developing my practice, then I started doing night duties. I took night duties and daytime I kept myself free. So I was doing only night duties in a corporate hospital, and daytime all 7 days I was going to other places as a pain specialist. And then when in 2012, around 2012 when I established my practice, then I switched over completely, I left complete anesthesia practice and switched over completely into pain medicine. After that, since it's been 11-12 years now, I have not practiced anesthesia. So this switching over is really very important. We cannot do both together, especially with the anesthesia. It's very difficult because what patient expects from you is that your presence, your availability, that is more important. You have to have your time as a dedicated time as a pain specialist.
Small interjection, Dr. Pankaj here. Your story, our story, and all the grandfathering period story is slightly different because at that time there was no formal training was available. So we were all doing and learning. But now we are talking about the generation who is actually getting formal education in the form of PDCC, PDAF, DNB, FNB, and DM.
Yes, I'm coming to that. Yeah.
So
now with the availability of these opportunities what we have in a corporate setup.
Yes.
Now in a corporate setup, that is what I was telling, that till 2015 it was like that. You come as an anesthesiologist and spend you do the pain practice.
True.
But now in last 3-4 years especially, the corporate hospitals, they are taking pain specialists as a primary pain specialist. They are ready to open the pain departments. And the reason behind this, we know that in a corporate setup, they are seeing a good opportunity in terms of finance. They see there's a good financial things available with this pain medicine. Now most of the pain procedures are covered under insurance. So that is what is attracting the corporate hospitals to develop as a pain departments in the hospital setup.
So basically,
that is very good development which just happened in the last 3 to 4 years.
So you should be able to generate revenue. That is very important. That's the base of medicine.
Absolutely.
I would like to have a little word about this thing from Dr. Devendra, who is among with us. He is the first one who break into the corporate sector of Uttar Pradesh and Lucknow after being trained under Professor Anil Agarwal sir. So what has been your experience, Devendra? How did you start? What was your journey? Did you work as an anesthesiologist initially for a few time?
Sir, thank you, Dr. Anurag. I would like to thank all my teachers here, Dr. Anil, Dr. Rastogi, everyone. Just for the beginners, I don't think much of them are in this hall, but I would like to, just as Dr. Pankaj told, that he was doing his night duties and in the daytime he was practicing. So this is one of the options you can do, but now the things have changed.
No, Devendra, there is a slight interjection. Again, you were formally trained.
Yeah, I was formally trained.
We were not. So you were formally trained with an official degree in your hand. So
yeah.
What was like?
In Lucknow, that time in 2010 and 11, there was not much corporate sector organized. Only there was one Sahara hospital was there. So I initially went there, and I had 3 rounds of interviews. Even the anesthesia, our HOD who was heading our anesthesia department there, that time, he also didn't have much idea what you will do. So they asked me, what type of pain do you see and how do you treat? So I immediately came to know that they are also zero about the pain. So what they'll understand. So I gave them my logbook. Sir, there were 4 people there. The director was there. Our anesthesia HOD was there. I gave them my logbook, which was made at SGPGI. I told them that these are the procedures which we do. And you believe they have not heard about those procedures at all, most of them.
So you joined there as pain physician or as?
Yeah, then they told, you can come on the next day. First, we'll discuss what opportunities can we have for you. Then they called me next day. Then again, there was the same thing. They told I think they talked to Apollo people in Chennai. There, I think, there's pain clinic. So they told, some pain clinics have been opened in some corporate hospitals. So we are ready to take you. But if you practice anesthesiology, your amount will be this, X. And if you practice only pain, your amount will be X by 3.
X by 3?
X by 3.
1/3?
1/3.
Of the...
That time they told 1.8 lakhs for anesthesia plus pain and 60,000 for only anesthesia. Only pain, sorry.
Okay.
So I told, okay, 1 by 3 I am happy. So I left 1.8 and I joined at 60,000. And believe me, next 5 years, they gave me only 60,000 only. For next 5 years. But I didn't have grudge. I didn't have any grudge because my stipend at JCPJ was 40,000 only. So I gained 10,000. And I told this much is enough for me to survive in Lucknow because I have my home here. And I'll build up on this only.
So do you defend that decision or not?
No.
Working as
This is the only way to grow in pain. I tell you, this is the only way to grow in pain. If you think only of money initially, you won't grow in pain.
Great. That is a big lesson
Because
for all the
you
people.
have to just make your survival and wait for 5 years. It's intense opportunities have in this branch and you will definitely grow. Even if you don't get opportunity in any corporate hospital, you just open your simple clinic, put the list of things you want.
Dr. Pankaj is here, na? He started with a small clinic. Now he's having
then
a chain
also
of
it is
hospital.
feasible.
Please give us, Smita ma'am, she wants to add a few things.
Hello, good morning. Regarding this, I just want to add that in 5-6 years back only, a huge corporate hospital of 200 beds was inaugurated, and everyone had a dream that maybe, and this was by doctors, okay. And after 3 months, I got a call from cardiac surgeon who is one of the director. Madam, will you like to join? We want you as a pain physician. So this is the scenario now that they want us.
They want us. So there is a need. Actually, I will ask this question to Sir, Dr. Naveen Malhotra sir. Sir, what can be done to increase the रस्तोगी साहब अभी यहाँ थे, आप लोग ऑलरेडी बात कर चुके हैं इस बारे में कि actually there is a need in the society. People, corporate sector is looking for a trained pain physicians. So what else can be done? And how can we increase the number of production? Because there is a supply chain, then there is a demand. So demand is there, we need to increase the supply. So what can be done in your opinion?
I 100% agree with you. We are very, very short of the supply. The fact, the production, which we cannot change the nature, production is always from the medical colleges.
Through the medical colleges?
No, it is always
formal training.
MBBS students, they are produced from medical colleges. Postgraduates, they have to produce from the medical colleges. So, for that responsibility, if we the anesthesiologists are not taking up that responsibility, that means we are shying away from it. A day will come, if we don't take it, somebody else will take it. So, better we take it and fulfill it to the demand. There are two aspects to unlock. One, we are thinking that is demand. But the administrators, the bureaucrats and the politicians, they should also think that, and they should also realize that there is a demand.
So we have to rope them in.
So first step is always ensure that those who matter, the politicians, the bureaucrats and the administrators, they are made to sensitize that yes, people are suffering from chronic pain and inappropriate treatment or no treatment is being given. One. Second comes the courses. And we all are working that if first question comes to mind for any youngster is whether this is MCA recognized or not. So if there are certain courses which are MCA recognized, once pain medicine comes into the NMC curriculum, it will sooner or later, all the courses will get recognized. All the PDCCs, all the PDAs, or everything will get recognized. Only thing is right now, word pain medicine is indirectly into NMC because of FNP in pain medicine, because National Board of Examination in Medical Sciences is a part of NMC. So we are working, everybody is working together to ensure. Then they will recognize the Indian Society of Study of Pain, FIPM also, and other institutes fellowships also. Because मैं हिंदी में बोलूँगा, when I was a small child, पहली बारी पेट्रोल का रेट बढ़ा था ना, तो इतनी स्ट्राइक्स हुई थी कि ये 10 रुपए का पेट्रोल 15 रुपए कैसे हो गया. आज 100 रुपए हो गया, सब चुप बैठे हैं, किसी को फर्क नहीं पड़ता. Same way, I am telling you, it is the mindset at that level which we have changed, that pain medicine is a super specialty. Once it gets recognized, all the courses of all types will get some sort of recognition.
Sir, great, sir. So it's very important, the message I think that sir was giving, that we need to sensitize the authorities also. Talking about pain medicine interventions is good, but not enough to bring the government on board. डॉक्टर पंकज, थोड़ा सा बीच में रह गया, मैं आपसे थोड़ा सा बड़ा एक्साइटिंग सा पार्ट है जो आपने रिसेंटली चालू किया है. यू हैव बिकम एन एंटरप्रेन्योर पेन फिजिशियन ऑफ फर्स्ट आई बिलीव इन कंट्री, जो आपने खोला है. तो उसका थोड़ा सा आप बताओ कि आपने कैसे सोचा, हाउ डिड यू डेयर, यू आर हैविंग अ क्लिनिक, वी आर फ्रेंड्स, एक्चुअली वी आर फ्रेंड्स, क्लोज फ्रेंड्स. So I know that he was having a certain set of life with a good clinic, family responsibility. How dared to you took such a big leap of faith?
So one thing is that since we are thick into the pain medicine and we have been talking to the government agencies and the private sectors, so we knew that it is going to grow in a big way. So that is one of the reasons why
you believed it.
Yeah.
You believed in your craft.
Yeah. So basically, I was running a daycare center. Everybody, most of the people are running here the daycare centers, and they are really doing good because we have very good margins in the pain procedures. Now we are talking about liberal business language.
Okay. That's very important. This is what we want to listen.
So what we see is that in pain medicine, in pain interventions, we have very good margins. The margins which is going to give us a good high on other specialties. I just give you one example of Ayushman Bharat. We have this Ayushman Bharat. Since we have Ayushman Bharat in our hospital, so I'll give you one example. For spine fixation, the cost of the procedure, the total price of the procedure is 40,000.
Okay.
Endoscopy discectomy, what we do is 50,000.
Yeah.
Right? In Ayushman Bharat, if you go for the spine fixation, 40,000 plus 10,000 they are going for the implant only, which is 50,000. Endoscopy it is 50,000. What is your cost?
Yeah.
In endoscopy? Hardly anything.
Yeah.
For that, you have an implant. Nobody is ready to give implant less than 25,000.
True.
Right? So what you are earning? So this is what we have to tell all the corporates also whenever the youngsters, that we tell the youngsters, whenever you approach a private hospital, a corporate hospital, that we want to establish a pain department, you have to tell them in terms of these numbers. This is the margin what we are going to give you. Right?
The revenue potential of the pain medicine branch, you need to explain.
Not just the revenue, the margins.
The margins, yeah.
The margins are important.
Margins are.
So the moment you show them the margins, this is what your margins are. For pain procedures, your margin in a hospital setup is almost 60%.
Okay.
If you go for the same surgery, the margins are just 25%.
Okay. That is a use.
So what we did for this, when we approached insurance companies, we gave this comparative charts of multiple surgeries and what we can do as a pain specialist, and we have compared everything. So this is how we can approach the corporate setups. Now what you mentioned is that why I entered into the pain hospital. Because there was a need of insurance coverage. For that you have to have a hospital setup.
Okay.
Right? In a daycare setup, till now, it is not acceptable.
Okay.
So that is the main...
That was the requirement from the insurance companies also.
That was one of the major requirements why I switched over to from daycare setup to hospital setup. Second is our international patients. Now
okay.
what is happening?
International patient, medical tourism.
Medical tourism.
Very good, very important.
Now what is happening nowadays is that whenever they come from outside India for their medical treatment, they are given a visa that you will go directly to the hospital.
Okay.
You will not go anywhere, you will not stay anywhere else.
Okay.
You will go directly to the hospital and from here go back to the airport and you fly
back.
For that again you need a hospital setup. So we were losing a lot of our international patients because of this. So these are two main reasons why we switched over from daycare setup to the hospital setup.
Great. So,
and one thing, if I
yes, please.
mention you, we had to change the mindset also. We are as an anesthesiologist, we are totally dependent on the surgeons, right? Now you know what happened with the cardiology. All the cardiac surgeons are dependent on the cardiologist. Now this is the change we have introduced in IPSC. Now all the surgeons are dependent on us. We tell surgeons, you will do this surgery. This patient needs surgery and you will do this surgery only. So this kind of change is also required. Now they are dependent on us, on the pain physicians. We are not begging them for the intervention procedures.
So that is very important. Actually, this is the logo of Indian Society of Pain Clinicians. Pain physicians are the primary custodian of the chronic pain. So we are destined to become the primary custodian of the chronic painful conditions in the coming era.
Anurag, but we have been talking about entrepreneurship in corporate setup. But there is a big entrepreneurship in the government setup also.
Please, sir.
See, because the important is that again, you have to move out of the anesthesia department and do the pain medicine. And at times, the charges are totally nominal only. There are certain institutes, like your institute, where nominal charges are there. The institute where I come from is that everything is free of cost. Until unless you are in a private ward. The medications are also free of cost, but there is no procedure cost, only which is charges 5 rupees OPD card which is to be there. But doing these procedures day in and day out, what that has helped is, that has helped the private people to grow in the sense that these procedures became acceptable.
Yes, yes.
See, 15 years ago, THR and TKR were very, very few. But then all the orthopedicians started doing it. And it has now become an accepted norm that THR and TKR are safe procedures with good results. Same way, if we people sitting in the institutes do more number of procedures, day in and day out, it helps the indirectly because see, more number of people will get so they will say, okay, we can get these procedures done at the center near to our home, near to our city.
True. Sir, इसमें मेरा एक टेक है, हाल ही जो आपने बोला कि तुम्हारे पैसे हैं मेरे, Mike, when we are working in a corporate government setup, our rates has to be comparable to other specialties. That is my argument. It should not be cheaper, it should not be more. So हमारे यहाँ है क्योंकि हमारे सब ब्रांचेस के हैं. वहाँ पे अगर न्यूरो सर्जरी में डायसेक्टमी के 5,000 रुपए जमा होते हैं, तो हमारे यहाँ पेंडोस्कोपिक डायसेक्टमी के 5,000 जमा होते हैं. क्योंकि at the end of this, someone is going to look at the balance sheets कि पेन मेडिसिन ने कितना रेवेन्यू जनरेट किया in comparison to न्यूरो सर्जरी or orthopedics or any branch. So that has to be comparable. Now, a very important question, sir. Please. Yeah, please, Dr. Ashok. He wants to add something.
When you are talking about government sector, I am fully in a government sector. It's Tamil Nadu multi-speciality hospital, super specialty hospital, where even though everything is free, but it comes from the insurance. We have one thing called the CM's health insurance scheme, where we can claim for the patient is everything is done free, but with the help of that Aadhaar card and a few documents, we can claim the amount. So the whole system now runs on the claim made from the CM health insurance. So the bureaucrats and the politicians, what they try to see how much of cases being done on the health insurance, how much revenue you have generated. So I would say with a sense of pride that my department in the multi-specialty school, the only department, pain department that is earning revenue. So we have been generating revenue. So people, bureaucrats and everybody has been looking to a new department which has been earning revenue and which also gives us a sense of reputation and from the administrators. So in that way we are also generating revenue for the government sector, and we have been procuring a lot of infrastructure from the revenue generated. So that is why we are trying to be on par with whatever other departments are.
Great, that is very important actually. This is the same which is the Ayushman Bharat scheme. So we are also trying to bring all our interventions into the Ayushman Bharat so that we can do. We are already doing few interventions through the Ayushman Bharat, same CM scheme there. So sir, I would
like to add one point, is that we are in the budding phase of this specialty, and we should keep in our mind what cardiology like branches have been going through at this when they have almost reached to the level of the pinnacle, kind of criticism of the kind of procedures that they are doing. So when we are looking at the specialty of pain medicine, it should not be like we are just focusing on the kind of interventions that we have. It's kind of a clinical branch, and besides intervention, there has to be focus on a thing that we should take medical management exercises alongside. So I fully agree what Dr. Pankaj has said, that we should focus the kind of interventions and the variety of interventions on which we should focus. But message should not go to the young minds who are coming that this branch is only
all about the interventions.
It should be kind of a holistic approach, because sooner or later, after 10 years, when we would be doing too much of interventions, then suddenly a thought will come that are the whole of these interventions essential, or we can have a way where we can avoid the kind of...
True, absolutely.
I think everybody will agree, based on the clinical practice, that 70% of the patients do well without the minimally invasive pain and spine interventions. If you are saying 100 patients, 20 to 30 will require the blocks. But the problem is, some centers may be doing interventions is because those 70 would have already been seen by 10 other physicians who don't know the interventions. But I agree with Dr. Sujit, and all of us agree that the worldwide number of interventions rate is 20 to 30%.
Yeah, hardly. And even after doing a successful intervention like the vertebroplasty or vertebral augmentation, so it's not, your job is not over. You have to take care of the disease itself, which is the osteoporosis. So you need to know the whole treatment of osteoporosis also as well. I absolutely agree. Thank you.
Why don't we convince our patient to admit with us for a period of 1 week, where we are going to take care of their medications and the way of addressing their problems?
Certainly.
Because we don't heard like a 1 week program kind of an admission where patients could be admitted and different approaches could be told to the patient.
Certainly, there can be multiple ways to skin a cat. Sir, I am just coming back from my international conference at Dubai. That was of American Society of Pain and Neuroscience. So I met a lot of Indian diaspora there. Lot of people are there working in the anesthesiology field as well as in the pain medicine field. Some of them work from UK, US also, and other part of the world. So what, like we had a discussion, हमारी डिग्रीज की वहाँ कोई वैलिडिटी नहीं है. Start from the MD anesthesiology to MD MCH to anything. I am not worried about the MCH thing, but I am certainly worried about the MD anesthesiology as well as PDCC's DM courses, FNB's courses, all these. So what can be done? Because that is also important. If we want to become a supply chain of the qualified people throughout the world where there is a requirement. So our degree, and मजे की बात है कि सर पाकिस्तान की डिग्री वहाँ वैलिड है, बांग्लादेश की है. So I am asking you this question because you is the chairperson of ISA. So what can be done?
So we have been looking into this on a very, very serious note, because all the three neighboring countries except Nepal, Bangladesh, Sri Lanka, Pakistan, their degrees are recognized in UK.
Yes, UAE.
If it is recognized in UK, so all other countries they automatically get recognized. And see, the essential criteria which the Royal College wants, the inside story is that they want to validate the NMC curriculum.
Validate the NMC curriculum.
Yes.
Okay.
And that is a very difficult. You ask NMC people to submit their curriculum to RCOA to get it validated.
Okay.
And secondly, there, like Sri Lanka, I talked to the College of Physicians, College of Physicians of Anesthesiologists and Critical Care, just like this. So the exam is conducted by Royal College. They come and conduct the exam there.
Okay.
So their training is bit, you can say,
different.
Supervised. Simply supervised and managed by Royal College. So I don't think in near future with NMC it is possible. We can only think of having some other channels open by calling them. See, the best way is to talk to them. So we have been in touch with 3 major players: Royal College, Australian section, Australian New Zealand section, and the US section. So that we get involved with them, talk to each other, so that we can have some sort of arrangement where our qualifications are recognized there. Because these 3 bodies, they are in a very, very powerful role in policy making in their country. ISA is just now on the brink of entering into the policy making. I can tell you, because nobody listens to the association people in India except for IME. Only that is the association which is heard. But now, with combined efforts, our voice is being started to be heard. So I think it will take some years. But yes, nothing is difficult. But at present, I will be honest enough to confess, it's a long way to go.
You are from AIMS. क्या AIMS में इस बारे में कभी discussion होता है? Because AIMS हम सब जानते हैं कि
I don't think there is any discussion because scene is totally different from Pakistan, Bangladesh, and Sri Lanka. They are very small countries. They have very minor population, and they have very good exchange program among faculty and residents. Their residents go to UK, their faculty come. So that is totally different in our aspect, especially in
from
India.
the society side, sir. You are the president of ISPC. Can we send some representation to some places?
That has to be done by from NMC, government to government.
No, we can send the representation to NMC.
We can always request or represent the NMC or the government, other bodies like Health Ministry and all that. That has to be taken by especially IMA. IMA is the best body to do all these things. Isn't it, Dr. Malhotra?
कहाँ बताओ ना IMA की ये नहीं IMA के भी ये प्रेसिडेंट बनी है तो सुन रहे हो भाई कि सब लोग बता रहे हैं कि IMA ही सबसे ताकतवर बॉडी है तो अपनी डिग्रीज को अपने बच्चों के लिए हम लोगों को एफर्ट करने होंगे IMA को तो नेशनल बॉडी को आप सेंसिटाइज करो लखनऊ को करो लखनऊ के थ्रू तो शी हाँ प्लीज हाँ प्लीज यू हाँ यार मास्क माइक या प्लीज Please, Chinmay.
Actually, 10 years back, I also heard this thing that these degrees of Bangladesh, Sri Lanka, and Pakistan is acceptable but not ours. So, just from my side, I wrote to NHS that it is why it is like that. Then reply was nobody ever applied.
I want to clap because this is the same answer I received just 2 months back from someone in Dubai. कि भाई हमारे PDCC बच्चे PDF DM वालों को इनको तुम काहे नहीं ले रहे हो अपने यहाँ पे as a pain physician. So fortunately now one of us is there and he is looking after, he is the examiner of DHA. So he said to me कि बॉस किसे अप्लाई तो करवाओ किसी से अप्लाई कराओगे तो मैं उनकी डिग्री दिखा कर DHA से कहूँगा भाई ये भी एक पढ़ा लिखा बंदा है इसको ले सको. So that is also very true thing कि हमारे बंदे शायद अप्लाई नहीं करें उनको पता नहीं. But I have requested many people in Dubai boss, they are going to send a mail to ISA especially to get their degrees recognized. क्योंकि उससे सर फर्क पड़ रहा है.
Around Middle East is different, but I was referring to UK, US,
no,
and
I am
Australia.
talking about the Middle East. Sir.
Middle East will be easy to crack.
Yes.
Middle East is not an issue. Middle East is because many people who are going there, they are going at this. Suppose they are consultant here, they are being taken as consultant there. I was
Where? In Middle East?
In Middle East, yes.
No sir, no, it doesn't happen. मैं बता देता हूँ वहाँ पर टायर सिस्टम है. So even if they make you consultant, you will be tier 2 consultant, getting half of the salary of the tier 1 consultant. So someone who is coming through the UK, even if he is an Indian, he is in tier 1. So that again makes a lot of difference. So उसके लिए हमको थोड़ा effort का जरूरत रहेगा. तो आपका blessings हम लोगों को चाहिएगा. मैम कुछ कहना चाहती थी हाँ.
In UK, few people are working after doing MD here in all the branches, including anesthesia.
After the exam, man. After they are passing out exam and... Madam, equivalence. What Anurag's question was, equivalence of MD, you straight away go there and practice. You don't have to get in.
But they get the jobs. Like
मैम वो वैसा वाला है लोकम वगैरह है वो एक्चुअली वाला नहीं. हाँ कुछ तन्मय wants to add something.
So what I think sir, the duration of the MD course हमारी जो है वो 3 साल की है.
वहाँ 6 to 7
और
years.
वहाँ पे 6 to 7 years होता है. तो वो जो duration जब तक हम लोग अपनी नहीं बढ़ाएंगे तब तक हम लोग की डिग्री को वहाँ.
Actually, yes, that's a very important question. This question was discussed on stage in Gurugram because Mr. Vijay Ojha was the postgraduate medical education president. Right now, India is not prepared to increase because they want more number of anesthesiologists, rather more number of physicians of all the specialties catering to the population. So at present, they think that increasing MD from 3 to 6 years is practically not possible. But Tanmay raised a very valid point. Tanmay, please continue.
Yes.
So the only problem is जब तक हम लोग का 6 years course का duration जैसे MCH वाला आपका 6 years course हो रहा है MS MCH वैसे हम लोग अपनी anesthesia में जब तक नहीं लाएंगे सर तब तक हम लोग ये
इंटीग्रेटेड कोर्सेज
इंटीग्रेटेड कोर्सेज
ठीक है
So
तो
is in Nepal and sorry is in Sri Lanka and Pakistan and Bangladesh. It is 6 years course.
I don't think so.
I don't think so. Maybe it is a comprehensive course.
No, it is 6 years.
Pakistan it is a 4-year course. Even Sri Lankan residency is also equally lengthy.
So I think.
So Devendra, I'm coming back to the thing.
SRship also.
Yeah. So these were the basic points for the career opportunities. मैं with due regards to everybody, मैं एक बड़ा ही छोटा सा क्वेश्चन पूछना चाहता हूँ. Suppose I have done a DM or FNB, pain medicine, and now I am going to apply to a corporate sector, say ABC hospital. Whom should I go and meet there? Should I go and meet the HR people? Should I go and meet the HOD anesthesiology over there? Or whom? ये बड़ा छोटा सा मेरा मासूम सा सवाल है, कोई अगर जवाब देना चाहे तो. Yes. हाँ. हैं? Anesthesiology HOD से नहीं मिलना है. मदर ब्रांच हमारे. तो वो
meet the whoever is financial controller of the hospital. And I agree with the Dr. Pankaj. When you give the business vision, how we can contribute, there are lots of patients who are catering in all the specialties and still they are suffering. So we are the gateway to those patients and this is the financials.
Okay. So, yes, ma'am, please.
See, this is in 2004. When I started working as pain physician, and actually in spite of having a very good anesthesia practice, I decided to switch over. So when I went to Jahangir Hospital, I did not go to the anesthesia. The anesthesia person said, yes, you come here, I'll help you, you will be in my department. So I went Dr. A.K. Bharucha, who was that time medical director, and I told him pain has nothing to do with anesthesiology right now, but I want my own thing. So I was one of the first ones who got appointment as a pain physician, and I was the top and the bottom. They said I was HOD, but I was also the also of my department.
House surgeon to HOD. House surgeon to HOD.
Secondly, everything I was, same thing I did in Sassoon Hospital in 2015 when we wanted to start the certificate course through MUHS. MUHS is our nodal university for all Maharashtra people. That time also I did the same thing, and that was again, my appointment was the first one. It was Dr. Madhuri Lokapur, assistant professor, pain clinic. Because I said I will not be attached to anesthesia department.
So the time has come for the.
Given me duties to that. So actually I had sent it to Dr. Rastogi, was very impressed that time because he said this is the first appointment in India. Because, so that is the only way to do it.
So the time perhaps has come to cut the umbilical cord. So the message for all the newbies in the future of the pain medicine, that dare to dream and they can come true. Thank you for the panelists and thank you for the very animated discussion to all the audience, and thank you the organizing team Sarita ma'am once again. और IMA की जिम्मेदारी आपको बतानी है.
Thank you everyone for such an insightful discussion. I would like to ask Dr. Anurag Agarwal sir to facilitate, Dr. Naveen Malhotra sir, Dr. Pankaj Solanki sir, Dr. V.K. Mohan sir, and Dr. Sujit Gautam sir.
जोधपुरी कोट पहन के आए, इधर खड़ा हो हाथ लगा भाई. बहुत मजा है. हाँ, एक ग्रुप फोटोग्राफ. अच्छा मुझे देना वाले. अच्छा अभी दे देना, पहले फोटो खींच ले. आ जाएगा.
Now I would like to ask Dr. Manish sir to felicitate Dr. Anurag Agarwal sir.
Thank you.
start our next session, that is chronic pain, a global issue. For this, I would like to call our chairperson, Dr. Viren Rastogi sir and Dr. Anil Agarwal sir. For our next session, I would like to invite Dr. Viren Rastogi sir and Dr. Anil Agarwal sir. Sir, please come on the stage.
Hello, good morning. So now we continue with the proceedings, and I would like to invite Dr. Madhuri Lokapur, and should be talking about need to be managed differently. That is regarding cancer pain, one of the important areas of pain management. As you all must be knowing that Dr. Madhuri is consultant pain management and palliative care. She is affiliated with Lokapur Hospital, Jahangir Hospital in Pune, and MJM Hospital Pune and Ruby Hall Clinic Pune. Her achievements are: she is President of Indian Society of Study of Pain in 2020-21, Founder, President and Trustee, Society of Study of Pain Pune, and faculty of national and international conferences and CMEs. She has publications to her credit. She is an author of Handbook of Pain Management and Palliative Care and many other publications in various journals and media. Her areas of interest are pain management and education. Hand over to Dr.
At the outset, I would like to thank the organizers, Dr. Sarita Singh, for inviting me for this prestigious conference, and I'm really delighted to have Dr. Rastogi sir and Agarwal sir here, because you were quite instrumental in me coming to the pain and starting my journey of pain management. So this today's topic basically is not to discuss how we should treat a cancer pain patient in depth, but this was just Dr. Sarita wanted to have something different. Like sometimes we have different cases, and in that case, how an individual would manage such cases. So that is something what we are going to discuss today. So what different things can be done? So as we all know that about 80% of the cancer pain patients, they can be treated with the three-step analgesic ladder, which has non-opioid and adjuvants at the first stage, then adding a mild opiate to the second stage, and having more powerful analgesics like morphine, fentanyl in the third stage. By mouth, by the clock, by the ladder, if we go systematically, you should be able to cater to most of the needs of the patient. And for the individual, because every individual responds in a different way. I have put across one of the cases where this individuality really comes into picture. Adjuvant drugs and attention to details, of course. It is essential to monitor the patient's response to the treatment, and that's how you will be able to catch people who are not falling into the regular algorithm and they require something different that needs to be done. As pain physicians, we can add interventional procedures or MIPSI as what we are calling in our parlance at any of these stages wherever required. So there is this case one of a 65-year-old gentleman who was a known case of CA prostate with metastasis. This patient had continuous complaint about diffuse pain in abdomen and pelvic region. Patient was receiving tablet morphine 20 mg 4 times a day, buscopan 10 mg SOS, NSAIDs, paracetamol, and of course lactulose, metoclopramide to take care of supportive treatment. However, the patient still kept on complaining of pain, and the VAS score was almost 7 on 10 in spite of all this treatment which was going on. And whenever they tried to give him SOS morphine tablet, the nausea and vomiting really made the patient very miserable. So he was referred for sympathy to our pain clinic. The patient underwent superior hypogastric plexus block. One of the take-home messages here is that I do all my sympathetic blocks under CT scan guidance because mostly these are all advanced cancer stages, and whenever I do a pilot scan, I get an idea whether my block is possible or not, how it is going to work, and the exact location. Because your bony landmarks never match the soft tissues in case of advanced cancers. So superior hypogastric plexus block was done, and we tried to keep the pain in the lower part of the abdomen. Patient complained later on that the lower abdominal pain had very much gone, but however he still continued to have upper abdominal pain, which was quite bothersome. We waited for another few weeks, a couple of weeks, to see how the action was coming up, and then we decided to go for additional celiac plexus block. So again, CT-guided celiac plexus block was given to this patient, and then patient was very happy. He said he has almost 70% reduction in overall pain, and the dose of morphine was also reduced to 10 milligrams 4 times a day, of course along with all other supportive adjuvants and analgesics, and there was drastic improvement in nausea and vomiting in this patient. So what exactly worked here? I had referred to number of presentations where I found that the multiplexus blockade sometimes is more effective in patients with this diffuse kind of a tumor burden. So there are multiple papers available, and in this patient, giving both the blocks together really worked. Because we always have these anatomical barriers in our mind that, okay, if it is upper abdominal, you go for celiac. If it is the lower abdominal, you go for superior hypogastric. If it is adrenal, then you will go for ganglion impart. So in some patient, giving multiple blocks, of course serially, is definitely going to work. So what worked was combined celiac plexus and SHP. So do keep in mind that maybe one intervention may not be enough, and of course these patients are going to be rare. Most of the time you will get very good response with conservative management plus one of the MIPSIs. I again had another case where there was a 60-year-old lady who had cervical cancer, again with metastasis, and she was brought to the emergency by the relatives. Now, usually patients coming to me are all chronic cancer pain patients who come to my OPD, and then we start with the treatment. Here, I got a call in the emergency department. The lady had been put on tablet morphine 10 milligram 4 hourly 1 day before for severe pain in lower abdomen and back. After NSAIDs and tramadols failed to give relief. having hallucinations as per the reports of the relatives. On asking her for the history, I found out that tramadol had been tried only for 2 days, but because the patient was really miserable, kept demanding analgesia, a palliative person had given this morphine, QID, and tried to give her relief. So initially, patient developed drowsiness, she had nausea, vomiting, and then she started having irrelevant talk and hallucinations. The initial patient's relatives were really very concerned and scared, and they got her to the emergency. So initially it revealed that she had meiosis, the patient was gazing vacantly, talking irrelevantly. However, cardiovascular and other parameters were within normal limits. The recent blood investigations which had also been done just before all this, they showed that she was anemic, she had slightly raised RFTs with urea and creatinine which had been raised. So we put the patient in high dependency unit under full monitoring. She was treated with midazolam IV with phenargan 12.5 milligram, and then she was put, for her delirium kind of a state, she was put on haloperidol low infusion drip of 5 milligram over 24 hours. IV paracetamol was advised 3 times a day with SOS tramadol because we wanted to wash out the load of morphine from her system. Slowly the patient improved, and in 48 hours we saw considerable improvement in all the cognitive functions. She was shifted to the ward, and then the pain also started coming back, and we put her on fentanyl topical patch. Upon discharge, the patient was quite satisfied with the treatment, and we could discharge her with her sensorium back to normal. What we learned from this case was, we are all very familiar with tablet morphine, and we have been advising it pretty regularly to all our patients. And normally they tolerate it pretty well, except for, say, like more symptoms would be nausea, vomiting, constipation. That is something what we expect. But this kind of delirium and hallucination is something which we see very rarely. We have to bear in mind that there is an inter-individual variability in the response to different opioids. So each patient is a different one. Careful evaluation should differentiate between morphine-induced adverse effects from comorbidities, because hyponatremia and uremia or RFTs or even dehydration, all these things, they can have similar kind of episode. So we have to make sure that these are not comorbidities, but solely you can assign it to the opiate. Symptomatic management of the adverse effect using neuroleptics such as haloperidol or benzodiazepine as midazolam is treatment for this patient. However, we have to make sure about the dosage. You must have seen that the dosages which we used initially were kept pretty low, because as it is, morphine can induce respiratory depression. On top of it, if you are giving benzodiazepines, you have to be very, very sure. So make sure that these patients should be kept under some kind of a monitoring, like a high dependency unit. Secondly, switching the route of administration. This has been known to give some kind of a relief. So in IV patient is receiving IV, tri-oral or tri-topical. Opioid switching from morphine to fentanyl or methadone, in this case, decreases the polypharmacy, and even changing the opioid itself might give relief from the symptoms to this patient. Chowdhury et al., they have got a very good paper on this particular condition. One thing I would also like to mention here is that whenever I see some out of ordinary cases, I like to go back. So you should always try to do remedies which have got some kind of record to it and which are always mentioned and which will be guideline based. This is a pretty straightforward case. I'm just mentioning it here because this was a 55-year-old gentleman with CA lung and metastasis in D7 and D11. He had completed his chemo and radiation therapy and came to us for pain and palliative care. The pain was quite well controlled on tramadol and paracetamol combination tablets 3 times a day. And in the past history, patient had history of being a chain smoker and hypertension which was controlled on Telma 40. Suddenly, in a few days, patient started having complaints of low back pain with radicular pain going down into the left lower extremity. There was occasional tingling and numbness, no loss of control over bowel and bladder. He was already a cancer patient, so some nighttime pain was expected. On examination, we found all the tests positive for radicular pain. SLR was positive, heel and toe was not possible to this thing. ROM we could not check completely because of pain. Now, knowing his history, we decided to go ahead with an MRI of the lumbosacral spine, in which we found a prolapsed intervertebral disc. However, we did not find any evidence of cancer spread or metastasis. So, epidural steroid injection MIPSI was done, and patient had excellent pain relief. He was also started on pregabalin and vitamin supplementation, and he continued to have his tramadol paracetamol combination. So here what I would like to mention is that what worked was that patient needs a reassessment all the time, because every pain that individual is going to suffer does not have to do with his original cancer complaint. I mean, it is a degenerative condition, so like anybody else in that population, he can have some pain complaint which is totally divorced from his cancer. So that is one of the major things that you have to keep in mind, that don't try to connect the dots all the time and individually examine the patient, because the cause may have nothing to do with cancer. Lastly, we had this very interesting case where there was this 40-year-old lady, known case of CA breast with extensive metastasis. She had already undertaken all sorts of curative therapy like chemo, radiation, surgery had also been done before. And they had decided not to pursue this, any of these curative methods, and she had come to us for pain and palliative care management. On examination, she did not have any comorbidities, the vitals were stable. Patient, however, was very sullen. She was impolite, like an angry kind of an individual, and very demanding. I mean, she kept our staff running around all the time. Whenever we asked her about the VAS score, she said it was 10 on 10, and like she was put on morphine 4 times a day, she was on paracetamol, diclofenac, but whenever you asked her how much is the pain, she said no difference, there is no difference, I am getting pain. Morphine dose was titrated to 30 milligram slow-acting tablet twice a day for over the next few days. Again, you ask the patient, there is no response, there was something wrong with the staff, there was something wrong with her treatment. Patient was very angry, and actually she got abusive on a couple of occasions. Initially also we had suggested counseling, but their relatives were not in a frame of mind to do that. However, now that we realize that increasing the dosage, even if we asked her if there is any percentage of relief, the patient kept denying that and said she was just miserable, unhappy. Especially when the husband was around, she would be really inconsolable. We finally had a meeting with her relatives, and we sat them down and we explained that they had to consider the counseling, because that was what we felt, that the patient needed something more than what we were offering her by way of pharmacological treatment. Counseling sessions, when they once started, we were very happy to see that the patient was settled in a more comfortable zone. Many issues like fear of death, worry about her family, especially her children, frustration, and about that why me kind of anger issues, they were addressed. And antidepressants were also titrated as per the psychiatrist consultation. Her sleep got regularized, and we found that the patient settled down very comfortably on the same conservative treatment which we were giving her earlier, and no further escalation of analgesics was required. By the time she was discharged, family and patient were both glad of the outcome. So one concept all the pain physicians need to keep in mind is that we are all very happy when we can give some kind of interventional treatment. We are also very comfortable with conservative pharmacological management. However, in cancer pain, there is a concept of total pain, which will be characterized by various dimensions like physical, social, psychological, and spiritual. So unless we address all that, patients may not get a complete relief. So we have to look beyond the physical pain and check if the patient has got any psychological, social, or spiritual issues. And once they are all addressed, patient will definitely be a very, very happy person. I'm completing right on dot, sir. I just want to mention here that winners don't do different things. They just do things differently. This was said by Shiv Khera. I would like to give the same advice to all the pain physicians, especially the budding ones, that we all have the same armamentarium of medicines and various procedures. It is just that we have to tailor it to that patient and give a proper treatment. Thank you very much. I would also like to take this opportunity to inviting everybody for our national conference, ISPCON-2023, taking place in Pune in the first week of February. So please join us and let's continue to have the feast spilling over in February as well. Thank you.
Thank you, ma'am, for the excellent presentation and timely finish as well. I have some queries regarding, it was interesting presentation and case one. You have pointed out a very important area, like simultaneously we can give two blocks and they will be helpful. My only concern was regarding safety of these blocks and timing of these blocks. So what and how to proceed about it?
About the safety of the block, that is why I said that all my blocks I always do under CT guidance. So I know exactly where my needle is and where my drug is tracking also, because the normal anatomy is not there in cancer patient. So safety wise I am not worried about it at all. I first put the dye in and only after checking that I would put my neurolytic solution. As for the timing, sir, it depends symptom based, because the patient was very miserable, because even though the lower abdominal pain was very much controlled, the upper abdominal pain was bothering him a lot. So we waited for 2 weeks for that entire neurolytic process to get completed. After that, when patient was still miserable, we went in. So I don't think there is any formula for how long you should wait. It will be symptom based.
One query I have just one, that you said about that secondary metastasis recently another. So do you try that disponates and IV acid, but they didn't respond to it?
No, sir. Because all these patients who have got osteoclastic lesions, we are always giving them bisphosphonate. Zoledronate IV 4 milligram every month we are giving them. And also the Miacalcid nasal spray and calcium, all these.
Do they respond to that treatment?
So, yeah. And that I said 80% of the patients, they all respond to it. It is only these rare patients where you have to think out of box. And those are the cases I presented to you.
I think we have also shown one patient who has got the PID also, because at that time, most of the time we forget that this patient is having cancer, but they can have other disease also. They can also have osteoarthritis, they can low back pain, and that's rightly pointed out that this patient was having neuropathic pain, that too idiopathic. And these are the patients which will not respond to morphine therapy, they are opiate resistant. But even you have to be a higher dose, maybe up to 1 gram, they will not respond. And that's why we should look that there is some other pathologies there and try. That's a very good message we should go to the audience. Any question from the audience? Any queries?
Another, there was case 2. In case 2, we had given morphine to this patient and patient had morphine-related side effects. So my concern was that this patient was not started on paracetamol and tramadol earlier or either along with morphine, starting morphine. Should we have started with paracetamol? First thing to start would have been better if we would have started with paracetamol.
In palliative So for
Without
all
insurance.
practices, patient must have been opioid naive only, na sir. So that's why she landed up with this. So the take-home message is that we have to have some patience, regardless of how much patient is crying. We have to go in a systemic manner. But that's what I found.
Thank you. Any queries or comments from the audience? If no, we'll proceed. Organizers are pushing us. Thank you.
Thank you.
The next speaker, speaker will be, and he will be speaking on a when a patient comes to you, cervical neck pain, Dr. Nana Deem Okay. He is a consultant spine and pain physician, Nanavati Max Hospital, Mumbai, Fortis Raheja Hospital, Mumbai, Director of Morkani Pain Clinic, Mumbai. He is also Deputy Registrar IAPM currently, Secretary ISSP Mumbai City Branch, Fellowship of Indian Society for Study of Pain, invited faculty for many conferences and workshops, contributed a chapter in the textbook of pain management. I invite Dr. Nana Moke for the presentation.
Good morning. Thank you, organizing team, for inviting me. I'm going to talk on when patient walks in with a neck pain. I'm going to generally discuss how we should assess the patient, what history we should take, and how we reach a proper diagnosis so that we can be treated properly. As we know, neck pain is a very common presenting symptom in primary care with an incidence of around 10.4 to 21.3 per year. It is the fourth leading cause of disability worldwide. The prevalence of neck pain is higher in older adults because of the degenerative changes and local facet joints as well as endovertebral disc issues. It is estimated that 1 in 5 people with neck pain seeks a medical care. It is important to recognize the pain signals that will potentially take us or think about serious conditions. That is called the red flags. How to this one? So we have to always think about the red flags when patient comes with a neck pain, like traumatic injuries like fracture, cord compression, myelopathy, infection when patient is having fever, malaise or rigidity, malignancy, and cervical myelopathy, as well as vascular emergencies. So we should always think about all these things when patient comes to you. That's why accurate patient history is very critical in the for the appropriate diagnosis and management of these conditions. And this can be confirmed with physical examination and diagnostic and other laboratory testings. So obtaining accurate clinical history is very critical. Acute versus chronic and neuropathic versus non-neuropathic symptoms can help us to determine where the So one study showed that only 43% of neck pain cases are non-neuropathic, and only 77% are neuropathic, and 43% are non-neuropathic, and 50% are mixed. So while taking history, location of pain is very important, where the pain is coming from. So it helps to know us underlying pain generator. So pain generators are the important thing. So if you find the pain generator, it's very easy for us to target those pain generators and treat the patient. So the pain generators and muscles and joints are localized. Nerve root pain generator, nerve root compression, it will show a dermatomal distribution pattern. Axial pain is generally due to the IDD or facet joint pain. Myofascial can be, again, depending on which muscle is involved, it can be paraspinal, paramedian, or it can be referred. Then when patient is having a widespread pain, that can be a fibromyalgia, RA, or SLE. Infections and neoplasms are generally axial pain. So we have to see where the pain is coming from, and then we can think about further symptoms and easy to diagnose. Then duration and character of the pain is also very important. When there is acute pain, it can be due to trauma, infection, disc prolapse, muscular dissection. It should be aggressively investigated and treated. More gradual onset of pain is due to progressive degenerative or inflammatory or neoplastic process. Musculoskeletal pain will be deep aching or deep throbbing pain. The neuropathic pain will be sharp shooting, electric shock-like pain with a tingling numbness. Facet joint and vertebral pain will be, there will be stiffness and it will be localized, more localized. If there is a hypoaresthesia and allodynia, that will take us to the thinking about CRPS. And then, which are the aggravating relieving factors we should know. So, if facet joint pain is there, it will be aggravated by neck extension, lateral flexion, rotation. Atlanto-occipital joint arthritis will be aggravated by flexion extension. Atlanto-axial joint arthritis will be worsened by rotation, lateral rotation. Discogenic pain again will be increased with the forward flexion. Myofascial pain will be aggravated by the muscle stretch or deep palpation. Then radicular pain will be relieved by the arm abducted and externally rotated overhead. So, if by taking proper history, we can easily come to a proper, at least two, three important diagnosis, differential diagnosis, so that it can be diagnosed properly. And chronic inflammatory pain again will be increased after a period of inactivity and it will be improved with exercises. So, then if there are associated symptoms, that also help us to diagnose the patient, like morning stiffness, polyarthritis, rigidity is there, then it will think about inflammatory arthropathy or rheumatoid arthritis. Ankylosing spondylitis will have an entire axial involvement. Lumbar motion limitation will be in the beginning and then will be followed by cervical. Then fever and night pain will make us think about the infection. Dyspnea also can be a part of the symptom which can be related to the C35 innervation of diaphragm. Occupational history is very important because if, for example, if patients are doing a job like which need a hyperextension of a neck, they are prone for occipital neuralgia and cervical pain. Then rapidly progressive neuropathic symptoms warrant more aggressive evaluation. Injury to the central spinal cord and nerve roots may be the result of degenerative changes, trauma, mass effect, infection, other inflammatory or demyelinating conditions. Even without an acute presentation, we should be mindful of the myelopathic signs and symptoms. So, what is myelopathy? It refers to neurological compromise resulting from a disturbance of spinal cord tracts within the spinal canal. So, initial symptoms of myelopathy will include a deep aching pain with the possible radicular symptoms and muscle weakness. This can quickly progress to the gait changes, ataxia, bowel and bladder dysfunction. So, physical examination will show us increased muscular tone, fasciculations, clonus, hyperreflexia. There can be concurrent symptoms like fever, fatigue, rash that should make us think about infectious etiology. There can be neck stiffness, photophobia, other neuropathic findings will raise the concerns of meningitis or epidural abscess or discitis. If there is a weight loss, significant lymphadenopathy, fatigue, this signals malignancy or underlying other inflammatory condition. So there can be other comorbid conditions like herpes zoster, angina, endocrine compressive tumors, fibromyalgia, psychogenic pain. All this will again increase the risk of this cervical painful conditions. When the history is done, we can come to 2-3 differential diagnoses, or maybe we can just come to 1 or 2 differential diagnoses, and then we can do a physical examination to confirm or take us more towards narrowing our diagnosis. So physical examination should target concerns within the history and distinguish between mechanical and neuropathic symptoms. Localized bony tenderness or prominence is an indication for Range of motion can be more useful in identifying asymmetry or provocation of local radiating symptoms. Clinical examination starts when patient walks in. Okay, gait, you should see the gait, Trendelenburg gait or bilateral spastic ataxic gait in myelopathy. Skin can look for herpes, vascular scarring, inflammatory signs of local pathologies. And head and neck position is also very important, like loss of lordosis will show us muscle spasm. There can be underlying pathology to cause this muscle spasm or torticollis. In torticollis, neck is always turned to the opposite side of the pathology. Then we should look for muscle wasting in case of myelopathy, brachial plexopathy. Palpation will show if it is a local tenderness is there, trigger points are there. You can press on the facet joints to elicit facet joint pain. Occipital neuralgia also can be elicited by some types of palpation of at the knuckle line. Then range of motion is affected in arthritis, atlantoaxial joint issues, stiffness. So we should see all these things should be examined properly. Then there are some special tests to see for specific conditions, like Sperling maneuver will tell us about the radicular pain. If it's positive, it is a diagnostic of radicular pain. Shoulder abduction relief sign is reduction of these radicular symptoms. Neck distraction test is there. Again, it will be radicular symptoms should be reduced. Pulsar watt test will increase the intraspinal pressure and increase the mass effect and show the symptoms accordingly. Then Jackson compression test is there that will again positive in facet joint pain or radicular pain. Then Lermit sign is there that produces paresthesia in the arms and legs followed by the forward flexion of the spine. So that will show that will make us think about large disc herniation, cord tumors or cervical myelopathy. And there is some grip release test, inability to open or close the fist rapidly because of the weakness and spasticity. So all these tests will take us, confirm the whatever findings we have got it from these two. So this provocative test can be useful in the evaluation of suspected neuropathic conditions. Specificity of Sperling test is valuable in radiculopathy suspected. Further examination should include the upper and lower extremity strength, hip tendon reflexes, if other neuropathic conditions are suspected. Radiculopathy is manifested by dermatomal-based upper extremity pain and changes in sensation and weakness. In contrast, myelopathy will have a very overt lower extremity findings are not there, but there can be difficulty in balance, spasticity and weakness will be there. So there is a distinct difference between radiculopathy and myelopathy. Examination will reveal atrophy of hands, hyperreflexia, Lermit sign as we discussed. So if after the proper examination, history and examination, then we should go for the investigations. So routine blood investigation like ESR, CRP, these are needed for to diagnose inflammatory arthropathy along with other arthritis profile. X-rays will show us fractures, degenerative changes, cervical rib, other issues. And then the imaging, further imaging like MRI. MRI detects degenerative sleep disk in 50% of asymptomatic patients in 20s and 85% of asymptomatic patients over 65. So MRI is the important diagnosis, important imaging tool in neck pain when there is a more than just a muscular pain or more than just a musculoskeletal pain. So time to diagnosis and intervention can be critical when serious conditions are suspected. So MRI is recommended for patients with suspected infection, any neurological compromise or progressive neurological conditions. MRI is appropriate for patients otherwise also when patient's pain persists for more than 6 weeks and does not resolve the standard treatment. Then CT scan is again useful for trauma cases mainly when we suspect a bony disruption or where there is MRI is contraindicated. EMG, NCV studies are also very important when there is a neuropathic involvement is there, but it is not generally recommended for patients unless they show the signs of neuropathic involvement. EMG can be useful in peripheral neuropathy also if neck pain is associated with that. Diagnostic blocks we do to diagnose or rule out other conditions like median branch blocks or any trigger points. So more than 50% pain relief should be considered positive. And again, if one more thing, USG also can be done to see when there is a muscle or tendon issues are suspected, we can diagnose with that. Then when the after this investigations, we generally after history examination investigations we come to the diagnosis, and then the treatment can be planned. So in the absence of red flags that requires urgent care, treatment can be generally focused on patient's level of pain. So if pain and function, many patients will improve over time regardless of treatment, whether it is a Conservative care includes medications for pain relief, NSAIDs, muscle relaxants, and other painkillers and other analgesics for non-neuropathic pain. There is some evidence that oral corticosteroids provide a short-term relief in patients with acute radiculopathy. Tramadol also is given, but it has only for short-term relief. And narcotics can provide a good relief, but their use is limited because of their side effects. And of course, there are interventions depending on the cause and depending on diagnosis. We can do multiple interventions in neck pain, like cervical epidural injection given with the PID, the radicular pain, median branch blocker, RF ablation for passive pain, trigger point injection for myofascial pain, and further interventions like stellate ganglion, spinal cord stimulator, endoscopic discectomy. All this depending on the condition of the patient. This intervention can be done. So, while treating the patient, should keep in mind inflammatory conditions may briefly respond to steroid insulin, but there is minimal evidence for degenerative conditions. So, we have to think while giving this. It is challenging to determine value of complementary and alternative treatment options, but these provide very modest benefits. So, we have to see each patient and decide on that. Isolated manipulation, mobilization, and other physiotherapy is very important along with our interventions or along with our medical line of conservative treatment. Treatments such as dry needling, low-level laser therapy, TENS, compression therapy have good benefit. Especially dry needling or intramuscular stimulation is useful in muscular myofascial pain where there are trigger points. So trigger points injection followed by IMS is very useful. And surgical, of course, when there is many of the patients will definitely need a surgical intervention. So surgical referral is warranted in cases where progressive neurological deficit is there or any myelopathy or any fracture, trauma, any these conditions need surgical referrals.
Thank you, Nana, for an excellent presentation. We are running short of time. I would like to invite the next speaker, Dr. Krishna Poddar, who is the director of Calcutta Pain Clinic. She has received Times of India Healthcare Pioneer of East India in year 20. That was an award for her pain management skills. Then she has done BCLS, CCLS activity award. She has received an award for that by ISA. Then she has also received COLS activity award by ISA in 21. She has got a long CV. Because of shortage of time, I shall not be going through that. And everybody knows you. Thank you. Please start. And she will be talking on osteoporosis.
Sir, for giving so kind introduction of me, and thank you organizers to give me opportunity. And today I am talking on increasing morbidity of the osteoporosis. And actually osteoporosis is very, very important subject or important disease because and very less aware of by the physician and the patients also. And lots of mortality and morbidity due to the osteoporosis occurring. And we just see when the patient is coming with the vertebral fracture for the vertebroplasty, but how these patients are going under the morbidity and mortality, we have to see that mortality is not directly because of the osteoporosis, but the complication of the osteoporosis, like the most important, the femur fracture, which is the very debilitating and causing the lots of morbidity and leading to the mortality. So this is our patient who is the 76, came with the lots of the chest infection and severe back pain, and because of the back pain he was not able to breathe. When we did the x-ray, we find out the vertebral fracture, but when he came he was having the already done the femur fracture operation. So first symptom was the femur fracture which got operated, but he never got up from the bed. So this is the severe type of the morbidity which occur after the osteoporosis. And the second patient, I just missed the photo of that patient walking the next day, 91 years old doctor. He had this D12 fracture and we actually did the vertebroplasty and patient just walked down next day. When he came and I interview ki we can do vertebroplasty, but as with your age and a lot of the cardiac issue, blood pressure, sugar, there is a risk. His answer was, doctor, it's better to die on the table than not standing or walking. So we need this type of the inspiration to do the vertebroplasty or kyphoplasty to prevent the morbidity, because he didn't want to on the bed after this vertebral. So osteoporosis is classified as a very much public health problem because it is associated with the increased risk of the potential serious fractures at the very old age. So very heavy burden on the morbidity, and due to that is ultimately financial cost. Progressive disease, any movement or bump can cause to the fractures. Painful vertebral fracture may cause a marked decline in physical activity and quality of life, leading to general physical deconditioning with the increased psychological effect. They just bound to bed and they become very depressed, and that they think we can't stand or walk. And most important thing, the problem is most of the physicians, they ask them to lie down after the fractures, not to treat it. And I remember one of my patients, he was just 66. He had a vertebral fracture, he had some cardiac issue. Advised by the cardiologist to have a strict bed rest, he was even not going to toilet, and he was not ready for the vertebral fracture treatment, vertebroplasty. And after 1 month, I heard he died of the embolism because he was strict on bed rest. So this is happening where we see day and night the increased morbidity and mortality after the osteoporotic fracture. So the severe pain and immobility causes the vertebral fracture. Because of the vertebral fractures causes depression, anxiety, reduced pulmonary function, then muscle wasting and the decubitus ulcers. So high risk of developing vein thrombosis, which causes the maybe embolism, and again a very fatal, as I already had an experience of the one patient. So morbidity and mortality, hip fracture causes very severe. Hip fracture actually the main cause of this morbidity, and even after treatment I have seen, even at my home I have seen my Taiji, she never walked down after even the fixation of the fracture in the femur. So they can cause the physical disability, loss of self-sufficiency and confidence. They don't have then confidence to stand because already they are very old. The excessive mortality after the hip fracture, 12 months rates are 12 to 35%. And women with the vertebral fracture had increased 5 years mortality. So these are the normal asked question from the patients, from the doctors, and we have to understand all about this, what is the osteoporosis. So what are the means different, like it can cause the again complication, what are the medication, shall I have to take long-term use of the medication, then they can have the complication for the joint. This lot of the means with the complication we have to answer, and we should be aware, and we should again aware the other people also. So what is the osteoporosis? Is a living bone. Bone is what? Everyday bone we have the osteoclast and osteoblast. So osteoclast is causing the absorption of the bone matrix, bone cells, and give the signal, and osteoblast is manufacturing. So this is the way, I am not going in detail. So 1.5 million fractures annually happen due to the osteoporosis, which causes 700,000 for the vertebral fracture, 200,000 wrist, and the hip are again 300,000, and the other fractures are again 300,000. What is the lifetime risk at the age of the 50? Osteoporotic fractures, women 46 to 53%, men 21 to 22, hip fractures 15 to 23%, and the hip fracture actually not much difference, but the osteoporotic fracture in general is very much difference between the female and male. Radiographic vertebral fracture 27% in female and 11% in the man. Clinical vertebral fracture again 15% in women, whereas the 8% in men. Breast cancer is the cause in the female, and the prostate cancer is the cause in the male. Risk factor is the excess. So what are modifiable and non-modifiable causes, risk factors for the osteoporosis fractures? Like which can modified is the BMD, alcohol use, weight, smoking, physical inactivity. Sorry. And coexisting disease like the diabetes, rheumatoid arthritis, epilepsy, and the pharmacology like steroid therapy and all. Whereas the non-modifiable is the age, we can't change it, gender, ethnicity, fragility fracture, family history of the osteoporosis. Early menopause is very, very common nowadays. I don't know what is the cause, but people are coming at the age of 40, females, and they already achieve their menopause, and BMD. The fracs is very, very important. Know which patient have the high risk of the fracture and which we can prevent it. It has a different questionnaire. You can ask age, sex, weight, height, previous fracture, parent fracture. Then current smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis or alcohol use, and the femoral neck BMD. These are the important points we note and we find out. The second, how can we prevent is the BMD DEXA scan. So according to 2014 NOF guidelines, the BMD should be done all women at the age of 65 and above and men 70 years and above. Younger postmenopausal women who has the clinical high risk of the fracture. Men aged 50 to 69 where again they have the high risk of the fracture. Adults who have conditions associated with the bone mass or bone loss like rheumatoid arthritis. Adults who take the medications like glucocorticoids. These are the where we should do the BMD. And what is the interpreted? T-score is the main. Everyone knows the T-score. If it is a less than -1, it is normal. Osteopenia -1 to -2.5 and osteoporosis -2.5. In elderly patient, we see the Z-score also. So Z-score where they are the severe osteoporosis. Other tests are also important. QCT scanning, single photon emission, and quantitative ultrasound is very just screening program. MRI and bone scanning and bone biopsy is important. Which already have the fracture and we want to do something. So normal questions asked, we have to see like what is the treatment, what is the adverse effect, how much time I want to have the injection, risk assessment, and living with the this or caring with the fractures and what I heard. So we have to do mainly awareness about it. The main treatment is the aims to strengthen the bone for reduction of the fracture risk. So we have the anti-resorptive like bisphosphonates, hyaluronic acid, resveratrolic acid, ibandronic acid, and we have the rankine inhibitor like which is now, it was very expensive before, but now it has the very much less price and in the use of it. HRT and the anabolic agents like the teriparatide. So how the bisphosphonates prevent or treat the osteoporosis? So what happened, the bisphosphonates is given to the patient, they deposit in the bone and the osteoclast attaches tightly to bone surface and produces the acid which dissolve the minerals in the bone and causes the dissolution of the collagen and bone matrix. So when the osteoclast absorb the bisphosphonate, the drug causes the osteoclast to self-destruct so that they don't have any activity for destruction of bone. And as the osteoclast is killed, the message to the osteoblast occur to reduce the slightly reduction in the osteoblastic activity also. So that is why we are very important to give both type of the treatment together. So what is the nice recommendation? Oral bisphosphonates are recommended for the patient who has the 10 years probability of the osteoporotic fracture of the less than 1%. Second, intravenous bisphosphonates are recommended who has the probability of the fracture, 10 years probability of fracture is more than 10%, or the patients who are not able to have the oral bisphosphonates or maybe contraindicated, some patient can't tolerate it. So estimate the 10 years probability of the osteoporotic fracture by FRAX or the QFRAX risk tools, and NICE guideline says the choice of treatment should be made on individual basis after the discussion with the responsible clinician and patient carrier, and then we have to decide what type of the bisphosphonate. So dose for eldronate is 5 mg daily or maybe 35 mg weekly. or for if the patient has already osteoporosis or minus 2.5, then you should use 70 milligram weekly. Ibandronic acid 150 milligram monthly tablet comes, Restoronic 75 milligram for 2 consecutive days per month, or the 5 milligram daily, or the 35 milligram weekly. Again, the zoledronic acid, it has the one more problem is the renal toxicity, so you should be very, very careful. And the dose is the 5 milligram by intravenous for the 15 minutes once in a year. But you should always assess the patient because it sometimes causes a lot of the muscle cramps and all. Side effect of the bisphosphonates, osteonecrosis of the external auditory canal and the hearing loss. So you should suspect if the patient comes with a hearing loss on the bisphosphonate, you should again assess the patient. Osteonecrosis of jaw is bit rare, but it can happen, and very delayed healing of the wound occur in the jaw. So you should be aware of it, and you should not use the bisphosphonate if the patient's GFR is below 30 to 35 ml per minute, because it can cause again fractures, femur fractures, unusual femur fractures. So it is very important to compare the side effect and what is the needed the drug, and then we should give. Denosumab is the again drug of choice when this renal toxicity or bisphosphonate not given. So it is a human monoclonal IgG2 antibody that has high affinity of the rankling receptors, blocks the binding of the rankling to the rank, and administered always subcutaneously. 60 milligram is the dose every 6 monthly. It increases the BMD of all the skeletal muscle and decrease the bone turnover in the 24 months. Independent of the renal function, so you can always advise when the patient has the renal issues, and adverse effect, sometimes the dysregulation of the immune system. So be careful, and you should always do all the TB Gold and the hepatitis B, C before prescribing the denosumab. Parathormone or the teriparatide approved for the osteoporosis with a very high risk of the fracture. It is dosed at 20 microgram subcutaneously daily, and duration not to exceed that 18 to 24 months. And when what happened when this treatment is stopped, the bone loss can be rapid. So you should give the other like the denosumab or bisphosphonates to prevent this. Side effect: leg cramps, nausea, dizziness. Contraindications are the osteosarcoma, and who are on the radiation, or the bone metastasis, hypercalcemia. These are the you should keep in mind. The other medicine drugs are the raloxifene, which is the selective estrogen receptor modulator. The raloxifene is the mixed estrogen agonist antagonist activity. Indication: prevention of the osteoporosis in the mainly most menopausal women. Dose 60 milligram tablet. Again, the venous thrombolism is the side effect. Newer drugs are coming, they are making, that is the abaloparatide. These are the parathyroid hormone related protein, and it can be used with the subcutaneous, or patches can come, and similar vertebral fractures reduction can be done. Similar safety profile as the teriparatide, and still not in market, actually not in India. Non-pharmacological treatments are also very important. We should keep in mind diet changes of the patient.
Can you conclude now?
Yeah.
Can you conclude now?
Yeah, just
already running short.
I can skip this. So vitamin D and calcium are the big factor, and we should supply the patient like 500 milligram daily is the normal dose. So we should give 1200 and vitamin D also. Exercise again very important, not to patient lie down to the bed, and so management of the acute pain in the vertebral fracture is the early mobilization, because not the bed rest. Bed rest is for 1 or 2 days. This is very important, and patient should be mobilized. Exercise, physiotherapy is very, very important, and if possible, vertebral augmentation is the choice of the treatment in the acute fracture in the vertebral, and the femur fixation in the femur fractures. So take home message: prevent osteoporotic fracture to decrease the morbidity of the osteoporosis. Give information and support all the osteoporosis patients and the healthcare workers, or who are the stakeholders in healthcare. Speak with the public, give the talks to the nurses, or who are the gynecologists, or the general physician, and research the evidence and politically work hard to aware the profession.
Okay, thank you very much for an excellent presentation
Thank you,
on
sir.
a topic osteoporosis, which should be actually now more and more, it needs more and more awareness. Actually, what I said, there should be something like a screening, and from the screening, by conducting, we can have that camps also.
Yes, sir.
And then even we can have that out of 100 patients, means individual female patient, you can have 40 or 50 those who are having osteoporosis. And from that time, we start treatment. Thank you very much.
Thank you, sir.
Any question? Okay. Thank you very much for patience hearing.
Thank you, sir.
बैटरी खत्म हो गई है ना, वही हम निकाल ले रहे हैं। शील्ड वगैरह तो नहीं दी? शील्ड अभी नहीं दिया है। अंदर कह रहे वो फ्रेम के ऊपर थोड़ा फोकस कर दो। चार्जर नहीं चल रहा है, चार्जर नहीं चल रहा बनता है। फिर मेरे को बैटरी लगा है, नंबर चल रहा है पर चार्ज नहीं है। वो वाली में लगा लो ना, ओरिजिनल में सोनी है।
उसमें 100 आदमी आ गया था।
माइग्रेट करते रहते
माइग्रेट नहीं कर, हम फिक्स है सर। बीएचयू थे, बीएचयू के बाद वहीं
हाँ अभी तो शुरुआती नहीं तो आए हैं लेट आए ना
रश्मियों को जो धरित्री को जगाती हैं, निशा की वेदना से मुक्त प्रकृति मुस्कुराती है। नमन नत नयन नत 10 नील अंबर के नियंता को, दिशा प्राची को जो नित्य सूर्य का दर्शन कराती है।
न त्वहं काम्ये राज्यं न स्वर्गं न पुनर्भवं, काम्ये दुख तप्तानां प्राणी नामार्तिनाशनम। कल्याण पत्रिका के सेवा अंक में प्रकाशित श्रीमद् भागवत गीता के इस श्लोक का अर्थ एक चिकित्सक से बेहतर कौन समझ सकता है। इसमें निहित भाव को हम सभी मूर्त रूप में रोज ही जीते हैं। इसी भावना और मंगल कामना को सुदृढ़ करते हुए मैं डॉक्टर हेमलता
और मैं डॉक्टर मनीष कुमार सिंह आप सभी का ISPCCON 2023 के उद्घाटन सत्र में अभिनंदन एवं स्वागत करते हैं। सभी चेतना और चैतन्यता की बात करते हैं, किंतु चिकित्सा जगत में पेन मैनेजमेंट का महत्व और यह कितना आनंदित कर सकता है, यह हम चिकित्सक ही समझ सकते हैं।
दर्द एवं पीड़ा से निजात प्रत्येक जन का अधिकार है और इस क्षेत्र में चिकित्सा विज्ञान ने अद्भुत प्रगति की है। इस 3 दिवसीय वैज्ञानिक चिंतन मनन के माध्यम से हम सभी पेन मैनेजमेंट के संदर्भ में अपने अनुसंधान एवं तकनीकी पक्षों के अनुभवों को साझा करेंगे, ताकि हम अपने मरीजों को और बेहतर से बेहतर सेवा प्रदान कर सकें।
इसी क्रम में मैं हम सभी की अभिभावक KGMU की माननीय कुलपति महोदया प्रोफेसर सोनिया नित्यानंद मैडम का, जिनके कुशल संचालन में किंग जॉर्ज चिकित्सा विश्वविद्यालय नित्य नए सोपानों को छू रहा है, मैं आदरणीय मैडम से विनती करूंगा कि कृपया मंच पर प्रतिष्ठित हों।
बिना नाविक के नाव, बिना सारथी के रथ और बिना ड्राइवर के गाड़ी चल नहीं सकती। KGMU के एनेस्थीसिया विभाग के रथ के सारथी प्रोफेसर GP सिंह सर, जो बाधाओं का निवारण करते हुए बड़ी ही सहजता से हम सभी का मार्ग निष्कंटक और प्रशस्त करते रहते हैं, मैं उन्हें मंच पर प्रतिष्ठित होने के लिए आग्रह करती हूँ। सर, कृपया अपना स्थान ग्रहण करें।
नरता का आदर्श तपस्या के भीतर पलता है और देता वही प्रकाश आग में जो अभीत जलता है। हमारे बीच उदित ऐसे ही चमकते सूरज प्रोफेसर वीरेंद्र रस्तोगी सर, जो पेन मैनेजमेंट के क्षेत्र में एक सशक्त हस्ताक्षर है और जिनके उल्लेख के बिना पेन मैनेजमेंट से संबंधित कोई भी आयोजन हो ही नहीं सकता, का सादर अभिनंदन करता हूँ। आपने अपना संपूर्ण जीवन इस क्षेत्र को विकसित करने में लगाया है और देश में इस क्षेत्र में 1 वर्ष का सर्टिफिकेट कोर्स सर्वप्रथम बनारस हिंदू विश्वविद्यालय में आपके ही सतत एवं निरंतर प्रयासों से ही सार्थक हो सका था। मैं माननीय प्रोफेसर वीरेंद्र रस्तोगी सर से निवेदन करूंगा कि उत्कृष्ट हो मंच पर अपना स्थान ग्रहण करें।
मैं अकेला ही चला था जानिबे मंजिल मगर, मैं अकेला ही चला था जानिबे मंजिल मगर, लोग साथ आते गए और कारवां बनता गया। दृढ़ता से अपने चुने हुए मार्ग पर अडिग रहते हुए जिन्होंने अपना कार्य क्षेत्र दर्द निवारण को बनाया तथा अपने निरंतर प्रयास से SGPGI लखनऊ में इस विधा को स्थापित किया, ऐसी प्रतिभा के धनी प्रोफेसर अनिल अग्रवाल सर को मैं मंच पर स्थान ग्रहण करने के लिए आमंत्रित करती हूँ। एक जुझारू और सदिक्षा के धनी पेन मैनेजमेंट की विधा के दिग्गज एवं ISPC के प्रेसिडेंट प्रोफेसर VK मोहन सर पेन मैनेजमेंट के क्षेत्र में उल्लेखनीय कार्यों के लिए जाने जाते हैं। प्रोफेसर मोहन अखिल भारतीय आयुर्विज्ञान संस्थान में पेन मैनेजमेंट यूनिट के इंचार्ज हैं। मैं मंच पर प्रोफेसर VK मोहन सर को आमंत्रित करती हूँ। सर, कृपया मंच पर अपना स्थान ग्रहण करें।
भीड़ से हटकर चला हूँ और भीड़ से हटकर चलूंगा, मौत की वीरानगी में मैं तुम्हें जिंदा मिलूंगा। ऐसे व्यक्तित्व के धनी ISPC सेक्रेटरी प्रोफेसर अनुराग अग्रवाल को मैं मंच पर अपना स्थान ग्रहण करने का आग्रह करता हूँ।
सीढ़ियां उन्हें मुबारक हो जिन्हें छत तक जाना है, सीढ़ियां उन्हें मुबारक हो जिन्हें छत तक जाना है। मेरी मंजिल तो आसमान है, रास्ता मुझे खुद ही बनाना है। इन पंक्तियों के साथ अब मैं इस कॉन्फ्रेंस की ऑर्गेनाइजिंग सेक्रेटरी प्रोफेसर सरिता सिंह मैम से आग्रह करती हूँ कि कृपया मंच पर आकर अपना स्थान ग्रहण करें।
नशा पिला के गिराना तो सबको आता है, नशा पिला के गिराना तो सबको आता है, मजा तो तब है कि गिरतों को थाम ले साकी, सरे होश को बेहोश करना कोई बड़ी बात नहीं, सरे होश को बेहोश करना कोई बड़ी बात नहीं, सोते को जगाना होश में लाना ही तो है करामती। मैं प्रोफेसर मोनिका कोहली मैडम से आग्रह करता हूँ कि माननीय कुलपति महोदया प्रोफेसर सोनिया नित्यानंद मैडम को पुष्पगुच्छ देकर उनका हार्दिक स्वागत करें।
अब मैं प्रोफेसर मोनिका कोहली मैम से आग्रह करती हूँ कि प्रोफेसर जीपी सिंह सर को पुष्पगुच्छ देकर उनका स्वागत करें।
मैं मैडम से आग्रह करता हूँ कि प्रोफेसर वीरेंद्र रस्तोगी सर को पुष्पगुच्छ देकर उनका हार्दिक अभिनंदन करें।
मैं मैम से आग्रह करती हूँ कि प्रोफेसर अनिल अग्रवाल सर को पुष्पगुच्छ देकर उनका स्वागत करें। अब मैं मैम से पुनः आग्रह करती हूँ कि प्रोफेसर वीके मोहन सर को पुष्पगुच्छ देकर उनका स्वागत करें।
मैडम से आग्रह करता हूँ कि डॉक्टर अनुराग अग्रवाल को पुष्पगुच्छ देकर उनका भी अभिनंदन करें।
अब मैं पुनः मोनिका मैम से आग्रह करती हूँ कि प्रोफेसर सरिता सिंह मैम को पुष्पगुच्छ देकर उनका अभिनंदन करें।
मैं आप सभी मंचासीन विद्वज्जनों को दीप प्रज्वलित करने के लिए आमंत्रित करना चाहता हूँ।
शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। हे शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। हे शारदे माँ, तू स्वर की देवी है, संगीत तुझसे, हर शब्द तेरा है, हर गीत तुझसे। तू स्वर की देवी है, संगीत तुझसे, हर शब्द तेरा है, हर गीत तुझसे। हम हैं अकेले, हम हैं अधूरे, हम हैं अकेले, हम हैं अधूरे, तेरी शरण हम, हमें प्यार दे माँ। हे शारदे माँ, हे शारदे माँ, शारदे माँ, हे शारदे माँ, अज्ञानता से हमें तार दे माँ। हे शारदे माँ, हे शारदे माँ।
अब मैं कार्यक्रम के चेयरपर्सन एवं विभागाध्यक्ष प्रोफेसर जीपी सिंह सर से आग्रह करती हूँ कि आप सभी अतिथियों का स्वागत अपने उद्बोधन द्वारा करें। सर।
थैंक यू डॉक्टर हेमलता। आप सभी का लखनऊ शहर में स्वागत है। लखनऊ शहर सिटी ऑफ नवाब, पहले आपकी नजाकत और नफासत वाला शहर है। Dignitaries at the dais, Professor Sonia Nityanand ji, our Honorable Vice Chancellor, King George Medical University, Dean Academics, Madam आना था कहीं बिजी नहीं आ पाई, President of ISSP, Professor Mohan साहब, Secretary ISSP, Dr. अनुराग जी, और वरिष्ठ एनेस्थीसिया के और पेन सोसाइटी के पूर्व अध्यक्ष डॉक्टर वीरेंद्र रस्तोगी साहब, जो कि हमारे किंग जॉर्ज मेडिकल यूनिवर्सिटी उस टाइम KGMC था के प्रोडक्ट हैं, यहीं के MBBS और MD हैं, प्राउड जॉर्जियन। डॉक्टर अनिल अग्रवाल साहब, रिटायर्ड प्रोफेसर एंड हेड SGPGI, डॉक्टर सरिता सिंह, ऑर्गेनाइजिंग सेक्रेटरी, delegates, ladies and gentlemen, people from media. On behalf of Department of Anesthesia and Pain Unit, I welcome you all in this conference of pain, which is being held in Lucknow at King George Medical College University. And मैं आप सबका वेलकम करता हूँ, हार्दिक अभिनंदन करता हूँ, स्वागत करता हूँ। आप लोग यहाँ पर आए, दूर जगहों से आए, कष्ट सह करके आए, लेकिन कॉन्फ्रेंस की भावना से कॉन्फ्रेंस अटेंड करने के लिए आए, इसलिए आप सबका मैं हृदय से स्वागत करता हूँ। विभाग की तरफ से, किंग जॉर्ज यूनिवर्सिटी की तरफ से, जैसा कि अभी मनीष जी कहते थे, पेन इज फॉर एवर, इटर्नल प्रॉब्लम। आदि समय से पेन की परिभाषा चल रही है। अब कुछ
लाइजॉल फिनाइल
पेन जो है नॉट ओनली इनका स्ट्रेस
से बेटर हुआ तो अपना नाम बदल लूंगा। चलो क्लीनिंग टेस्ट करते हैं।
है ना लाइजॉल सफाई में 10 गुना बेटर।
पर फिनाइल तो सस्ता है।
सस्ता? फिनाइल के 3 ढक्कन के मुकाबले लाइजॉल सिर्फ 1 ढक्कन।
स्पिरिचुअल और इमोशनल कंपोनेंट भी अब जोड़ दिया गया है। तो सिर्फ इंजेक्शन लगा देने से पेन का नहीं हो सकता है, उसके लिए इमोशनल एस्पेक्ट भी, उसकी भी साइकोथेरेपी के लिए, फिजियोथेरेपी के लिए कुछ होना जरूर चाहिए। और KGM नेशनल मेडिकल कमीशन इस पर बहुत ध्यान दे रहा है और फैमिली मेडिसिन, पेन मेडिसिन, इन सब पर विशेष रूप से ध्यान करके नई ब्रांचेस खोल रहा है। अब मुझे लगता है कि बहुत शीघ्र पेन DM in pain medicine permission will be given by National Medical Commission. Since I am HOD, I have to make a small request, madam. She's sitting here. There is some space crunch. I know you are under great pressure for space allotment, but still being HOD, I have to request you to give space to the further expansion of this unit and department. In the end, I hope you will all enjoy the conference, and एक बार मैं फिर आप सबका तहे दिल से स्वागत करता हूँ, अभिनंदन करता हूँ। बहुत बहुत धन्यवाद।
धन्यवाद सर। अब मैं ISPC के प्रेसिडेंट प्रोफेसर VK मोहन सर को आमंत्रित करता हूं कि वे अपने शब्दों से हम सभी को अभिसंचित करें।
आप में से ज़्यादातर लोग संवेदना हरण से थोड़ा सा आगे हटके दर्द हरण विद्या में निपुण होने की कोशिश करें और सभी मरीजों को जिनको जो दर्द से परेशान है उसके लिए उनका नीड देना चाहते हैं। मैं जब शुरू किया था तो काफ़ी उससे शुरू किया था और तब ये विद्या इतना बनी थी कि लिमिटेड उसके आचार्य प्रचार्य और लोग थे जो प्रैक्टिस करते थे। धीरे धीरे हमने लोग सीखा और हमने डॉक्टर सैनी होते थे एम्स में, डॉक्टर गुरुदास होते जो, और हमारे मेरा जो गाइड थे प्रोफेसर YK बत्रा PGH चंडीगढ़ में, उन लोगों को देख देख के जो थोड़ा इंटरेस्ट डेवलप हुआ कि ये भी एक विद्या है, इस विद्या को भी सिखाया जाता है जिससे हम मरीजों के लिए थोड़ा उनको दे सकते हैं, उत्थान कर सकते हैं और उनको दर्द हरित कर सकते हैं। धीरे धीरे हमने ये किया और मैं डॉक्टर रस्तोगी का धन्यवाद करता हूँ। उन्होंने इस जो ट्रेंड और अनट्रेंड लोगों के लिए जो काम किया और एक सोसाइटी को भी जिसका मैं प्रेसिडेंट हूँ और सोसाइटी ने काफ़ी काम किया और इसलिए जो जितने भी हमारे एजुकेटेड और स्ट्रक्चर ट्रेनिंग वाले जो पेन फिजिशियंस हैं उनके लिए कर रहे हैं। इस सोसाइटी का जो उद्देश्य था वो ये था कि हम डॉक्टर रस्तोगी और सोसाइटी मौका देना चाहती है उन सभी जो नए नए पेन फिजिशियन आए हैं उनको एक प्लेटफॉर्म दें जिसमें अपने विचार, अपनी नॉलेज, अपने स्किल शेयर कर सकें और इसी कड़ी में ये छठी कॉन्फ्रेंस है और आप लोग सब इस कॉन्फ्रेंस में आए, मैं आप सब लोग का धन्यवाद करता हूँ।
आपकी ओजपूर्ण वाणी ने निश्चय ही हम सबको उत्साहित किया, धन्यवाद सर। अब मैं ISPC के सचिव प्रोफेसर अनुराग अग्रवाल सर से आग्रह करूंगी कि वो वार्षिक रिपोर्ट प्रस्तुत करें।
धन्यवाद डॉक्टर हेमलता। सर्वप्रथम भगवान श्री गणेश को प्रणाम। साथ ही प्रणाम है हमारी वाइस चांसलर प्रोफेसर सोनिया नित्यानंद मैम जो कि हमारे अपने डॉक्टर राम मनोहर लोहिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज की डायरेक्टर भी हैं। आपका थैंक यू मैम, आप यहाँ पर समय निकाल कर आए हमें आशीर्वाद देने के लिए। उसके बाद मैं नाम लेना चाहूँगा प्रोफेसर वीरेंद्र रस्तोगी साहब जो कि लिविंग लीजेंड है, हिंदी इसकी मुझे पता नहीं क्या बोलते हैं, ऑफ पेन मेडिसिन इन इंडिया, जिन्होंने 1984 में पहले सोसाइटी का गठन किया जिसका नाम इंडियन सोसाइटी फॉर स्टडी ऑफ पेन है और उसके बाद 2015 में ये दूसरी सोसाइटी जिसकी कॉन्फ्रेंस हो रही है इंडियन सोसाइटी ऑफ पेन क्लिनिशियंस का गठन किया जब उन्होंने एक एनविजन किया कि भाई फॉर्मल ट्रेनिंग की ज़रूरत है पेन मेडिसिन में। और क्यों है ज़रूरत पेन मेडिसिन में, थोड़ा सा मैं प्रकाश डालना चाहूँगा इस पर, क्योंकि आज की तारीख में एक स्टडी चल रही है गवर्नमेंट इंडिया सपोर्टेड बाय हार्वर्ड बाय द इंटरनेशनल इंस्टीट्यूट ऑफ पॉपुलेशन रिसर्च इन मुंबई। They have published their midterm finding, that is a longitudinal 20 years study. They have found the incidence and prevalence of pain, chronic pain conditions in the Indian population up to 35%. Start from 20 to 35%. As the age increases, the incidence of chronic pain increases. So it is the biggest NCD, non-communicable disease. The danger is looming over our society because the age of living is increasing continuously. So that's why the formally trained pain physicians are required to help this. So इन शब्दों के साथ में मैं सभी बाकी को प्रणाम करता हूँ, प्रोफेसर अल्ला साहब, प्रोफेसर जीपी सिंह सर, प्रोफेसर वी के मोहन, डॉक्टर सरिता सिंह इस भव्य आयोजन के लिए। और सोसाइटी की जहाँ तक बात है, ये सोसाइटी का निर्माण 2015 में हुआ। मुझे मौका मिला है इसकी सेवा करने का पिछले 4-5 साल से, क्योंकि बीच में कोविड पैंडेमिक की वजह से 3 बार हमारी कॉन्फ्रेंस नहीं हो पाई। बस इस दौरान भी सोसाइटी का लगातार काम चलता रहा और हम लोग पेन मेडिसिन एजुकेशन के क्षेत्र में काम करते रहे। जब कोविड में सारा कुछ बंद था तो सोसाइटी ने एक बीड़ा उठाया और एक पेन मेडिसिन गुरुकुल, ऑनलाइन गुरुकुल का इस्तेमाल किया, जिसमें हम लोगों ने करीबन 12 वेबिनार किए जो कि वेल अप्रिशिएटेड थे, नॉट ओनली इन इंडिया बट अक्रॉस द वर्ल्ड। उसके अलावा हमारे नए मेंबर्स की लगातार संख्या बढ़ रही है। पिछले 2 साल में करीबन 60 नए मेंबर्स ने हमारी सोसाइटी को ज्वाइन किया है। इसमें मैं थोड़ा सा बताना चाहूँगा कि हमारी सोसाइटी में जो एंट्री सर ने बनाई है, दैट इज ओनली फॉर द पीपल हु आर फॉर्मली ट्रेन्ड फॉर एटलीस्ट 1 year इन सम इंस्टीट्यूट ऑफ रेप्यूट एंड देयर मेंटोर्स। अदरवाइज मतलब जो जिनके नॉन फॉर्मली ट्रेन्ड हैं, दे कैन नॉट कम टू द सोसाइटी। विद द एफर्ट्स ऑफ ऑल द सीनियर्स एंड द सपोर्ट फ्रॉम द एडमिनिस्ट्रेशन, हमारे यहाँ पर अब आज की तारीख में 2 जगह पर एम्स गोरखपुर एंड एम्स ऋषिकेश, उन 2 जगह पर डीएम पेन मेडिसिन स्टार्ट हो चुका है। एम्स ऋषिकेश से 2 बैच, एक्चुअली 3 बैच पास आउट होकर अलग अलग जगह पर ज्वाइन कर चुके हैं। उसके अलावा बहुत सारे एफर्ट्स के बाद में प्रोफेसर नवीन मल्होत्रा इज हियर, FNB पेन मेडिसिन 2 years FNB पेन मेडिसिन स्टार्ट हो चुका है, जो कि 3 इंस्टीट्यूट में अभी एज ऑफ नाउ चल रहा है देश के अंदर और धीरे धीरे बढ़ रहे हैं। इसके अलावा PDCC कोर्सेज जो सबसे पहला सर ने BHU में स्टार्ट किया था, फिर अनिल सर ने SGPGI में, और अब लगातार KGMU में स्टार्ट हुआ और आपके आशीर्वाद से मैम RML में भी स्टार्ट हुआ। पहला बैच निकल चुका है, दूसरा बैच गोइंग ऑन। तो ये हमारी कॉन्फ्रेंस की सोसाइटी के उपलब्धियां हैं। very kind. मैम के समय में हमारे यहाँ PTCC स्टार्ट हुआ. मैम gave us some space also to admit our patient. तो मैम हमें पूरी उम्मीद है एज अ सोसाइटी कि आपके आशीर्वाद से हम लोग एक अलग सेपरेट पेन मेडिसिन डिपार्टमेंट एज अ सुपर स्पेशलिटी ब्रांच ऑफ एनेस्थीसियोलॉजी कैन स्टार्ट. एंड as KGMU has been always the pathfinder and torch bearer in multiple specialties, and as you have already carved a niche of the hematology in the pet medicine, मैम आपकी हमारे ऊपर आशीर्वाद रहेगा. तो KGMU again will show the path in the field of pain medicine by starting a DM pain medicine. इन्हीं शब्दों के साथ मैं आप सबको अपनी शुभकामनाएं देता हूँ. आपका स्वागत करता हूँ लखनऊ शहर में कॉन्फ्रेंस के लिए भी और हॉस्पिटल के लिए. धन्यवाद.
धन्यवाद सर. इस क्रम को आगे बढ़ाते हुए अब मैं विशेष अतिथि प्रोफेसर वीरेंद्र रस्तोगी सर को आमंत्रित करता हूं कि वह सभा को अपने पुण्य वचनों से अनुग्रहित करें.
Honorable Chief Guest, Sunita ji, dignitaries on the dais, off the dais, and the delegates attending this conference, ladies and gentlemen. First of all, I express my thanks to the organizers for giving me this honor and being the alma mater of this KGMC. This is, I feel privileged and proud to be this guest of honor. And I did my graduation as well as post-graduation from the KGMU, and my teacher, actually the mentor, Professor S. Yagnik, he was very much keen for pain procedures. And that time, I think it was somewhere in 76, 75, he used to run a pain clinic where he used to do few nerve blocks and some blocks he did in radiology also. And I think that was the initiative or the inspiration which I had. And once I joined Banaras Hindu University, Institute of Medical Sciences, there I met Professor K. Pandey, and Professor Akram Lal. Actually, Professor Pandey, you know that he was the legend in the anesthesia. Professor Lal, actually, he was very much keen for pain management. And there he gave his support to develop the pain management department there. And we started in 1980, we started the pain clinic there with his support. And then he also supported in formation of various societies. First we had in 1984. He was also instrumental in another society. After 30 years we launched. This is the Indian Society for Pain Clinician. So it was already existing, and why should we have another society? The reason was simple. Because in that first society, means Indian Society for Study of Pain, this was multi-professional. It was you can say that disciplinary. Here we have got a representation from the physiotherapy, we have got nursing, neuro surgeon, then we have a specialist ortho. So what we thought actually is that let us have a society which will look after only the part of the pain clinicians. And then we thought anybody who has got some training in the structured training in medical college or wherever. So we should include those, and we bring all those physicians at one platform, and we form the Indian Society for Pain Clinician. However, this society or the 6th conference is going here. After that, we never look backward, and we are all progressing day by day. But still, there are few things I want to mention which need to be addressed. One is the awareness. Still, in spite of the 40 years of ISSP formation, there is hardly any awareness, even that public, not only the public, the health providers, even our own colleagues, they are not aware of what is pain management. So now the emphasis should be on the creating awareness, either through the newspaper, you can through the talk, through this TV. So this is the need of the hour. Then the education part. We started simply a PDCA, that is 1-year course. Now we have got 2 years courses in PTF as well as the, you can say this FNB, pain medicine. I'm happy to share with you that at least 3 places they are having FNB courses, and we hope that in near future more and more center will come for that. We have got 20 medical colleges where we have got the PTC 1-year course, and we have got 2-year courses in at least 3 or 4 institutions. DM we have got one in Rishikesh, another is coming up. So this is what we have achieved, but we need to achieve more. I think the first priority should be to get recognition from NMC. I think we are also trying to get, the moment we have in recognition is pain medicine from National Medical Council, the things will start moving. One thing I want to share with you that this, you can say that third party assured TPA, and we have got certain ISPCCON as well as the CGHA scheme where some of the pain procedures are included. So we should also try to include these procedures in the Ayushman Bharat or PMSY scheme, so that the poorest people should get benefit. With these words, I again thank to the organizers for giving. Thank you very much.
आपका अतिशय धन्यवाद सर। अब मैं विषय अतिथि एवं पूर्व विभागाध्यक्ष डिपार्टमेंट ऑफ एनेस्थीसियोलॉजी SGPGIMS लखनऊ प्रोफेसर अनिल अग्रवाल सर को आमंत्रित करती हूँ कि आप अपने शुभ वचनों से हमारा मार्गदर्शन करें।
हेलो, गुड आफ्टरनून एवरीबॉडी। ज़्यादा टाइम नहीं लेंगे आप लोगों का, बट जस्ट आई वाज थिंकिंग 2006 के ऐसे सोच रहा था क्या आप लोगों से शेयर करूं। तो 2006 में एक इवेंट हुआ था मेरे साथ CABG, मेरा ओपन हार्ट हुई थी, एंड सब्सिक्वेंट टू दैट सब चीज़ें बड़ी अच्छी रही ऑब्वियसली, दैट इज़ व्हाई आई एम हियर। बट पोस्ट ऑप में काफ़ी पेन हुआ था मेरे को, फिजियोथेरेपी वगैरह जब कर रहा था तो इट वाज रियली वेरी पेनफुल। सो दैट डे जिन्होंने हेल्प किया था मेरे को, अभी मेरे सामने बैठे हैं, सुजीत वॉज देयर, ही हेल्प मी आउट ऑफ दैट। तो दैट डे आई टुक अ रिजॉल्व। उस समय एक्यूट पेन हम चला रहे थे PGI में, मिनिस्क्यूल लेवल पे चल रहा था। सो दैट डे इट गेव मी अ रिजॉल्व, नहीं कुछ हम लोगों को करना चाहिए, PGI में रहते हैं तो कुछ तो करें ऐसा जिससे कि पेशेंट की सफरिंग कम हो। सो दैट इज़ हाउ आई गॉट द मोटिवेशन। सब्सिक्वेंटली फिर एक्यूट चलाया, एक्यूट के बाद क्रॉनिक पेन आया, क्रॉनिक पेन में कुछ जब करना सोचा कि क्रॉनिक पेन कैसे शुरू करें, तो उस समय ना तो आता था कुछ हमें, नीदर हमें, ना हमारे पास पेशेंट लोड था, पेशेंट से कैसे डील करते हैं ये भी हमें नहीं पता था, कि अगर कोई प्रोसीजर करना है तो प्रोसीजर के लिए क्या क्या चीज़ चाहिए, कि दैट ऑल्सो वी डिडंट नो। अगर वो मिल जाएगी तो सियाम नहीं मिलेगा, सियाम मिल जाएगा तो OT नहीं मिलेगी। सो देयर वाज नथिंग एक्चुअली, सो वी रियली स्टार्टेड फ्रॉम स्क्रैच। तो उस दिन को जब मैं सोचता हूँ और आज का जब दिन देखता हूँ तो इट इज़ अ ट्रेमेंडस फीलिंग कि हम कहाँ से कहाँ तक पहुँच गए। सो ये सब बहुत तारीफ की बात है, क्रेडिट की बात है कि हम इतना यहाँ तक आए। लेकिन कोई भी चीज़ मन दिल नहीं, क्या होता है, दिल मांगे मोर। सो ठीक है हम यहाँ तक हैं, लेकिन अभी हमें बहुत कुछ आप लोगों को आगे जाना है, एंड इसमें एडमिनिस्ट्रेटर्स का भी रोल है, अवेयरनेस बढ़ाने का भी रोल है कि पेन के बारे में बहुत अवेयरनेस बढ़ी है रिलेटिवली उस टाइम से, बट स्टिल लॉट मोर इज नीडेड। एंड सिमिलरली इसी में एज ए मैम बैठे हैं तो मैम से चाहूँगा कि क्रिएशन ऑफ न्यू कोर्सेज पे हमारा, क्योंकि पेरिफेरी में डिमांड बहुत है, पहले नहीं थी, पहले प्रॉब्लम थी, बट आज के दिन बहुत डिमांड है। तो हमको कौन प्रोवाइड करेगा? प्रोवाइड तो हम ही लोगों को करना है। सो क्रिएशन ऑफ न्यू कोर्सेज एंड क्रिएशन ऑफ द डिपार्टमेंट, आज हमारे KGMC में एज ए यूनिट चल रहा है ये, मे बी वी कैन थिंक ऑफ क्रिएटिंग ए न्यू डिपार्टमेंट ऑफ पेन मेडिसिन और पेन और पैलिएटिव मेडिसिन व्हाटएवर। सो बहुत कुछ करना है, आई एम श्योर विल टेक इट फॉरवर्ड। थैंक यू।
आपके वक्तव्य से हम सभी अभिभूत हैं सर, आपका हृदय से धन्यवाद। हमें गर्व है कि आज हम उन कर्मठ विद्वान गुरुजनों को सम्मानित करने जा रहे हैं जिन्होंने अपने जीवन काल में पेन मेडिसिन के क्षेत्र में अद्वितीय योगदान दिया है और इस विधा को नई ऊंचाइयों पर पहुंचाया है।
मैं माननीय कुलपति महोदया से आग्रह करता हूं कि आप अपने कर कमलों से प्रोफेसर वीरेंद्र रस्तोगी सर एवं प्रोफेसर अनिल अग्रवाल सर को पेन मैनेजमेंट में उनके दिए गए योगदान के लिए लाइफ टाइम अचीवमेंट अवार्ड से सम्मानित करें। कृपया गड़ाहट कम न काटे। उतनी नहीं चाहिए।
अग्रवाल सर। धन्यवाद मैडम। अब मैं माननीय कुलपति महोदया से विनम्र निवेदन करती हूँ कि आप इस सभा को अपने आशीर्वचनों से अभिभूत करें। मैम।
Dr. G.P. Singh, the head of the department, Dr. Virendra Rastogi, Dr. Anil Agarwal, Professor Mohan, who is the president, Professor Anurag Agarwal, the secretary, Dr. Sarita Singh, who is the organizing secretary, Dr. Monica Kohli, many other distinguished faculty members who are from the country, who are from the department, from the country, and I believe some international speakers have also come. The participants in this conference today and the media friends. First of all, I would like to congratulate the organizing team for this first international conference of the Indian Society of Pain Clinicians. It's the first conference. And of course, the 6th nationals. So many congratulations, Dr. G.P. Singh and Dr. Sarita, Dr. Monica Kohli, many congratulations. As has already been highlighted, if you see anesthesia, the basic crux of anesthesia is that the body goes through any surgery, any complex surgery, without the perception of pain. So it's very logical that the field of pain medicine goes to anesthesia department. It is a deep knowledge, the way I perceive pain medicine. It's a knowledge of the pharmacological modulation of pain. So a deep knowledge of the drugs, the pharmacokinetics, the pharmacogenomics, the pharmacovigilance of all the drugs which are used to alleviate pain. And as science, as medical science proceeds, it's topped by procedures which are then used for removing pain, for alleviating pain. And then in procedures, the minimally invasive procedures. So that's how medical science evolves. And I understand that there is going to be a cadaveric workshop on minimally invasive procedures by ultrasound fluoroscopy and spinal endoscopy. So how beautifully this field has evolved, and that's why it's a specialized field, from drugs to procedures to minimally invasive procedures.
and I'm sure very soon to no invasive procedures like radio ablation, etc. I've been a witness to the pain clinic, which was started by Dr. Anil Agarwal in SGPGI, because I deal with blood cancer patients, and the pain clinic was a very important clinic for us. And we used to refer patients all the time, and they used to give us service actually 24 hours and even home service. So many vertebroplasties have been done by Dr. Anil Agarwal in my multiple myeloma patients, where their whole quality of life has changed. So it's from drugs to procedures. He's done them so beautifully, these vertebroplasties. And then in RML, when I moved, I tried to give a lot of emphasis, because I saw a lot of enthusiasm in Dr. Anurag and Dr. Shivani, who is sitting here. They both used to keep coming to me as, young faculty members who came to me. I had a background experience of the importance of pain medicine from SGPGI, and I saw that flare of enthusiasm in both of them. So I tried to encourage them into developing this field, and finally in KGMU I find a lot of enthusiasm again in the department with Dr. Sarita Singh being there. So I do hope that both these institutes, both RML as well as King George's Medical University, very soon start a DM in pain medicine. It goes without saying that the quality of services improve when academic courses are started. So the academic courses, we've all heard, started with PDCC, with PDF, with FNB, and now we hope that both these institutes will start with DM in pain medicine. It is interesting because NMC now allows DMs in broad specialities to be started within the same department. So the way to go forward will be to start DM as soon as it is a NMC recognized subject, and then as it grows to hive into a separate department. But first, more important would be to start the DM course. The whole area will get a big thrust with the DM course because it's a field by itself. I'm very happy to see also that there are so many participants for this emerging area of medicine and anesthesiology, people from all over the country, and so many people have come for this emerging area. And my good wishes, and from the side of the society should try to push the recognition of DM in pain medicine by NMC. So wish you all the best, and thank you, the stalwarts who started pain medicine, Dr. Rastogi and Dr. Mohan, for being here and gracing this occasion. And I hope all the participants have a very useful meeting today. Thank you.
धन्यवाद मैडम। मैं आप सभी मंचासीन विद्वज्जनों से आग्रह करता हूं कि आप स्मारिका पत्रिका का विमोचन करें। मैं प्रोफेसर जीपी सिंह सर से आग्रह करता हूं कि माननीय कुलपति महोदया को स्मृति चिन्ह देकर उनका सादर अभिनंदन करें।
अब मैं प्रोफेसर जीपी सिंह सर से आग्रह करती हूँ कि प्रोफेसर वीरेंद्र रस्तोगी सर को स्मृति चिन्ह देकर उनका अभिनंदन करें।
मैं प्रोफेसर जीपी सिंह सर से आग्रह करता हूं कि प्रोफेसर वीके मोहन सर को स्मृति चिन्ह देकर उनका अभिनंदन करें।
अब मैं प्रोफेसर जीपी सिंह सर से आग्रह करती हूँ कि प्रोफेसर अनिल अग्रवाल सर को स्मृति चिन्ह देकर उनका अभिनंदन करें। अब मैं जीपी सिंह सर से पुनः आग्रह करती हूँ कि प्रोफेसर अनुराग अग्रवाल सर को स्मृति चिन्ह देकर उनका अभिनंदन करें।
मैं प्रोफेसर सरिता सिंह मैडम से आग्रह करता हूं कि प्रोफेसर जीपी सिंह सर को स्मृति चिन्ह दें।
और अब मैं प्रोफेसर जीपी सिंह सर से आग्रह करती हूँ कि प्रोफेसर सरिता सिंह मैडम को स्मृति चिन्ह देकर उनका अभिनंदन करें।
धन्यवाद सर। कार्यक्रम के अंत में मैं ऑर्गेनाइजिंग सेक्रेटरी प्रोफेसर सरिता सिंह मैडम से आग्रह करूंगा कि वह माननीय अतिथियों को धन्यवाद प्रस्ताव ज्ञापित करें।
धन्यवाद डॉक्टर मनीष एंड डॉक्टर हेमलता फॉर इनवाइटिंग मी टू डिलीवर द वोट ऑफ थैंक्स। आप सभी को मेरा नमस्कार। मंच पर आसीन माननीय कुलपति एवं इस कार्यक्रम के मुख्य अतिथि प्रोफेसर सोनिया नित्यानंद मैडम को मैं हृदय से आभार प्रकट करती हूँ तथा धन्यवाद देती हूँ जिन्होंने अपने इतने बिजी शेड्यूल से समय निकालकर हमारे कार्यक्रम में उपस्थित हुई और अपने आशीर्वाद वचनों से हमें अनुग्रहित किया। हम आगे भी कामना करते हैं और उम्मीद करते हैं कि मैडम का आशीर्वाद ऐसे ही पेन यूनिट पर बना रहे। धन्यवाद मैडम, बहुत बहुत धन्यवाद। इसके साथ साथ मैं प्रेसिडेंट ISPC प्रोफेसर वीके मोहन सर, गेस्ट ऑफ ऑनर प्रोफेसर अनिल अग्रवाल सर, फाउंडर मेंबर ऑफ ISPC प्रोफेसर वी रस्तोगी सर, विभागाध्यक्ष एवं चेयरपर्सन ऑफ दिस कॉन्फ्रेंस प्रोफेसर जीपी सिंह सर, सेक्रेटरी ISPC प्रोफेसर अनुराग अग्रवाल तथा इस शुभ अवसर पर उपस्थित देश के विभिन्न स्थानों से आए हुए प्रशिक्षक एवं कॉन्फ्रेंस में भाग लेने वाले प्रतिभागी तथा इस विश्वविद्यालय के शिक्षक, विभागाध्यक्ष एवं विद्यार्थियों का मैं हृदय से आभार व्यक्त करती हूँ तथा इन्हें धन्यवाद देती हूँ जिन्होंने हमारे इस कार्यक्रम को अपनी उपस्थिति देकर सफल बनाया। इसके साथ साथ मैं अपने विभागाध्यक्ष प्रोफेसर जीपी सिंह सर एवं को चेयरपर्सन ऑफ दिस कॉन्फ्रेंस प्रोफेसर मोनिका कोहली मैम तथा विभाग के सभी फैकल्टी का मैं उनके द्वारा दी गई प्रेरणा, समर्थन और मार्गदर्शन के लिए हृदय से आभार व्यक्त करती हूँ। मैं पेन मेडिसिन यूनिट की फैकल्टी डॉक्टर अजय चौधरी, डॉक्टर मनीष कुमार सिंह को उनके अनवरत कार्य एवं समर्थन के लिए धन्यवाद देती हूँ तथा यूनिट के सभी मेडिकल डॉक्टर ऋचा, डॉक्टर नीरज को मैं और सभी पैरामेडिकल स्टाफ एवं विभाग के सभी कर्मचारियों को जिन्होंने इस कॉन्फ्रेंस को सफल बनाने में अपना योगदान दिया है, इसके लिए मैं सभी को धन्यवाद देती हूँ। इसी क्रम में मैं सभागार में उपस्थित सभी पत्रकार एवं मीडिया बंधुओं को इस कार्यक्रम में आने के लिए धन्यवाद करती हूँ और मैं इन 2 लाइनों के साथ अपनी वाणी को विराम देती हूँ। खुशियों भरी इस महफिल में आज अपनेपन का एहसास हुआ है। खुशियों भरी इस महफिल में आज अपनेपन का एहसास हुआ है। आपकी गरिमामयी उपस्थिति पाकर यह कार्यक्रम खास हुआ है। धन्यवाद।
धन्यवाद मैडम। सभी साथियों से अनुरोध है कि कृपया राष्ट्रगान के लिए अपने अपने स्थान पर खड़े हो जाएं। यह भी अनुरोध है कि कृपया सब लोग रुके रहें। इसके पश्चात सब लोग लंच के लिए प्रस्थान करेंगे।
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
कृपया सब लोग लंच के लिए प्रस्थान करें। धन्यवाद।
ये तार देखे थे, तार देखे थे।
अभी डॉक्टर
हमारा में कराया फिर 14-15 में कराया बीच में हाँ 12 में
इधर लंच हुआ ये तो उधर भी हुआ ये।
अबे वहाँ कोई है नहीं,
वहाँ पे कोई ना। बैठे रही का पैर फंसा दी बार फंसा तो पर फिर उधर बैठ जाओ जाले पे हाथ लगा रहे देखे वो हम सब चले गए हम भूगो तो लग रही भागो हम लोग का कर रहे मुझे तो लग रही है अभी किसी की लग कहाँ रही है ऐसा तो सूत रहे हो अभी नहीं अभी है नहीं उधर खाली हुआ बता रहे उधर अभी सर से पूछे पंखा नहीं लग रहा बैलेंस से, यूं है शर्त लगाइयो
इधर को ऊपर रहा है ना,
देखो पाया
इसका लेवल देखो पहले,
ई लेवल की हुई है यहाँ ऑफिस है, ये कोई तुम्हारा घर नहीं है,
लेवल लेवल इसलिए करते हैं,
ये ऑफिस है, कोई घर नहीं है, लेवल ऐसे बराबर कर जाता है, दिखाई देता है ये पंजों जी
वैसे ही बराबर करेगा, अब भी वैसे ही लिखी थी, कुछ भी ना अंतर लगे,
चलो छोड़ दो तो बैठे बैठे ना अभी इसे रखना
भाई पूरा फैला के ना
नहीं, ठीक है कोई बात नहीं, गिर जाइए इसे तो गिर
तो ही चाहिए हम,
रुक जाओ ये सर से पूछते हैं, सर जा रहे हैं, सर
पूछो हमारे आधे घंटे टाइम लिखी है,
सर अभी स्टार्ट होगा ना,
हाँ अभी फिर से स्टार्ट होगा, खाने वाने के भी तो लोगे फोटोग्राफ,
जी जी भाई,
हेलो
हाँ
हेलो
जाओ उठो फटाफट निपटो, स्टार्ट कीजिए तो एक साथ कहाँ दिए जाओ जल्दी जाओ फटाक से, और क्या करियो, जाओ जल्दी जाओ, चलो
हेलो चेक
भेज दिया है,
हेलो
वो कहाँ
हेलो
है
हेलो
ऋषभ
हेलो
ऋषभ यहाँ
हेलो
हम खा रहे
हेलो
थे तो देखे
हेलो हेलो चेक हेलो चेक हेलो 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 चेक हेलो चेक 1 2 3
किया हो, बाकी थोड़े
बहुत
डिपार्टमेंट
मेहनत
वाले।
किया है। नहीं नहीं डिपार्टमेंट्स कुछ नहीं है सर।
हाँ?
मेरा चली जाने दीजिए, आगे हमारे हेड बोल दी, हमारी एक और सेल्स के लिए भी बोल दिया सर।
बोल दिया ही बोल
So, so the topic of this panel discussion is role of regenerative medicine in pain medicine. So this is an upcoming arena of pain medicine, and I think this is a very important area which need exploration by the pain physicians. So I would like to start with Dr. Ashok. So what do you mean by regenerative medicine, sir? And what do you think, what is the principle behind it?
Can you hear me? Yeah. Okay. So when we talk of the regenerative medicine, it's about the tissue and cell-based repair, and it involves basically stem cells and stem cell derived products. And it is not a medicine, but you can call it a living medicine, where we just do not treat the symptoms only, but we try to treat the cause of problem also by various methods.
So by using regenerative medicine, we are trying to regenerate the tissue. So this time the role has been reversed. Okay, I would like to ask Dr. Krishna Pradar ma'am, what agents or drugs can be used for regenerative therapy?
So many products for a long time, it has been now to advance so much, but before also we used to use so many things for the regenerative. Like if you use the hyaluronic acid, it is also one type of the regenerative therapy. And even the prolotherapy, the dextrose prolotherapy, before it we used to, even the ozone prolotherapy, these all are also regenerative therapy. Now we are using PRP, platelet-rich plasma, and then stem cell or mesenchymal cell. Mesenchymal cell we derive from many things, like we derive from the bone marrow autologous or the autologous fat, then from the cord, mesenchymal cell from the umbilical cord, and sometimes we then grow. So these all are the regenerative products which we use for anything.
So we have got right from the drug to the living tissue or the cells which we can utilize to have the regenerative effect on the human body to relieve our chronic pain conditions. So Dr. Sudhir, what are the common clinical conditions which we can treat with regenerative therapy?
Hello, I'm Dr. Sudhir Mishra. Regenerative therapy is actually, there are so many conditions. As the age progresses, our regeneration process is a normal process that continues, start from the childhood, it continues. But as soon as after a particular age, the regeneration process reduces, and after a particular time, after the age of 50 or 60, the regeneration process stops. So it went to the degeneration. So all the joints and means any degenerative joint,
You meant to say osteoarthritis.
Spondylitis, lumbar spondylitis, and along with that, the regenerative therapy is used for the treatment of any rupture of tendon, muscles. Even it has been tried in bones also, but effects are not that good, but it is very good in tendon, muscles, and even for degenerative process, old age problems, it helps. So there are many conditions, age-related, many conditions are there.
Now it's coming in a big way in sports medicine also, no?
Yes.
There is a definitely role, yeah.
Musculoskeletal trauma.
Yes.
That musculoskeletal injury at the level of bone, ligament, muscle, everywhere after a particular regeneration process becomes slow. The only thing which we do with the regenerative medicine, we increase or improve the regeneration process, and simultaneously we reduce the edema and other things with the other drugs.
Yes. Dr. Ashok, what is prolotherapy and what are the clinical conditions in which it can be utilized?
Actually, prolotherapy, as you know, has been there for so long. So prolotherapy basically means to, it actually mimics our repair process. Like you put some dextrose or something, it mimics our, because it induces inflammation and it actually aids in the repair and you won't say regeneration, but it aids in the repair in our own body mechanism.
Okay, so is there any particular concentration of dextrose that produces inflammation, that induces inflammation?
Yeah, but I don't have a very good experience in prolotherapy. But since we started, we have been using PRB and other things. Maybe those who have.
Yes, more than 10% dextrose, it acts as a irritant and it produces inflammation, and less than 10%, it behaves just as a sugar solution. Yes.
We had done one study comparing the 12.5% with the 25% dextrose in cases of osteoarthritis. So initially the effects, if we consider the duration of the action, the 25% was found more superior than the 12.5. But the initial effect was okay with both the things, but after 6 months, the effect of 25% lasts longer.
Okay.
So 25% is also a good, can be used. And as per our study, we got good result.
So you have used it intra-articular or peri-articular?
Intra-articular.
Intra-articular. So you use this peri-articular also?
Peri-articular
Just
we had
intra-articular.
used not for the osteoarthritis, we had used for the sacroiliac joint pain.
Okay, for peri-articular application, and you got.
But we had not done the study between the two, but we had used that, the effect was good.
Okay, so in your experience, it was good.
Not in diabetic patient. That was the exclusion criteria. So that everything to be considered.
That has to be keep in the mind. Yes.
Regenerative therapy, patient selection is the most important. If you select correct patient at correct time, your result will be very good.
So what about tendinopathies? Has any of the panelists have got experience of using prolotherapy in tendinopathies?
Yes, even those patients who can't afford or they are not willing for the PRP, in tendinopathy also it is good, but requires the multiple injection. And in cases of PRP, single injection was very well.
Okay, fine. So prolotherapy, yes, as far as I am concerned, we used to do it 10 years back, but we left it now. Now the literature is coming up with the use of prolotherapy. So now we are giving it a trial again. So let's see. I think many more studies are needed to get the real picture of using prolotherapy in. Yes, please.
That pain can be SOS medication. If you can give the tramadol or any this paracetamol, if he is having more pain. Usually what I had done, we given the tramadol for few days. With that week, and simultaneously we had kept the pill count also. During the study, we had kept the pill count also, how much drug he had taken during that duration. So that initial a week, the pain is as per the nature also. It causes pro-inflammatory therapy. So it causes the inflammation, pain will increase. But you have to counsel the patient. Patient education play a very vital role in this patient. They should be before enrolling or before giving treatment, you should educate the patient what the problem he will face.
So, after how many days patient gets real pain relief after prolotherapy?
10 to 15 days. It depends on the patient. Few patient actually thing is that the pain tolerance of each individual is different.
patient psychology also you have to think how to manage that. I would like to suggest one thing. You see, when you want to give regeneration in a tissue, you should prefer a method which creates the least pain to the patient, because we are in a pain conference and our aim is to reduce the pain of the patient, miseries of the patient. And in my personal experience of hundreds of cases, I think the least pain is done when you give intra-articular cord-derived stem cells or the PRP, and more pain is than in bone marrow derived cells, and maximum pain in prolotherapy.
Prolotherapy. Yes, I remember that. The problem with the prolotherapy is because it produces inflammation, and you cannot give anti-inflammatory drug because this is what the basis of action of prolotherapy. So I remember that I used to give only paracetamol to the patient. So it was, for 1 week it was very painful to the patient. So this is to be kept in mind.
One thing I want to say is actually all the patient who's coming for pain relief, they expect immediate pain relief. So it is the pre-counseling that is very important. You should say that this is how the pro-inflammatory therapies work. You will have the most common complication is the soreness or stiffness on the area. You will have it for maybe a week or two. You will be get controlled by tramadol or such. We will control the pain, and after that you will be okay. So the pre-counseling is, I think, it's needed. Otherwise, when the pain persists, then it will the patient gets annoyed, and it will be a big problem. So counseling is a must before going for pro-inflammatory therapies.
Yeah, sure. Dr. Ashok, I would like to ask you, what is the method of preparation of PRP, and what should be ideal attributes of a PRP for chronic pain management?
Yeah, actually the method of preparation of PRP has come from a long way, where we used previously used a centrifuge machine, and we draw the patient autologous blood, and we do it in a lab centrifuge or something like that. But now it has become easier. We have a lot of commercial kits that are available. So what we use is one of our commercial kit where we draw 15 ml of blood. We put it in that centrifuge, and we when 12,000 with the RPM, the set RPM, we do it for 12 minutes, and then we take it. There is a provision in the kit itself where you can screw it and lock the WBCs and RBCs down, and we can lock it. After that, we can introduce the syringe and take the platelet response. And now I have seen in this conference there is one company that's saying that they have a gel tape which actually capture the WBCs and RBCs, so there won't be much of mixing. So it is a simple technical procedure only, but as the commercial kits become more and more advanced, I think we will get very leukocyte poor, or even maybe we can't make it a leukocyte, but leukocyte poor PRP can be derived, and it will minimize our complication that we will encounter.
So there is a debate between leukocyte-rich PRP and leukocyte-poor PRP. So, Dr. Rajput, I would like to ask you, which works best, leukocyte-rich or leukocyte-poor?
You see, for intra-articular, it is always said that you should use leukocyte-poor, and for other like tendinitis, fasciitis, other things, you should use, even for shoulders, you should use leukocyte-rich PRP. And secondly, one more thing I want to say, that if these PRP preparations are done in a particular temperature, like in a particular cold PRP we call it, there the quality of PRP would be better, and the results would be much more without causing much discomfort to the patient. And since I prefer to use stem cells in most of our cases, so PRP I use just for the beginning of the arthritis or like that. If when stage 2 is there, then I would prefer to give PRP plus stem cells and even hyaluronic acid. as a lubricator. This combination of all the three becomes the essential cocktail for the regeneration. What is the essential cocktail? That is the cell component, growth factor, and the matrix. So if you think always this regenerative protocol, where you take care of all these components, then your results would be definitely better.
So we can combine, yes please.
So I have a comment to make on leukocyte rich versus leukocyte poor. What Dr. Rajput said is correct in terms of pain only, that leukocyte rich will cause more pain and leukocyte poor will cause less pain. But if we talk about the efficacy part, there are studies published in American Journal of Sports Medicine and Orthopedic Journal of Sports Medicine, specifically on both knee OA as well as lateral epicondylitis. They say efficacy wise, if you use leukocyte poor or leukocyte rich, there is no difference. But one thing to always watch for in leukocyte poor is the platelet count is directly proportional to the WBC count. So if you are trying to deplete WBCs, you are also depleting the platelet count. So you have to still make sure that your platelet count remains in 5 to 7 times compared to the baseline level for PRP to actually work.
Yes,
definitely you are right. But you see, it is still very controversial. Some meta-analysis are saying on one side, another meta-analysis is saying on the other side. And there was some gentleman from PGI Chandigarh and who published the data and said that definitely for the joints it should be PRP, the leukocyte pool.
Even I have published just one study recently in which I have used leukocyte rich PRP in knee OA patient, but in the earlier stages, and I found good efficacy up to 6 months in this patient. So this is contrary to what the literature is saying, but still I think we have to find out the literature by doing more and more studies.
I think the issue is most of the literature out on the PRP is short to mid-term follow-up. We really have nothing which does it for the long term with adequately powered studies.
Yes, and there is also ambiguity regarding definition of leukocyte rich or leukocyte poor PRP. In the different literature, you will find different definitions. If one study label it, that is number of leukocytes, and one other study label it, is how times the leukocytes gets accumulated in the plasma. So the literature is not uniform, so that's why there is a difficulty in applying these kind of guidelines in your patients. Okay, Dr. Krishna, what protocol do you follow for your patients regarding PRP therapy, like for suppose knee OA patients?
So I also always give the leukocyte poor PRP and normally up to grade 2. And if it's a grade 2, a bit of advance also, I am also giving more of the stem cell autologous than the PRP for the knee OA. But otherwise, other places, for other places like shoulder, all the tendinopathy, then tennis elbow, plantar fascia, the excellent result with the PRP. Excellent. Even one dose is enough. And I always give ultrasound guided. We also take the ready-made kits are available, commercial, and those are good. And I always take. And first dose I give, and then I ask the patient after 24 hours he can move. First day ice application, after that hot compression, and sometime it may be painful. We have got 3-4 patients where actually we readmit and take out the fluid because it was so inflammatory and pain. But those were the where we have not done the leukocyte poor. We have done that, and then for OA I usually repeat after 1 month, second dose, and
irrespective of the pain relief. Irrespective of the pain relief.
Same, yeah. Okay. Then sometimes third dose also, and with the first dose I also give the hyaluronic acid. Okay. With the first dose.
So is there
not for the second and third. Second and third I give only the PRP.
So is there any clinical factors you consider for repeating your injections, PRP therapy? Some patients' factors you consider?
Patient factors, of course, not very late age, like 65 plus. I don't prefer to give the PRP. The early stage, and stage also up to grade 2. And if I give grade 3 because of the patient, I'm in private practice also. So if the patient wants, then I always tell the guarded result. I never assure the patient that you will get the 100% benefit. So I always tell that you may get, you may not. So we always ask them not to take anti-inflammatory for 1 week. No anti-inflammatory, and even no Ayurvedic and no homeopathic. I always tell, because I don't know what they carry.
Yes.
And these people are lot of, on Ayurvedic, allopathic, lot of oils. So I always tell after my treatment, don't do all this thing. Only you can take paracetamol or Tylenol.
So these all things have to be kept in your mind. Yes, please.
Can you please explain about the method of preparation of stem cells from the ISPC?
Yes, we will come on that part.
I just am, as you said too, there is a lot of discrepancy on the definition of leukocyte poor. So when you, Dr. Podar, use it in your practice, how do you define what is leukocyte poor? Is it like maintaining levels to baseline, or you using a leukodepletion filter to actually get rid of leukocytes?
Actually, I think those kits are available ready. What they say is the leukocyte get down.
No. Now they issue a filter.
Yes.
And when the final product is ready, just you pass through it, and it will be depleted from the leukocytes. Yeah. But it might deplete some stem cells are also retained in that. That is the disadvantage of it.
Actually, one more thing is quality control. Actually, in my institute, the Department of Transfusion Medicine, they make PRP. So we are not making PRP. So every time they make PRP, they do the cell count of that PRP.
Yes,
How many platelets are there? Leukocytes there? What is the concentration of leukocytes? Only when pre-specified criteria is met, only then they issue PRP to us for the patient. So those who are using commercial kits or using a laboratory centrifuge, so they can do time to time the quality check of your PRP preparation.
That is very important actually, the count. And because see, at present, all over the world, not even India, everywhere there is no standardization for all these products.
Sure.
Everything is new, there is no standardization. They have the different, some people use the different thing, ACD, some use the citrate, some use the something. The machines are different. People using 10 ml, someone is using 25, someone 50 ml. So there is no standardization. So it is now required, we should go, there is a standard methods to prepare the PRP where we can tell this count will come, 3 plus or the 5 times.
But
So
you
this
see,
is very, very important.
when you are going to use the autologous blood, and the same kit is being used in different patients, the outcome is going to be different.
Yes, that is also one factor. Because everyone has a different platelet count also. And I always do this platelet count also before doing the PRP of the patients.
Okay.
Because I don't know what they originally count, and then no point.
Okay, Dr. Ashok, what is activated versus inactivated PRP, and what do you think, what should be used and what agent can be used for that?
Actually, we go for that activated activated PRP. That is what I use in my clinical practice.
Okay, in all clinical conditions like OA, tendinopathies,
Yeah, we do actually, we concentrate more on OA&E and tendinopathies. So we do activated in OA&E and tendinopathies. That is to a clinical condition in our institute we do.
So what agent do you use for that?
Actually, that's what it is more often. It's a commercial preparation. It comes with it. So we get 2-3 commercial preparations. So we don't do it ourselves. So it's a commercial preparation that comes with it. So we go by that.
So it's basically calcium chloride or calcium.
Yes, calcium chloride is being used for that.
Chloride is used to activate.
If you activate, then there is a time window is very important. Once you activate your PRP, you have to give that PRP immediately to the patient.
But actually, when we inject PRP, they activate it in the body and they release the growth factor.
Yes.
So mostly no point of doing activation out of the body.
Because collagen is also activator of the PRP. So if you are using it in a joint, so some studies suggest that there is no need for activation of PRP. But as Dr. Ashok has got, I think, good experience of using that. consider that as well. Dr. Sudhir, how safe is PRP and what could be the potential side effect or complication of use? Because till now we have been talking about benefits, advantages of PRP, but what could go wrong with PRP therapy? This should be discussed as well.
We have done 2 studies. The PRP usually is prepared in transfusion medicine only. We had used that, and for the osteoarthritis grade 2 and grade 3, as well as for the kind of patient, we had used for both. We had not found any side effect in both the studies. What I feel any side effect that would have occurred is due to your technique as well as the preparation, how you prepare. Fault can be during the technique, not in the PRP. So if you correct your technique, if you select your patient well, aseptic precaution while injecting, aseptic precaution while collecting the blood, and aseptic precaution while doing the procedure and developing the PRP is very good. Even as I am a PMR physician, so along with in OA patient, along with the PRP, we consider other things also. Modify the activities also, patient activity, how he is working, how his daily activity, squatting, cross leg sitting, all these degenerative diseases, and along with that, how much daily work pattern and environmental modification play very vital role in the old age patient.
Okay, in enhancing the effectiveness of PRP.
Enhancing the effectiveness, and the aim is to prevent the re-injury. Whatever regeneration we achieve with our therapy, it should be maintained, it should not lose. So the duration of effect remain longer.
Okay,
if you don't modify the activity, the duration effect will go, and finally the patient will end up in the further grade, and will not come back to you and go for the knee replacement.
So because it's an autologous product, so there are minimal chances of any severe complication or adverse effect with PRP. Okay, so this is the take home message. You can very well utilize in your patient. So Dr. Rajput, what are mesenchymal stem cells and how they are helpful in regenerative therapy? I think you have answered it partly, but I would like to discuss it further.
Yeah, you see, when we see these mesenchymal stem cells, these are basically mesenchymal stromal cells, and this is also called the adult variety of the stem cell, which is non-hematopoietic. Okay, so in the blood, stromal cells, it has the quality that these are HLA privileged cells, means there is no HLA loci, so it doesn't react. It can be taken from anyone, it can be given to anyone, so that is the beauty. And it has certain markers, and there is a criteria of marker like CD90, CD105 that should be positive, and HLA-DR negative, CD34 negative. Okay, so these are the mesenchymal stem cells which we normally source in the practice from, right from blood, placental blood, cord tissue, and bone marrow, and even neural tissue also, and fat also. So in such cases, you see, this mesenchymal stromal cell has become the very important tool of treatment for the degenerative conditions, because it has very good quality of tissue regeneration. And even after allogenic transplants, they do their work and come out of the body within 3 to 6 weeks. They hardly remain in the body. They will just activate your dormant stem cells
and give the paracrine effect and come out of the body. Okay? And it can be used in various musculoskeletal conditions and so many other conditions which are coming up, right from metabolic diseases to even lifestyle diseases.
Okay, so what actually these MSCs are doing in the body? I mean, are they really regenerating, or are they just taking care of pain?
You see, when we give it in the body, these cells, number one, they work by the effect of the paracrine activation. So a lot of growth factors are released in the body and they start the tissue regeneration. Secondly, they activate the dormant stem cells, as I told you. Like in the muscles, they will activate the satellite cells. Okay, to make a new muscle formation. Okay, they don't directly convert to the particular type of the cell. If it is allogenic, autologous can convert. So they will go initially reduce the inflammation, so they work like anti-inflammatory. Then they will work like the immunomodulatory, and then increase the vascularity and tissue regeneration. These four things are basic works of the mesenchymal stem cells.
So what I get is that in muscle injury or tendinopathies, they do regeneration.
Yeah.
And what about osteoarthritis? Because majority of the patients are of osteoarthritis in old age. So is it really growing that hyaline cartilage or not?
Yeah, definitely it helps in the growth of the cartilage. And as I told you earlier, if you are using autologous cells, definitely it is going to be converted into the cardiocytes, cartilage cells. But if it is allogenic, it will just activate the formation of a cartilage.
Okay. As per my knowledge, in the literature, right now, the literature is saying that in OA patients, it is taking care of pain, but when the patients are getting post-procedure MRIs, they do not show increase in the thickness of the hyaline cartilage. So I think we need more studies and literature regarding that, and if all the researchers, they started using MSCs more often and do studies, most likely we will get more evidence for that. Yes, please.
You can say that definitely repair is limited in the meniscus, but as far as the osteoarthritis is concerned, a lot of breach is there in the cartilage layer. Okay, and once there is a formation of the very thin, even in fraction of the millimeters, the cartilage is formed, you will see that the pain has come down drastically. And in the follow-up MRI, you will find there is subchondral cyst has disappeared. So I have got a series of the patients where I showed that after successive months, maybe after a year, when I got the repeat MRI, there was no subchondral cyst. And the space, intra-articular space was also increased in the medial compartment. So this all show that there is some cartilage formation and taking care of the subchondral cyst. So repair process is also there and sealing of the chondral defect is there. So until unless you make the new cells, you cannot seal it.
Yes, so definitely that I think it should be published, sir, so that the medical community should know about it.
I have the publication, international publications, several, where I have showed my results. And this is coming up through various researchers. Yeah.
So any other panelists want to add something over this?
No much experience.
Okay. So what are the potential sources of MSC?
As I told you, that normally we, in the clinical practice, we use either blood Control Act, in which these MSCs were taken as drugs, then we focused on the autologous cells. And since then, we are more focusing on the bone marrow and the fat. And the fat cells, we are just doing the liposuction and processing them with the Australian patented technology, where the ultrasonic cavitation method is there, and that is giving excellent results to the patients. And from the bone marrow, you can take the autologous from the bone marrow, and even allogenic is available as a product, pharmacological product. It is being sold by company.
So, sir, what is the status of MSC therapy in India? I mean, if a pain physician wants to do MSC therapy, how he can go about it?
He has both the options of the bone marrow and the fat. And
actually machines are available for preparation.
So machines are available for preparation. Is any pre-formed MSCs are available in the market?
Cells are MSCs only, which are being provided in the vial of 25 million vial, 25 million cells in the single vial.
So this is for the information of audience that.
Yeah, adipose is definitely better. Adipose is much better.
But adipose preparation machines are also available, that ultrasonic cavitations.
So machines are available, pre-formed MSCs are available for use, so which you can utilize for your patients. So what are the safety concerns of MSC therapy? Is there any safety concerns we need to worry
You see, with the MSC, only one thing you need to keep in mind: if patient is already having some malignancy, okay, you should avoid doing it. Okay.
Okay.
And especially you should not use these MSCs systemically.
So they have to be injected locally.
For if patient are on therapies like cancer therapies or radiation, people say you should not do the regenerative therapy.
Okay. Any side effect of MSC therapy?
Pardon?
Any side effects of MSC therapy later on to the patients, which you have observed?
You see, no. You see, in MSCs, as I told you, if there is existing malignancy, there are chances of flare-up. Okay, so that is the only thing you have to take care. Or otherwise, I have used thousands of cases where these MSCs were used. No one has complained.
There were no major side effects.
No.
You have not observed that. Okay. Now, low back pain is a very important entity area for us. So, what do you think, panelists? What is the role of regenerative therapy for low back pain patients?
Yeah, it's actually very important in spine also, because the degenerative disc disease is a very common thing for the low back pain, and whatever you do is very difficult to treat them. So we can even use the intradiscal this is stem cells or the autologous mesenchymal cells or the PRP also. People are using PRP, but the only thing what I got one or two patients problem, whenever you are using in a spine, you should be very, very careful about the sterility, because PRP what we prepare is the machine is outside, and that vials we keep and take out any breach in the any sterility, then it can cause the discitis. Otherwise it is very good. Even for the facet orthopathy, of course the median nerve RF we do, but sometimes they don't respond. Then even the peri joint, if you give this PRP or the stem cell, they are very useful. Even patients are, few people are giving the transforaminal epidural also, but the most important, these are the two uses where intradiscal, for the disc degeneration it is very, very good. But the only thing is that you have to be very, very particular about the sterility, because discitis then can be a a nightmare for you again. So you have to be very, very careful. Evidence, a lot of evidence. Lot of evidence for the spine. In US, the people are using a lot. Here also, few people are using a lot for the spine. So there are a lot of paper publication. OA, see, first of all, both the diseases are different in the spine, but there is results are good in spine also. But OA actually, as you are not concerned about so much of the discitis or any infection, so not so severe as that, because in a spine it is really very difficult. You have to be very, you should have good control over it. So OA for everyone is using, and it's for long time we are injecting in his knee. So we have no fear. But when you do the spine, even I'm doing for long time the ozone as a prolotherapy for the spine, the interdiscal for this region. I never got a single discitis. But for the PRP, I don't know whether it is because I also got one patient who suffered with the discitis after the PRP. So I'm very susceptible. Stem cell I have not used, but I have planned to use, but I must get the good patient for it.
So we need to publish more, so that the evidence can be generated. One must, because we are hard pressed for the time, so I'm going to ask just my last question. So what is the future of these therapies in India for chronic pain management?
Big future.
So is it just a hype, or are we really progressing something, exciting in our field?
Actually, what is happening, everything comes with the price. Like, if physicians they know this is a particular indication, maybe being pain physician we use for pain, but many different specialists are using for different problems, giving some may give the good assurance but not getting result. So in US actually particularly they have banned now. They started in a big way, but now starting ban also. So I don't know about the future. If anything is misused by any means, then it will come with again a ban. Otherwise, it's really giving good result at present. That I can say.
Thank you all my panelists. That was a very nice discussion we had. Thank you very much.
Thank you everyone for such an informative discussion. Now I would like to request Dr. Sandeep Kuba sir to felicitate our panelists. Dr. B.S. Rajput, Dr. Krishna Podar, Dr. D. Ashok Kumar, Dr. Sudhir N. Mishra, now I would invite Dr. Manish Singh sir to felicitate Dr. Sandeep Kuba sir.
Can I give
next session asks us a very important question. How do I do it? To make things simple, I request Dr. Krishna Podar ma'am, Dr. Nanadin Murkhan sir, Dr. Ajay Chaudhary sir to take their respective seat on the dais.
We'll start the session. The first speaker would like to call upon Dr. Vishnu Kumar. He will talk on fluoroscopic anatomy of spine, clinical aspect, lumbar spine.
Very good afternoon, everyone. Thank you very much for the opportunity. Today I'll be talking on fluoroscopic anatomy of the lumbar spine. So can I proceed? Yes, sir. So my topic is very basic. First I'll be dealing with the basic anatomy and then few common interventions regarding the clinical aspects. So before going to the fluoroscopic anatomy per se, we have to know the basics of the CM. And more importantly, the source, radiation and reduction, the usage of timing, usage of collimation, shielding, distance and the fluoroparameters has to be considered. And first let us go to the topic per se, and this is the AP view where we have pointed view. So we have
You can use the cursor meanwhile.
yes, sir. Okay, sir. So we have got an X-ray tube down, and we have got an intensifier image intensifier above, and we are going to get an AP view. Whatever procedure that you are going to do, first start counting the vertebra, and you see always you count from above to below. So the 12th thoracic vertebra has got a false rib, and now you can count 1, 2, 3, 4, 5. So this is how we have to count, and there are some variation to this. Here there is lumbarization of S1 vertebra where you have like 6 vertebral bodies. So here as you count L1, L2, L3, L4, L5, L6. It's not L6 basically, it is S1. There is a failure in the fusion of the first and second sacral arches. But here in the sacralization of the S5 vertebra, what happens? We will be getting 4 lumbar vertebra only. The 5th lumbar vertebra will be fused with the S1. So counting of lumbar vertebra is at most important before you are going to do any procedure. Next thing is obtaining a true AP and lateral view. This process is called as centralization. So you are taking an AP image, you always have to make sure that you are going to bring the spinous process in the straight line. So this is called as the centralization. More specifically, when you do in the L5 interventions or S1 interventions, so you have to make the iliopectineal line. When you take a lateral view, you have to make sure that the iliopectineal line are parallel to each other. So it should not be like this. Can you see here? The iliopectineal line is superimposed and it is parallel to each other. So now this is what a CM image that you will be getting. This is an AP view, and in the AP view, these box-like structures are the vertebral bodies L1 to L5, and in between the vertebral bodies, you will be having the disc, intervertebral disc. And this rounded structures which is being marked here is the pedicle. Pedicle you cannot cannot see in the AP view. Actually, in the normal anatomy, you will be seeing in the superior view or in the lateral view. So this is a thick bone. Because of this thickness, you represent this pedicle is being represented as a circular structure, and this pedicle is more important in doing many interventions, as we will see further. And here you can see the inferior articular facet and the superior articular facet of the L1 and L2. So as we go down, the sagittal orientation of the facet slowly turns out into be a oblique. So as you see, between the L5 and S1, it is very oblique in nature. So again, here we have a lateral margin of the lamina. Lamina is the posterior border of the vertebral body. So which is being painted here in violet color, and here you can see the X-ray picture of the lamina. And this is the superior margin which I have marked, and this is the inferior margin. So between the superior and the inferior margin, you will have interlaminar window. And identifying this interlaminar window is extremely important whenever you are going to do a neuromodulation, when you are placing a lead placement, or when you are going to do an interlaminar epidural in a difficult case, for example in an obese patient or in a patient with rheumatoid arthritis or ankylosing spondylitis, it is going to be different. And now here in the center, these cone-shaped structures are the spinous processes, and transverse processes, if you see, the L3 transverse process is long, short is L4, and thick is L5. Remember this point when we discuss the endoscopic discectomy later. So in the lateral view, if you see, this is the image that is being obtained, and here you can see the vertebral bodies, and behind the vertebral bodies, here you can see the pedicle, and from the pedicle we have superior articular process, and then the inferior articular process, and this is the foramen. So in the lateral view, here you can see just behind the pedicle, this is the transverse process. So whenever you are going to give a facet block, the process, knowing the transverse process is extremely important. And these are the spinous process which is being highlighted. And now coming to the concept of squaring. So when the patient is lying in an AP view, this is how your X-ray is like. So your X-ray images are coming down parallelly. And now if you see, the X-ray images will be parallel to your L3 vertebra. And if you want to do some interventions in your L4 vertebra, the X-ray image is not parallel to the L4. So you will be getting two shades. So as you see in this image, the L3 vertebra is, the end plates of the L3 vertebra is coming as a single line. This is called as squaring. Okay, but if you want to if you want to square the L4 vertebra, then what you have to do? You have to take a cranial tilt so that your image will come this way. Okay, did you understand? That is called as squaring. Now you take a cranial tilt, and now the image will become parallel to the L4 vertebra, and now you can get squaring. So now you can see the squaring of the L4 vertebra. So first, whenever you do a procedure, always count the vertebra. Next, centralization, obtaining a true AP view, identification of parts. Then you have to do a squaring, and some people call as parallelization. What do you mean by parallelization? Like when the adjacent end plates, if they are appearing as one single line, then it is called as parallelization. But mostly we coin a term squaring, which means that the body, the end plates of that vertebral body should appear as one single line. And this is the oblique view. Whenever you are taking an oblique view, please remember that your junction of the inferior and the superior articular process should be exactly in the midline. It should not be in this way. This is absolutely wrong. Please take it in this way and get a Scotty dog picture. The most important is okay. Here is formed by the superior articular process. The nose is being formed by the transverse process. Okay, and then the eye is formed by the pedicle. So remember these three things: ear, nose, eye, and this neck is formed by the pars interarticularis. So the main purpose of viewing an oblique view is to just to see the integrity of the pars interarticularis. Many patients will say, sir, I am getting pain only on sitting, and you do nothing, you will be identifying. You do a flexion extension, even you cannot identify, because the subcutaneous fat is going to suppress this spondylolysis. So in that case, ask them to get an oblique view can check the integrity of the pars intra-articularis, and many just bring them off. So this is how you will get an oblique view. Here you have got the vertebral body and the pedicle, which is round. And this is the important thing. The ear is formed by the superior articular process, and the nose is formed by the transverse process, and between them you have a pedicle. And down as we go, we have pars intra-articularis, and foreleg is formed by the inferior articular process. So this is the most important point for oblique view. So the first, once I finished my residency, I had most problem doing facet MIPSI, especially radio frequency ablation. So I just wanted to, and this is the pertinent anatomy. So here, as you take an AP view, this is how your spinal nerve comes out, and then it branches off. So now, whenever you do a fluoroscopy guided diagnostic block branch, what you do, you take an oblique image, maybe around 25 to 30 degree. So you get a squatty dog appearance, and at the junction of the neck and the neck of the SAP and the SAP and the transverse process. Here we have got the medial branch. You can see that has been drawn in a line. You have to target that point, and you will be giving your injections, and you can give your diagnostic local diagnostic block. So this is how it looks in an AP view, exactly the junction of the SAP and the transverse process, and this is how it looks in the lateral view. And now, when you want to give an facet joint injection, always, as I told you, keep your facet joint exactly in the center of the disc, and make sure you are giving your injection in the center of the joint. Okay, this is how it is going to be. And this is the anatomic dissection. Here you can see the median branch. Whenever you do median branch RF ablation, please note you will be getting an effective relief of more than 1 year if you are properly placing your needle. Because sometimes you do a median branch block and you will be getting an effect only for 1 month. That is because the culprit is mammallo-axillary ligament. You can see here, there is something called mammallo-axillary ligament, MAL. So beneath this only, your median branch goes on. Okay, so whenever you are doing an RF ablation, what is going to happen? You are burning the ligament, but you are partially burning this median branch and leaving it off, so that the patient is going to come out with the complaints of pain after 1 month. So ideal placement of the electrode should be above mammallo-axillary ligament. So purposefully I have placed this one. So this is a diagnostic block procedure we normally do. And here you can see the medial branch block here, and this has been covered with ligament. Okay, and this is the accessible segment of the that you have to target when you are going to do an ablation. So how we are going to access it, that is very important, and this is the desirable placement of the electrode. You are not going to touch the MAL, and this is how it should be in the lateral view above the MAL. So previously what we were doing, we were placing at the base of the transverse process. No, the tip should always lie at the neck of the transverse process. So see here, it should be of the transverse process. This is how I used to do an RF needle place. Because if you keep like this is the superior articular process and the transverse process. You take an AP view, you cannot keep your needle like this. So you have to oblique and bit cranial. You create a bed, so that once you place an RF needle, what happens? Exactly, your nerve is being burnt. This is what, now can you picturize this along with my picture? So I am just putting my needle from the medial end to the lateral end, and then again I am taking an AP view. You can burn your medial branch like you can get your stimulation 100%. More than one. It's not parallel to the nerve. You have to keep it cross. Okay, you have to keep it cross. So your RF needle should be exactly at the neck of the SAP to get an optimum result. Now did you understand? Like, just by knowing the anatomy, you can manipulate the fluoroscopic images, because the fluoroscopic images are just 2-dimensional. So we have to interpret an lateral view, oblique view, so that we have to imagine it as a 3-dimensional figure and bring it. Okay. The second common thing is transforaminal MIPSI. So some will be doing subpedicular approach, some will be doing Campbell's triangle approach. So whatever it is. So Campbell's triangle. So again L4, L5. just squaring it off. You are finding the junction between the SAP and the transverse process. At the junction, you are just keeping your needle and sorry. Then you take in a AP view, okay? AP and in the lateral view. So when you in the lateral view, if you see the foramen, your tip of the needle should lie in the posterior inferior quadrant of the foramen. Suppose if you divide the foramen into 4 parts, in the lateral view, you are dividing into 4 parts, okay? Superior, inferior, anterior and posterior. So the needle tip, when you are approaching a Camden's triangle, it should be in the posterior inferior quadrant. And here you can see the excellent eye spread, which is going to cover both the exiting and the traversing nerve. But that is something different with the subpedicular approach. And here in the subpedicular approach, again you are taking an oblique view. Here you can see in the first image, you are just keeping your needle just at the midpoint of the pedicle. And then once you take an AP view, you are just introducing the needle subsequently. And in lateral view, the needle should be in the anterior superior quadrant. Okay. And once you give the drug, here you can see the drug is going along the nerve root. So why many are avoiding the subpedicular approach? The reason is that damage to the radicular artery. You are giving a depometrol, and what happens if there is an ischemia to the radicular artery? Of course, they can cause paraplegia as well. Okay. So the next, fluoroscopic anatomy and its relevance to the pedicle. This we discuss when we more, but please have this idea. And when we discuss regarding the endoscopic discectomy, you will come to know. So this is the pedicle portion. So the portion between, so this is the pedicle here, and here you have got a pedicle here. So this is the foraminal zone, okay? And in the lateral view, this is the pedicle, okay? And this is the foraminal zone, okay? So now, just watch for this blue line. If I am introducing the needle in the lateral view, sir, just 2-3 minutes more. Introducing the needle in the lateral, AP view, and if my tip of the needle is in the lateral pedicular line, and if I take the same image in the lateral view, it should be in the posterior pedicular line in the AP view. Can you imagine it? And the same thing, just follow the orange line. If I am keeping my needle in the medial pedicular line, at the level of medial pedicular line in the AP view, in the lateral view, if I observe the same needle, it should be here in the anterior pedicular line. Okay, so can you see here in this images, my needle tip is in the medial pedicular line, and when I take a lateral view, it is in the anterior pedicular line, that is in the anterior foraminal zone. Okay, so next is interlaminar epidural nipsy. So whenever you want to do a lead placement, so what you have to do is, ideally you have to take your take the caudal tilt of the CM. See why you are going to take a caudal tilt, because I have to just want to emphasize on this image. So once you take this caudal image, basically your interlaminar window widens. So whenever you want to do an L5S1 interlaminar endoscopic discectomy, this is very useful. And if you want to insert a lead placement during a spinal cord stimulation procedure, again this is very useful. So I had a very obese patient. The patient was like around 150 kgs. And like we people used to give like blindly all epidural thing. But for this patient, it was I was not able to do, and I have lost my practice also. Then what I did, she was having a spondylolysis, and I wanted her to give, and especially on the left side. So under fluoroscopy, like how you do for a cervical epidural steroid, how you take a contralateral oblique view, same thing you can apply for low back region as well. Increase the interlaminar window, which side you want to target, you just put the epidural needle directly using LOR, you can do it, or you take a contralateral oblique view. We do have a ventral intralaminar line, and as you get this pop off, you can give the knife, and you can see the dye spread. It is very excellent, and the patient got excellent relief after this procedure. And again, this is how the discography is done. Similarly, how you do for facet joint injection, as I told you, you just keep your facet joint, take an oblique view, the facet joint should be in the center of the disc, you keep the needle in the Camden's triangle, just come to the AP view, your tip of the needle should be in the center of the disc, and take the lateral view, and here you can see this patient was suffering from chemical radiculitis. The patient's MRI was absolutely fine. The patient was having severe electric shock-like sensation along S1. This, I did a discography, and then I told him, and then I gave a distal Gore blocks. I did not give anything intradiscal because I just wanted to he is literally suffering from radiculitis. And this is how the lumbar sympathetic block works. You just take an oblique view to make sure that the tip of the transverse process just closes off within the vertebral body, and take a lateral view. Here you can see the spread at the level of L3. And the similar thing applies for the superior hypoglastic plexus as well. So take an oblique view at the level of L5S1. This was the first case which I did when I was doing PDCC in SGPJ. So still I keep this reference image while doing a superior hypogastric plexus block. So bilateral you can do, and this is one of the thing for spinal cord stimulation which I did for chronic pelvic pain case. I have targeted the level of, I placed my needle at the level of T10, okay? I'm sorry sir. Right, so okay, after knowing the fluoroscopic anatomy, you have to optimize the needle trajectory to get an end-on view, that is the gun barrel view. And once you get that, keep the needle in the proper endpoint, and after adequate dye spread or after appropriate stimulation, whatever you do, it is going to give you a 100% result. So thank you all around.
Thank you, Dr. Vishnu. Very nice presentation.
Thank you. Now we have the second lecture, Dr. Rampal Singh. He will have presentation on the cervical facial intervention MIPSI. Yes, please.
Good afternoon all, and good afternoon Madam Chairpersons, and thank you Dr. Sarita ma'am and Department of Anesthesiology for giving us here this opportunity. So coming to the cervical facet interventions, MIPSI, how do I do it? So this was a case of a 40 years female patient, housebreaker by occupation and belonging to the low socioeconomic strata. She presented to us with complaint of left-sided neck pain, which was referring to the half of the shoulder downside and occipital area more than 1 year. She also had a history of weight bearing on the neck. And this was the area. This was the area of pain referral pattern. So on examination, there was tenderness on mid side of the neck. On left side, the CAM test was positive, in which there is extension, side rotation, and downward pressure was positive. Sperling test was negative. There was no sign of radicular pain. So we did investigation in which there was TLC, DLC was within normal limit, ESR was 25, CRP was normal, RF factor was negative, and anti-CCP antibody test was also negative. So we think that there could be facet joint involvement, so we go for the diagnostic cervical medial branch block of C3 and C5, C4, C5 joint. So we found positive with 0.5 ml of 1% lignocaine and 0.5 ml of 0.25% bupropion at C3, C4, C5 medial branch at different time interval. 70 to 75% of the pain relief was found on both occasions for 60 minutes and 3 to 4 hours respectively with lignocaine and bupropion. So So we go for the C3, C4, C5 middle branch radio frequency ablation for C3, C4 and C4, C5 passive joint. So these were the drugs which are required. These are triamcinolone, lignocaine, bupropion, radio frequency ablation machine, and these are the 20 gauge thermocouple, iodine, and these aseptic precautions, and this thermocouple wire lead. So patient is taken under CRM guidance, patient under CRM guidance, and in prone position, these are the local anesthetic which were given, and all aseptic precautions are taken. And under this CRM guidance, in prone position, patient's cervical spine is visualized, and we turn the patient's head to contralateral side so that these lateral masses are visible well, and by obliquing, caudally obliquing the CR machine, these spaces are well identified here. And this is your lateral X-ray picture. This doesn't belong to the patient. This is the patient picture. So these are needle placement. Where in AP view, there is C3, C4, and C5 needle were placed at C3, C4, C5 middle branch, and this is at the C3, this is C4 and C5. ये अभी ठीक नहीं है, लेकिन हमने बाद में ठीक कर लिया. Actually, at this level, this was looking at this is right, but in lateral picture, it was going toward the C2. So we take it out, and then last we placed it. So this is C4 and C5 in lateral picture. This was at last we placed it at the C3. So after placing the needles, so testing is done for the sensory and motor stimulation, which is done with 20 gauge 10 centimeter 1 centimeter exposed radio frequency thermocouple. Sensory testing is done at 50 Hz with range of 0 to 0.5 volt, and motor stimulation is performed at 2 Hz with voltage range of up to 1 volt. So sensory stimulation is done how close you are to the sensory nerve, and motor stimulation is done how far you are from the motor component. If it is coming close, 1.5 ml of 0.25% bupropion mixed with 5 to 10 milligram of triamcinolone was given before doing after checking the sensory stimulation and before doing the RF, and 2 cycles of 2 minutes at 85 degrees centigrade at each level was done. So this is the small video. The screening for the facet joints. This is C3, C4 and C4, C5. This is the placement of the C3. sensory stimulation. We will check for the sensory stimulation. First for the C5 nerve, middle branch. This is the motor stimulation. This is for sensory stimulation. Actually इसमें आवाज आ रही है लेकिन घर आवाज नहीं आ रही, ये प्रॉब्लम है.
We are doing radio frequency ablation of C-core medial branch.
C4 middle branch. So it takes about 14 seconds to reach to desired temperature of 85 degrees centigrade. And you used to conversate the patient continuously for any complaint of the patient. And patient is having no problem as the anesthetic has been given. This is for C3 middle branch. जो हमने बाद में डाला है निडल को, पहले थोड़ा सा लेटरल व्यू में देखा था कि इट वाज गोइंग टू द C2.
Thank you very much for your kind attention.
Thank you.
Excellent presentation, Dr. Hampal. Any question?
Thank you. Our next speaker is Dr. V.K. Mohan sir. He He will talk on approach towards case of trigeminal neuralgia. Dr. Vicky Moore.
I'll be speaking about trigeminal neuralgia. Let's have a case. This is a 61-year-old male patient which are presented in our pain clinic. Was part of my occupation. He complained of left-sided facial pain over the mandible and the maxillary area and in front of the ear. And sometimes he says he can experience the pain in upper and lower teeth, and the severity of the pain is on a narrow scale on 9 to 10. And the character of pain is sudden, paroxysmal, short-lasting. He explained that it's like a shock light, like current is flowing in that area. And he gave a still that pain usually otherwise doing something like chewing, brushing, gargling, but somehow he was able to do shaving without any problem. And number of attacks, painful attacks, they range from 5 to 10 most of the time. And usually he told us relief from pain occurs spontaneously, and in between those attacks he had pain-free period. There is no history of numbness in the affected area of face, headache, photophobia, phonophobia. There is no history of lacrimation, nasal stuffness, redness of eye, tinnitus. And duration of pain is around 5 years and off and on, and past history, he has received dental clinic similar type pain. And in dental clinic, he was started with pharmacotherapy in terms of carbamazepine and duloxetine. During that treatment period, he has a good relief, but after that, he again go back to the dental surgery after around 2.5 months. Then the dental surgeon, they gave some nerve block with alcohol, but the relief was very short lasting, hardly last for 2 months. Then they referred the patient to neurology, and in neurology clinic he was investigated. They get MRI done and put on same medication with some adjustment, but patient had no relief. They had some relief, but in between those periods we had severe pain. Then neurology people referred the patient to pain clinic, and here we see the patients and investigate further in terms of biochemistry and all that. And as this patient already have MRI, we have a look on MRI, and the patient was consulted and explained the different modalities available for management of pain apart from pharmacotherapy and nerve blocks. And before I go for this, let's talk about trigeminal. What is trigeminal neuralgia? Trigeminal neuralgia is characterized by recurrent unilateral brief that will last for about few seconds to few minutes. It's very painful, electric shock-like pain episode in the trigeminal distribution, and it has very abrupt onset and termination. Sometimes you can have a trigger, and usually these patients, they usually have memory of having very first attack of this type of pain, and it's very disabling order, and it impacts the basic human function like talking, eating, drinking, and touching the face, and resulting very poor quality of life. Sometimes the patient is so afraid of taking meal and doing things that he had very poor hygiene, and because of that he had anxiety, depression, and sometimes the pain is severe and so problematic with patient, they have some suicidal tendency also. So in those patients, from diagnosis, investigation, and proper management is very important. The overall incidence is between 4 to 29 per 1 lakh people, and lifetime prevalence around 0.16%. And female are more susceptible, and female-male ratio around 3.2, and onset is usually described in the literature 53 to 57 complication. But in our clinic, in our present clinic, we have very younger patients also. Those are coming for trigeminal. Why old individual having this type of? Because of staining of brain and because of atherosclerosis of the artery. Though it's written in literature in uncommon, we experienced that even 20, we have one of our patients at 23-year-old, and we have very few patients that they are between 30 to 40 years of age. And this trigeminal is more common in right side. Why right side? In this few studies that say that foramen ovale, foramen rotundum are very small in right side compared to left side. That's why this incidence is more in right side. More common B2 division and combination of B2 and 3 is also there. And most of the time, around 80 to 90%, the patient have trigger zone. And most of the time, the patient, as I told you, they have experienced pain while chewing, brushing, tucking. Even movement of breeze of air can cause attack of the pain. Now, what is the diagnostic criteria of trigeminal? According to IHS, it's a recurrent paroxysmal unilateral facial pain distribution, one of more division of the, and no radiation beyond including criteria 1, 2, that is elastic professions and civil industry, electric shock like shooting, stabbing, sharp quality, and it is usually preceded by innocuous stimuli and sometimes spontaneous, and no better control another IHD diagnosis. Accordingly, they have classified this trigeminal in 3 categories: classical, secondary, and idiopathic. In classical, that is there is some neurovascular conflict. There may be some compression while offending vessel, and this may be purely paroxysmal or continuous pain. Similarly, secondary trigeminalia that usually they have an underlying pathology in brain like multiple sclerosis, occupying lesions, and other causes. And another is idiopathic trigeminal, that there is no underlying causes found. It can be usually purely paroxysmal and concomitant continuous pain. Now coming to differential diagnosis, basically this patient we have to look for some, usually he have some dental problem or TM joint problem. So we have to rule out all those problems before taking treatment. The symptomatology of trigeminal is very, hallmark of this symptom is that usually that pain is paroxysmal. In other conditions, you never have paroxysmal pain. A sharp shooting character, and usually it lasts for few seconds to few minutes. Coming to pathology, there is a compression of nerve that causes demyelination, and once demyelination occurs, that myelinated nerve root, there is a structure change in the axon. They become more hyperstable, and there is a ectopic axial generation, and there may be extended after discharge. They cross-talk. There may be hepatic stimulation, and there is they found dysregulation of the sodium channel receptor. Coming to investigation, previously I think that before MRI was not recommended this classical presentation, but because of chances of having secondary or classical presentation, the impending vessel or some osteolarger, MRI is now recommended in each and every patient, especially in younger patients, or if the patient is having bilateral symptoms. Usually we have high resolution different techniques are available to find out the impending vessel or neurovascular conflict, and one can see the degree of compression, distortion, atrophy, and newer technology are available for better imaging of this, like diffusion tensor imaging, three-dimensional time of flight imaging, magnetic imaging, and functional neuroimaging. These are the few MRI pictures that shows cerebral axial cerebral level, you can see the content, you can see these two nerves, these are two nerves, trigeminal nerves. This is the root entry zone, this is the systolic portion. And you can see the number of vessels crossing or having contact with this. And one can see that this trigeminal nerve is okay, but this is more of less probably atrophied. And similarly, in this patient, you can see that even the nasal nerves, nasal roots are, one can visualize. You can see this is a normal trigeminal systolic portion is okay, root entry zone okay, but here you can see that impinging vessel that is causing atrophy. Similarly, in this patient, one can see this is the vessel that is crossing over the systolic portion of trigeminal, and here if you visualize, you can see this is the vessel. Here you can see that some as well that is impending and distorting the and this displays the trigeminal. Coming to pharmacotherapy, and first line, you always know that takes carbamazepine can be used in start with 100 milligram BD, and the problem is that it can cause sedation, dizziness, blurred vision, then cytopenia, hyponatremia. These are the common problems with this, and one has to use for longer duration of time that one can use for chronic side effect also, like there is always risk of osteoporosis. And similarly, now new drug that is oxycarbazepine can be used for the same type of drug, and these are all sodium channel blockers. Similarly, lamotrigine also sodium channel can be used with and more or less have similar drug, especially the problem of dry motion and chances of rash. Skin rash is very high. So one has to start with very slow dose and see the response, and chances of having, though it's rare, but chances of having Steven Jones syndrome, start the very high dose or escalate the dose very rapidly. Similarly, baclofen can be used, that is and gabapentin is that can be used in 100 milligram in Indian population. We usually start with 100 milligram HS dose, then slowly make the change the dosing schedule. And similarly, pregabalin can be used, though it's not available in India, 25 milligram, but 50 milligram tablets is available. But problem is that they can cause dizziness, vertigo, drowsiness, depression, nausea, blurred vision, peripheral edema, then confusion. So one has to start this in a slow manner. You start with say single dose at bedtime, see the response, and increase the dosage. These are the few. This is the RCT on pharmacological therapy in cases of trigeminal. You can see that most of the time that they respond very well, especially with carbamazepine. That is 68 to 100% patients do respond with. That's why it's a drug of choice in trigeminal. And oxycarbazepine they also have very good response rate. That is 80%. Otherwise, most of the drugs they have range from 70 to 85%. Then there is how to management acupuncture. Though one can use these line of drugs like lidocaine can be used as a nasal spray, and sumatriptan can be used 6 milligram, botulinum can be 3 milligram. But in my clinical practice, I never found that, because it's a sharp shooting and paroxysmal, very short lasting. Usually, sometimes the patient may have pain, that means you have 3 to 4 episodes of pain, and in between that period, which you usually don't have. So you can always plan properly for next intervention or next line of management. What all intervention procedure can be? They can be non-ablative of nature, like microvascular decompression. That the only procedure that will the cause, that will deal with the cause, like offending vessel. And usually this results in terms of pain relief and complications are very less. Though some of the complications like bleeding and that will be sometimes quite catastrophic. And as a pain physician, and gamma knife is another modality which can go further. But the problem with gamma knife is not all the centers have facility for gamma knife, and lag period is always there. The response gamma knife ablation is maybe 4 to 6 weeks. Another is post availability. I've told you that it's not available in all the. Then, as a pain physician, we are well versed with having some percutaneous transfemoral technique, and one of the commonest technique is RFA. We use Hartel technique. The detail Dr. Anurag will tell you. Then another same technique used, but rather doing RFA, we do give some glycerol, but this was very common in previous time, but nowadays rarely anyone is doing glycerol. The most the physician do the RFA. And probably Dr. Anurag will tell you all in detail about this. And another is percutaneous microvalvular compression. Here what we do is we approach the trigeminal ganglion through transfemoral approach, and once you approach the paraphernalia, when the tip is entry of the foramen, we insert the balloon, that may be Fogarty balloon or amylostomy catheter. Then we inflate the balloon to make a ischemic change in the ganglion. I think Dr. There will be overlaying by Dr. Rajkumar, I'm just skipping this. Another is gamma knife surgery. This is very useful in those patients who are not fit surgery or not fit, even if there is a neurovascular conflict. And this is really useful in young patients. Usually that ablation is made at the level of root zone. You use 70 to 100 degree, and response time is 6 to 8 weeks. Pain relief can occur at initial years 70%, at 5 years 66%. And neurodrugs can be used like corticosteroid, that's not available now. It's a novel sodium channel blocker. Escalcarbazine is a new drug available, and calcium channel can be used for, especially if the patient have, apart from pyrolytic, patient have continuous pain. This is the flow diagram I will take you. This is the flow diagram that tells about the, like in case of idiopathic, you go for pharmacology, especially carbamazine, lamotrigine, gabapentin, or botulinum type. And if there sometime in idiopathic also, the surgeon do internal neuralizing, the combing type of operation can be done, but that is rarely used. The treatment is just gamma knife surgery, graceful isolation, nobody is now. But RFA is the treatment of the most of the time, and one can go balloon compression, and trigeminal MVD, that is not recommended in idiopathic. There is no neurovascular conflict. Similarly, in classical, as we have some neurovascular conflict, one can go after pharmacotherapy. Suppose patient is not getting pharmacotherapy, they have reluctant or have side effect with prolonged pharmacotherapy, or there is a side effect pertaining to that talking, one can go for this. And especially young patient, it's better to always start pharmacotherapy. If young patient, always, I think it's better to refer the patient to neurosurgery to have microvascular deposition, because it's a very long disease, and the patient, young patient, if they can have lifetime problem with this. So if trigeminal MVD is only definitely procedure, it can take care of this disease. Similarly, secondary, if you have some second disease, some multiple sclerosis or some IUL, so it's always better to refer the patient to neurosurgery for a definite treatment. These are the few studies that show that number of patients and median follow-up, pain-free period 89-66, and C at the 82% idiopathy, and balloon compression 50 to 80%. In our clinical practice, we found that balloon compression is good as 95 to 100% pain relief, and similarly radiofrequency also has around 90% pain relief. And duration of action, pain relief, especially with balloon compression, we found that patients are coming back even after 4 to 5 years. And one of the beauty of this is that they ask for similar type of intervention if that required. And most of the time we have, in all the condition, we have intervention related complication can occur. Then anesthesia don't occur. Another problematic problem, especially of this is especially interneuralisis and visual rhizotomy. Mortality in terms of percutaneous intervention is very less unless you have injured some vessel and hematoma has occurred or something that causes more morbidity, but mortality is with the MBD is almost 0.3%. Now coming to this patient, which we described that this patient received CRF of V2 which was done in February 2020, and that after that he was not on any medication during this period, and as there was no coronary, again came back to pain clinic in November 21. That means that effect of RFA lasts only for say 15 to 16 months. We started medication, or he himself started the medication before coming to clinic. That's the period that we have corona. After this we again done CRF, same procedure like V2, V3. Again he had similar type of pain and not able to brush out. He came, I think in November, December. He again came with similar type of, now the frequency is increased and pain is more severe. NRS 9 to 10, then not able to brush, start pharmacotherapy, counsel advised about the value treatment, but he prefers similar type. He prefers CRF to be done this time only. We did CRF, now it's pain free. I think it's almost 3 weeks back I did that RFA. That time he was pain free. The crux of matter is that if you have some, say especially in the classic neuralgia, if the patient is of younger age, no comorbidity, always go for some different microvascular decompression. If the patient is old age, lot of comorbidity, not willing for surgery, and they always have a fear of brain surgery. It's a major surgery and chances of it. So you can do our percutaneous intervention, but if patient is young, having neurovascular conflict, always send the patient first for microvascular decompression. If not willing, then you can go for percutaneous intervention. Similarly, in say secondary time, that means symptomatic patient, he has some problem. So always send the patient for neurosurgery. For idiopathic, one can go for percutaneous intervention. And sometimes the MRI may show some contact, some surgeon may prefer for combic operation or some microvascular decompression in those patients. Thank you very much.
Thank you, sir. It was wonderful. Now thank you, sir. Now we have next speaker, Dr. Anurag Agarwal, the Secretary of ISPC, and again on trigeminal balloon, no? His favorite intervention. Endoscopy, yes.
Rest are also favorite, but they give more of mental and heart satisfaction. So connect. Okay. So good afternoon, everybody. After the stump lunch, नहीं आया दोस्त. So sir has made my job easy. Mohan sir, he is like master of trigeminal and everything related to that. So I will focus very much on the topic given to me. This is my institute, Dr. Ramanohar Lohia Institute of Medical Sciences, Lucknow. Approach, I am going to talk about the percutaneous balloon compression only. That's it, how I do it. And percutaneous approach is again the Hartel's approach given way back 100 years back in 1912. Those are great people who thought of this thing. Patient supine, C-arm fluoroscope must, submental vertex view must, and keep going to locate the foramen mobile. I believe that most of us are practicing pain friction sitting over there, so I am skipping some details. Gun barrel and axial coaxial view, and this is something important. This kit is a commercially available kit. Currently, we are using this kit. Before that, we were using indigenous system of 14 gauge cannula with Fogarty 4 Fogarty balloon. But since last 1 year, this kit has been available more than 1 year now, and we have found it very, very useful.
here you can see that this is a manometer where arrow marker को है pointer है so this is the manometer and this is the balloon the normal Fogarty balloon is 40 centimeter long so sometimes it is logistically difficult to hold the asepsis while using that so but here it is only 15 centimeter almost like that and here this is the tip where the balloon is situated and this is the blunt tipped access cannula and needle and then there is a guide wire followed after removing this thing this will show you in the video so this is just the submental vertex view and this is our volunteer actually OT boy very supporting staff so C-arm patient supine with or without extension of neck is this C-arm you make the AP view then you make the chordate view chordocephalic view in reference to the II and then you make the accelerator oblique view and then comes the video how I do it yes I will try to run it slightly fast ये इसमें नहीं होगा फॉरवर्ड नहीं कर सकते वहाँ से कर सकते हाँ चले साउंड इसमें नहीं आ रही नहीं नहीं वो so patient is in the supine position patient is under general anesthesia we have started doing it in the local anesthesia then we use deep sedation IV sedation now we have switched over to general anesthesia because that makes our life easy as well as patient's life easy because it's a quite painful procedure both because of the 14 gauge cannula as well as the inflation of balloon so our person is making the fluoroscopic view so that we can locate the foramen ovale sound video small only of 2 millimeter size so that our needle can go easily. They made a puncture hole after locating the foramen ovale and now there is chances of the bradycardia. So I have requested my colleague Dr. Shivari Rastogi ma'am to take care and we are trying to reach the foramen ovale in the gun barrel view on the C-arm showing that we have reached up to the tip, and now we are going ahead. Here, you should be able to see the mark. It is slightly more, so we are taking it back. There is a marker at the end of distal end of the balloon, which we need to open. Yes. So now we are around 1 centimeter ahead of the balloon. Now I am going to connect the dye filled syringe and make it open. And now I am going to inject the dye gradually, slowly, taking care of heart rate and all that. You can see that it is coming in a beautiful ear shape. I have injected and I have made it off. Now time is coming. It has come into ear shape. I am going to measure the, yes, show here. I have stopped the balloon, and this is showing the pressure of 200 kPa near to, and no, yes, only kPa, 200 kPa, and we have injected around 0.8 ml of dye into the balloon, and we have made it an off position, and so it is still staying fast. It is staying in the dead shape, that is gear shape, off gear shape. We are also going to check this in the AP picture, and we are going to inflate this balloon for 90 seconds. Yes. Okay, ready? 100 has been passed. Now we are going to wait for another 10-20 seconds. Yes. So, time is over. So we are going to deflate again, open the manometer in the on position and going to deflate it gradually. Please see the and you can see that the balloon has been deflated completely. Now we are going to take the balloon back slightly up to the first mark, so that it means that balloon has come near to the tip, and to take out the complete assembly with the balloon as well as with the reading. So this completes our procedure. It is very important to compress, keep the level puncture wood compressed for 5 minutes at least, so that there are no chances of any leakage of blood or CSS. So thank you very much. We thank you all. So this is how I do it. We do it at Dr. Ramgundui Institute, Medical Sciences. The advantages, sir has already enumerated. We are just forming it again. Very useful in elderly as well as young patient, especially useful for even neuralgia because it does not usually causes the corneal anesthesia as much as other modalities do. But there are slight permanent sensory loss. Sensory loss may stay, but the quality of pain relief is certainly very good, better than radio frequency, which we have found in our patients. And patient cooperation is not required. For radio frequency, you need to ask the patient. Many patients are very much sensitive. They are always crying, why, क्यों बताना है, सुई लगाते रहो. तो इसमें ऐसा नहीं है. Patient in the general anesthesia, you keep on doing whatever you want. Disadvantages, significant masseter weakness in some patients, but it gets better just within 15 days or a month. It becomes tolerable. Patient still complain of something, but कुछ तो हल्का लगता है, but खाना वाना सब खाता है. Aseptic meningitis, dysesthesia, transient otolgia. but now we have become like, you can say, more lion-hearted. So we know that it comes back. So asystole has happened, bradycardia happens many times, but again manageable. What can happen if the improper positioning of cannula? Please remember, 14 days cannula is being used, quite a big thick needle. So if it is superior to intraorbital fissure, retroorbital hematoma may happen, posterior medial to foramen injury to carotid artery may happen. If it is in posterior inferior, it may land into the jugular foramen or carotid canal. So you need to take care of all these things. You need to be quite confident. I will suggest everybody who is new in the field to start with the radio frequency, because that 22 gauge needle is much forgiving than that 14 gauge cannula. So to conclude, subcutaneous balloon compression is an amazing treatment option for trigeminal neuralgia, more in B1, and this treatment and all other treatment, actually all mixes of trigeminal neuralgia must be taught, make awareness about it, because still we see many patients with complete extraction of their dentures without a diagnosis. It should not happen. So please meet your dental colleagues, ENT colleagues, neurology colleagues, inform them. I never ask them to request them to send the patient, they are not going to send. So on a request. So but inform them that yes, this is a diagnosis, this can be made and this can be treated, so that the unfortunate type of society disease is removed or dropped from this thing. So it is not working, I don't know. Last slide में दिखाना चाह रहा था, है कोई बात नहीं, हाँ कोई बात नहीं, चलेगा. So this is my Facebook page and YouTube channel, Pain Free India, Dr. Anurag Agarwal. Here we put many videos, and thank you all for patient listening. Thank you,
Dr. Anurag. Question where absolutely you don't want to do balloon decompression, any case, because you said severe bradycardia, then asystole can occur, and most of the people are elderly, sometimes very elderly.
Actually there's also, मतलब अभी क्या है ना, perhaps we will rewrite the literature. We have patients of 22 years.
I also got the patient of 40.
So ma'am,
40 years I get patients, lot of patients.
20 years with a history of 7 years.
I got the 40.
हाँ, नहीं मैं बता रहा हूँ कि we are getting too many patients, है ना मैम?
But elder, what about, my question is to elderly patient, where you really don't want to do this procedure, then RF is quite safe.
Certainly ma'am. No, but RF can also cause bradycardia. We have got it there also. When you puncture the OA, it happens sometimes, but much lesser than that PVC. But अभी तक तो कोई ऐसा पेशेंट नहीं मिला मैम जिसमें हम ना करना चाहें. But हाँ, ऐसा पेशेंट अगर मैं सोचूं तो हो सकता है जिसमें कि हार्ट इश्यूज, कार्डियक इश्यूज हों बहुत सारे, जिनमें जो पेसमेकर पे हो, तो certainly we would be slightly wary. But again many time patient demands it. अब कितना भी एज हो, तो फिर वो क्या है ना, अच्छी बात ये भी है मैम, क्योंकि जनरल एनेस्थीसिया में हो रहा है, तो most of the things are in control. So even if there is bradycardia, there is some heart issue, perhaps it, मतलब we need to have a clearance, PSC, proper PSC, complete workup and optimization of patient.
You gave balloon the dye, right?
Yeah, dye. Otherwise you won't be able to see that into the CR.
How much time you get?
1 mm, hardly 1 mm. For currently we are doing it for 90 seconds. Yeah. So the people have compressed it for 20 minutes even.
So in your experience, duration
of pain relief?
Yes.
Most of the patients, now we have our experience of PVC from 2017 onwards at RML, and before that at Meerut Medical and Kanpur Medical College. I started at Meerut Medical College after learning from sir in 2012 at BHU Varanasi. तो मैम मेरा कहना है, कुछ पेशेंट तो फॉलोअप टू लॉस टू फॉलोअप टाइप के हो गए, लेकिन जो इतने सालों में देखा है, I would say that 20 to 30% there are recurrence rate. Otherwise, अभी 5 year, 7 year follow-up वाले पेशेंट हमारे पास हैं. Those they are, and मजे की बात इसमें एक और चीज हमने नोटिस करी है पिछले दिनों में, there is immediate pain relief.
That happened to RF also.
No मैम, हमारे मरीजों में नहीं आता मैम. नहीं, वो मैं immediate pain relief की बात बता रहा हूँ मैं. Immediate pain relief, और RF में जो हमारा एक्सपीरियंस है, ऐसे मरीज भी हैं जिनका कि 5-6 साल से
first, after first intervention, 6 months, then 2 months. But then third time, in fact, I asked him, go for either balloon or you go for the other center. But he said, no, I will do from you and same procedure. Now this time he has good relief till 1 year.
Okay.
Now it's 1 year, but
It happens,
the third time also he wanted to do. So as Dr. Mohan said, this patient want the same procedure from same people, but it's true. It's true because they have got so good relief. I think that's why they don't want to go anywhere and do.
But in our experience, we found that duration of sleep after PAD is significantly more than
Yes, sir. But this is what.
But in RF, this patient. Okay. Yeah.
And with complete relief or the freedom of medicine.
Yeah, freedom. Yes. But in this patient. Yes. RF is quite safe. RF. Yeah. But in this patient, when I was doing redo third time, after 2014, then 18, and now this time 2023, there was no stimulation, zero stimulation. I was very fearful, but still we did, and patient has 100% pain relief with the zero, but he has numbness, he has sensory. Yeah. But there was no, till 2, I did the stimulation up to 2, no stimulation, zero stimulation. Yes,
Yes. Actually, we have done few patients after RF. We tried to do RF. हाँ, मैम उसमें रहता है sensory loss और I have seen lot of sensory loss after gamma knife. Gamma knife के बाद क्या गजब वाला almost anesthesia dolorous जैसा देखा है. And same MVD के बाद वाले मैंने देखे हुए हैं.
But they are happy.
Yes.
But he's saying it's okay, madam, ठीक है, कुछ नहीं होता. Pain नहीं है.
Because pain is so bad, na.
Sir, what proportion of patients do have dense hypoaesthesia?
Dense, I would say that 10 to 20% dense. Dense means dense. मतलब इनफैक्ट हमारा जो इतना है 10 to 20 में ज़्यादा बता रहा हूँ. Dense वाले actually 2 पेशेंट थे हमारे, दोनों both are ladies, and one of them is actually unfortunately a mother of my friend anesthesiologist only. So she ended RF first, pain came back after 2 years. This time he demanded actually to the balloon, and she had the bad dysesthesia.
I'm not talking about dysesthesia, I'm talking about hypoaesthesia.
Hypoesthesia, I would say that mild hypoesthesia is always there.
The area is sensitized, but it is not painful.
Certainly. I got your point. मैं उस दोबारा बताने लगा उधर को. सब में होता है hypoesthesia, लेकिन dense वाला we have got 2-3 patient had, and but that also gets better. और उसमें भी मजे की बात क्या देखी है हमने, हमारी पोजीशन तो हर जगह हर बार सेम ही होती है. किसी मरीज में V1 में dense होगा, इधर बताएगा 50% जैसे कल एक मरीज आया था, यहाँ पे और 10% का अंतर, V3 में no difference. So ऐसा भी होता है.
Because as far as my protocol is concerned, I have done approximately 35 to 40 patients of balloon compression. I do 2 cycles of 60 seconds each. 60 seconds, and then deflate the balloon, and then again 60 seconds.
No, you change the position in between?
No, I don't change the position. 60 seconds, but 2 cycles.
No.
Balloon compression. Balloon compression. The pain relief is excellent. My So इसके बारे में recovery of this.
Yeah, that's better. There to one recommendation, vitamin B12 as well as vitamin D. So this which we supplement to all our patients कि भाई टेनिटॉल बंद कर दे, लेकिन एक हमारा ब्रांड है ग्लूकोल प्लस वो हम सबको दे रहे हैं और एक विटामिन डी और साथ में कैल्शियम वो अदरवाइज सपोर्ट करता बॉडी में, but there are few recommendation that decrease the recurrence as well as that helps in regaining the sensation, but I have nothing more to add to it.
And one more thing, when you are removing the balloon, how many times do you get CSF? Because you are actually removing the needle and the balloon together.
That is the must thing. That is the must thing. Never please, never ever do it that they remove the balloon leaving that, because one fine day.
Okay. Because this SYM needle, SYM kit, if we are using, it is blunt. It doesn't damage the balloon. So actually, I am doing the other practice. I am removing the catheter, and then so in almost 40 to 50% patients, I am seeing a significant amount of CSF coming out through the needle. So that was one of the concerns. Although none of the patients developed, कुछ patients में headache, pulsatile headache जैसे PDPH का headache होता है, उस तरीके का headache हुआ है, ठीक है, लेकिन that settled over next 2 to 3 days. NSAID से settle हो गया.
None of our patient had this.
Because CSF leak is one of the complications.
It can happen with any patient.
Yes.
इसमें भी हो सकता है. Far beyond this, we are going into the mid brain.
So my message was that if you find CSF, don't get worried. The patient will be fine, because many times we see and we get worried. So I have seen a lot of patients in which CSF has come out, but nothing bad has happened.
There, what is important is to compress it for 5 minutes.
Yes, antibiotic prophylaxis has to be.
What is important to decrease the chances of any CSF or bleeding, to compress it for 5 minutes. That is very very important, which I always tell to our fellows and we always practice. तो उसमें अगर कुछ हुआ भी है तो वहीं हो जाएगा, बंद हो जाएगा. डॉक्टर भगवान बहुत मदद करता है हम लोग की. Amitesh wanted to say something.
Hello sir. I want to share my experience as well, because I got few patients who had done microvascular decompression, and after 1 year, after later 1 year, 9 months or 1 year, the patient again had this same pain, and then I chose to did balloon compression, and that patient is completely pain free. And I have seen few patients who had done 5 to 6 years back, and they are completely pain free after balloon compression. So for me, I guess balloon compression versus RF, excellent result with balloon, because with RF I used to see 2 years down the lane the patient again used to come with, whether you do a pulse RF or a conventional RF, after 2 years patient used to come with pain. But with balloon I have seen few patients who have been done 5 to 6 years back and completely pain free. Anurag sir, I want to ask one question please. The method which you were using, the manometer in which the pressure, so what is the pressure जिसमें आप देख रहे थे 220 का
मैनोमीटर.
हाँ, तो उसका क्या फायदा है?
फायदा कोई फायदा नहीं है उसका. फायदा केवल ये है कि हमें पता चल रहा है कितना प्रेशर है. I was always curious, तुम्हें पता ही वर देयर. We tried everything which was available, every manometer to measure the how much pressure we are creating, why it is causing so much of relief. So we were unable. We used even the arterial pressure line to that pressure surpass. So when this manometer came into our hand and we found that the 1 ml of dye is creating that 214 psi becomes equal to 2100 millimeter of mercury. 2100 millimeter of mercury, just imagine. So, तो इतना प्रेशर, तो अभी फायदा वादा कुछ नहीं. We are following our patient. We are trying to find out कि कितना प्रेशर किसमें जनरेट हो रहा है और कितना उसका longevity of care. Perhaps we will have some answer someday. और कभी-कभी ऐसा भी होता है किसी भी पेशेंट में there is almost very
so that pressure will be inside the balloon, but it should
inside the balloon, but that pressure is which is it is inserted on the neck.
So there is it may not be always that the pressure inside the balloon is equal to the compressive pressure put on the nerve. Right, because that depends on the where your balloon is and how close the balloon are you in the forehead.
So it can happen, पर एक बहुत अंतर नहीं होना चाहिए. थोड़ा बहुत हो सकता है. भाई वो 2100 हो सकता है, वो 1800 जा रहा हो, लेकिन 1800 mm still is a very very high pressure. So that is the point.
सर एक और था, जो पहले आपने कैमरा निकाला, फिर एक दूसरा गाइडवर्ड डाला, लंबा डाला, उसका क्या फायदा है?
उसका फायदा यही है भाई कि इट इज मेकिंग अ पाथ इनसाइड द गैसिंग गैंग्लियन. सो उसके बाद में जब आप बलून डालोगे तो लेस लाइकली टू डिफ्लेट हियर देयर बिकॉज ऑफ द रेस्ट. सो बलून इज सॉफ्ट. दैट वे ना.
Okay. Thank you very much, Dr. Anurag, for a wonderful presentation and very nice discussion overall. Thank you. So our next speaker in the series of How Do I Do It, Dr. Shivani Rastogi. She will talk on lumbar sympathectomy for CRPS.
Good evening, everyone, and thank you to the organizers who invite me for the topic percutaneous lumbar sympathectomy. Kapis described the technique of lumbar sympathetic block and surgical resection of lumbar sympathetic nerve. In 1950, Bonica, More, and described important lumbar sympathetic procedures. Two techniques were technically described: classic techniques described by the Kapis and Mandal, and the lateral technique described by the Mandal and refined by Reeds and colleagues. So we use classic technique usually. Before going any intervention, we have to be very versed with the anatomy. So sympathetic ganglion of lumbar sympathetic chains are variable in number and position. L1 and L2 vertebra are fused in most patients. Ganglias are aggregated at L2 and L3 and L4 and L5 discs. They may be fusiform in shape, around 10 to 15 millimeter, or around 5 millimeter long. L2 ganglion is at chorded 1/4 of anterior border of L2 vertebral body, and L3 ganglion is at cephaloid 1/4 of L3 vertebral body. L4, L5 are variable and lies in between. So this is the lower border of L2. यहाँ पे L2 का ganglion है. L3 is upper border of L3 vertebra, and L4 is in midway between L4 and L5. So our target needle will be at lower border of L2 or upper border of L3 and L4. The common indications are peripheral vascular disease, arteriovascular disease, Raynaud's phenomena, Buerger's disease, diabetic neuropathy, perioperative vascular surgeries, and complex regional pain syndromes, hyperhidrosis, post-amputation, stump pain, phantom pain, frostbite, and sympathetic mediated pain of any origin. Contraindication to the procedure is local infection or sepsis, coagulopathy, vital function instability, and psychological problems to the patient. In technique, patient is kept in prone position with pillow under the abdomen to flatten the lumbar lordosis. We confirm the label in AP view. We take the AP view and confirm the label. L2, L3, L4 are the targeted label. We square the targeted vertebra by tilting the image intensified either chorded or caudal. Then we oblique the fluoroscope ipsilateral until the tip of transverse crosses in line with the anterior aspect of vertebral body. This is the oblique image of the patient. Then target needle at the inferior portion of L2 vertebra, that is this here, or superior portion of L3 vertebra here, or at L4 vertebra. We introduce a 15 centimeter 22 gauge needle or RF cannula if RF is indicated, and advance internal vision until the bony contact is made at the edge of the vertebral body. This is the fluoroscopic image showing the end-on tunnel vision of the needle. Then we confirm the needle tip in AP view. The needle should ideally approach the mid-pedicular position. The needle tip should be confirmed at level of the facet joint approximately 1 centimeter deep and hugging the vertebral body. We have to pass the needle hugging the vertebral body. Then we confirm the position of needle in lateral view. The needle tip should be at anterior border of vertebral body, as anterior to this are the major vessels, so we should avoid any injury to these vessels, and the depth of the needle is verified in the lateral view. This is the lateral view. The needle should be at the anterior border of the vertebra. After negative aspiration, inject up to 5 ml of contrast solution. Dye spread should be close to the vertebral body in AP view. This is the dye spread. The contrast solution should spread as a straight line at the anterior border of the lateral view, in the lateral view. This is the lateral view showing the dye spread. After confirming the correct position of the needle, one should administer 5 ml of combination of 40 mg methylprednisolone with bupivacaine, and if neurolysis is planned, we can give 5 ml of 6% phenol in glycerin or 50% of alcohol at each level. If RF lesioning is indicated, 10 or 15 centimeter 5 to 10 millimeter active tip electrode is position and confirm as described above. जैसे हम लोग ने L2, L3, L4 पे नॉर्मल न्यूरोलिसिस के लिए निडल डालने, सेम वैसे ही RF निडल डालते हैं. Then we check the sensory and motor stimulation with 50 Hz and 50 and 2 Hz. There should be an absence of fasciculation at the ventral root, dorsal plexus or genitofemoral nerve during motor stimulation. The patient may feel slight paresthesia in the back during sensory stimulation. Thermocognition of sympathetic ganglion can be done at 60 degrees for 60 to 90 seconds. If pulse RF is planned, we can give 20 millisecond per second at 45 volt for 2 cycles for around 120 seconds. We observe and discharge after 2 hours of procedure. And the successful response of lumbar sympathetic nerve is seen by an increase in temperature of at least 2 degrees centigrade, vasodilation, decrease in pain on the injected side of the lower ribs. The complication of lumbar sympathectomy may be neurological. It may be genitofemoral neuralgia in case if we are doing at L4 and L5 with neurolytic agent, but it lasts only for 2 to 6 weeks. Lateral cutaneous nerve of thigh, we are using alcohol. Inadvertent dural puncture, paraplegia, epidural puncture. This may be due if we are doing in the blind procedure. Renal complications may be penetration of the kidney or ureter, transient hematuria, impotence, and retrograde ejaculation. There may be the injury of the vascular components as inferior vena cava. Retroperitoneal hematoma may be formed in case of bleeding diastasis patients, so it is absolute contraindication in such patients. Hypotension may be due to sympathetic blockage. We administer RL before the procedure, and systemic toxic reactions may occur in these patients. This is a small video as how we do. We take patient in prone position, confirm the label, and we go at L2. This we are giving at L3 level. Burgess disease, if we are having gangrene of foot, we can target L4 level. Depth is confirmed in lateral view. After appropriate position of the needles, we connect the electrodes and check the sensory and motor stimulation. Then we inject the dye. The dye should come anterior to the lateral view. This we are checking on the above level. After confirmation of the needle position, we give local sensory key 0.5%, and then we inject 55 ml alcohol 50%.
Anyone has a question? Thank you. It was very good presentation. Our next speaker is Dr. Anuj, and he will present post-herpetic neuralgia.
How many of you are undergoing training? Any MBBS students?
more long lasting, and when in central sensitization, the classic example of nodiplastic pain develops in post-herpetic neuralgia when the duration becomes prolonged. As far as the risk factors are concerned, risk factors, most important is the age. 50% of the patients are in more than 17 years age group. Then immunocompromised conditions, as we all know, diabetes and many other conditions cause immunocompromise, and they make the patient prone for post-herpetic neuralgia. Uncontrolled pain during the acute phase. When the lesions are still fresh, if the pain is not well controlled, then the patients are more likely to land up into post-herpetic neuralgia. Then certain things which can reduce the chances is vaccination against varicella zoster virus, and there is some genetic predisposition which makes the patient more prone for post-herpetic neuralgia. Since the genetic aspects are most of the time unknowns, we can't work upon it. As far as the clinical manifestation is concerned, often the pain is burning, prickling, lancinating. It is associated with allodynia, hyperalgesia, and also it may manifest as anesthesia dolorosa. Anesthesia dolorosa will be in a patient who has been persisting with post-herpetic neuralgia for a pretty long time. And in the later part of the my presentation, we will see that it can persist for years together. So what is the impact on quality of life? There is reduced functionality because of the pain. The patient, if suppose the region affected is the thoracic region, the patients are having difficult time in wearing clothes because of the allodynia. When the clothes rub over that area, the patient has got intense discomfort. So because of that, then most of the time the patients, especially in cold climate, they have difficulty in putting any blanket over them, because again the blanket touches that area, and since there is allodynia, they are not able to put blankets, so the sleep gets disturbed. Then there are all these things lead to depression and other psychoaffective disorders, and some patients start living well without, they adapt in a positive way, but some group of patients, they develop maladaptive coping mechanisms. So these patients stop socializing, and once they stop socializing, another very important thing which prevents the pain from worsening is the descending pathway that modulates pain at the level of the spinal cord. That gets affected because the serotonin and dopamine that is coming from the higher brain centers gets depleted in patients who have got depression. So this psychosocial aspect further worsens the condition. So as far as the principles of treatment is concerned, we have to divide the treatment into two parts. First one is the treatment during the lesion phase, and the second one is the post-lesion phase. In the lesion phase, we all know we have to treat the patients with antiviral drugs like acyclovir and acyclovir. If the patients receive these drugs, the chances of post-herpetic neuralgia reduce drastically. So as soon as we identify that blisters have appeared in a dermatomal region, dermatomal distribution, we have to start acyclovir or famciclovir as soon as possible.
tricyclic antidepressants are the treatment of choice as far as PHN is concerned. Gabapentinoids, surprisingly, they are the most commonly used drugs, but they are not better than tricyclic antidepressants. On the contrary, gabapentinoids cause a certain bit of depression in the patient. So your treatment of choice will be tricyclic antidepressant. Opioids in the form of tramadol or morphine, it may help because the number, as we can see, the number needed to treat is very much comparable to tricyclic antidepressants. Then capsaicin, number needed to treat is very high to advocate its use. Then lidocaine patches, practically I found them absolutely futile in management of PHN, and the number needed to treat for lidocaine patches is not available in the literature. So although the company people say and advocate its use, but I have practically not found them of much use. As far as intervention for PHN is concerned, the most common intervention that we tend to do is a paravertebral block. But here I would like to clarify that as far as PHN is concerned, paravertebral block has to be given in the acute phase. Acute phase, or at least when the lesion phase is gone, the lesions have settled down, and the patient is still having persistent pain, say about 2 or 3 weeks after the lesions have settled. That is the ideal time to give a paravertebral block. Paravertebral block given 6 months or 6 months of year after the disappearance of lesion is less likely to work. This is what the study said. It was published in Neurosciences, and it said that the group 1 is the acute phase group, that is the lesion within 1 month of the lesion. Then the group 2 was subacute, that is 1 to 3 months after the lesion, and 3 is more than 3 months after the lesion. And you can see that there is a drastic difference in the pain relief at the end of 6 months. At the end of 6 months, all the patients started at around, in the beginning, all the patients started around 7 VAS, and at the end of 6 months, the VAS in the acute phase was 1.3, while in the chronic phase, when given in the chronic phase, the pain relief was much inferior. So the take-home message
extra minutes. This was a study published in 2000 in New England Journal of Medicine. And see the number size. Number size is also pretty big. 270 patients divided into 3 groups. It was a RCT, placebo-controlled RCT. And in this, they gave 60 milligram of methyl prednisolone acetate in the intrathecal space at the lumbar level, and then tilted the patient to approximately 15 to 20 degrees in the Trendelenburg position, allowed the drug to come to the region in which, suppose the upper thoracic region was affected. In that case, they tilted the table, allowed the drug to settle till the upper thoracic region, affected region, and they did it on a weekly basis. They gave intrathecal injection of methyl acetate every week for 4 consecutive weeks. And what they found, and this was the age, this was the demographic criteria, that almost the age was in the 60s or the 7th decade. The duration of neuralgia was 3 years and more than 3 years. So pretty long, these patients were suffering for very long time. Then cervicothoracic region was affected in most of the cases. So, and what we see is at the very initial phase, that is at the end of 4 weeks, 81 patients out of 89, they had excellent pain relief. So that's a pretty big number. 81 patients out of 89 patients getting very good relief, and that pain relief was persisting at the end of 2 years. That at that corner, we can see
also work very well, herpes, and even the DRG stimulator. So people are doing these two things also, more than the spinal stimulator.
Yes, if we involve, because face is also a very important area where post-herpetic neuralgia may happen. In that case, peripheral nerve stimulators are a very important modality, but I restricted myself to the cervicothoracic region.
DRG also. As you spoke about the restriction of DRG, so you can put a DRG stimulator also. Thank you.
Sir, excuse me, ma'am. Can I ask? Sir, I just want to ask a thing regarding shingles vaccination. Does it have any role in the post-herpetic neuralgia? Because shingles vaccination. Now, recently, few MRs are coming for like shingles vaccination for a post-herpetic neuralgia patient. Yes, it has been found that vaccination against VZ varicella zoster increases chances of post-herpetic neuralgia. So, in high-risk patients like diabetic patient, elderly patient, that time is immunocompromised. Once the patient has developed the neuralgia, like post-herpetic neuralgia, at that time, does it benefit the patient? Like after you do some intervention or start some treatment, then you give the vaccination. I think because it is actually a recrudescence of the infection. The infection has already happened in the yesteryears, and it is just a reactivation. So I think vaccination will not be the primary action that we will take. We will take interventions earlier than we will rely more on intervention rather than vaccination. Along with the intervention, shall we promote this shingles vaccination? We can. Another thing, sir, do you try T2, T3 sympathectomy? No. Did not find, not tried, did not find, but yes, I can extend my information as far as stellate ganglion is concerned. If stellate ganglion is not working, T2, T3 sympathectomy will also not work because of the conceptual conflict.
I think one more session is going to be there after this, right? So I think we should. Sure. Let's close the session now. Thank you very much, all the speakers and audience.
Finally, the last session for the day on the topic joint pain will be presided by Dr. Navdeep Sokhal sir, Dr. Shivani Rastogi ma'am, Dr. Suman Sokhal sir, and Dr. Rajdeep Gupta ma'am.
Good evening, everyone. Today I am discussing about the approach and evaluation of the joint pain.
Hello. So I think the excess people may go out. So the first presentation is by Dr. Ruma Thakuria. She is assistant professor in MCCCON, and she has done MD anesthesia, and she will be presenting on joint pain. So Dr. Ruma, you may start this.
Thank you. Good evening again. So the topic of discussion is approach and evaluation of the joint pain. Now the objectives I am discussing are the understand the clinical presentation, to recognize common causes and steps to diagnose the joint pain. In the introduction, joint pain is a discomfort in the joint. Sometimes the joint swells and feels warm as well. The joint pain, it can be mild, causing soreness only after certain activities, and it can be severe, making even small movements very painful. Epidemiology, we can see that more than 350 million people, they have arthritis globally, according to the Global Rheumatoid Arthritis Network. And in the US, 1 in 4 every adults, they have arthritis. And it is estimated that by 2040, around 78 million of US adults will have arthritis. So in the statistics, it is showing that arthritis will increase as the population ages. Now, joint anatomy, as we know, it consists of the bones, the articular cartilage, synovium, and the capsule. So whenever a patient comes with the joint pain, we have to think about from where the pain is coming from. Either it is from joint or bursa, muscle, tendon, ligament, or it has referred from other structures. So in the approach, our initial aim is to localize the source of the joint symptoms and to determine the type of pathophysiology that is responsible for their presence. The differential diagnoses are generated in large part from the history and physical examination, and laboratory test results primarily to confirm the clinical presentation. Next step is to differentiate whether this is arthritis or arthralgia. In arthritis, patient will present with joint pain. It is inflammatory, presence of swelling, redness, tenderness will be there, and limitation of movement in every range, and stiffness will be there. And in arthralgia, patient will complain of joint pain, but it is non-inflammatory and without any swelling, and achiness is present. Next step is to differentiate whether it is articular joint pain or extra-articular joint pain. Articular structure, as I have told, consists of the synovium, cartilage, and capsule. In articular arthritis, there is deep tenderness, diffuse pain will be there, and pain is present in active and passive all planes. And all the signs like swelling, crepitus, and deformity will be present. And in extra-articular, that arises from tendon, bursa, ligament, muscle, bone, fascia, nerve, and skin, there is a focal point of tenderness is present, and pain is present only in active movement, but the swelling, crepitus, and deformity will be uncommon. Next steps comes to differentiate whether it is inflammatory or non-inflammatory. In inflammatory, all the classical signs will be present, but in non-inflammatory, these are absent. Inflammatory joint pain, that decreases with activity, but it increases with rest. And in non-inflammatory, it increases with activity, but decreases with rest. And the systemic symptoms like fever, weight loss, loss of appetite will be present in inflammatory, but not present in non-inflammatory. So the list of acute monoarthritis is endless. So few causes I have mentioned like trauma, infection, crystal-induced, Lyme disease, systemic rheumatoid disease, rheumatoid arthritis, and osteoarthritis. And chronic monoarthritis causes include infection, sarcoidosis, enteropathic arthritis, synovial chondromatosis, synovial sarcoma. Oligo and polyarthritis causes are inflammatory causes are infection, crystal-induced, spondyloarthropathies, miscellaneous like sarcoidosis, and mechanical cause include osteoarthritis. And polyarthritis inflammatory causes are reactive arthritis, SLE, psoriatic arthritis like that. And in non-inflammatory causes are osteoarthritis, metabolic conditions, hypothyroidism, hemochromatosis, acromegaly, and ochronosis. So next, while approaching a patient with a joint pain, history tracking is very important. So age is the most important point we have to assess. If a young patient comes with the joint pain, we can think about it can be because of the rheumatic fever, SLE, rheumatoid arthritis, spondyloarthropathy. And when old patient comes, we can think about osteoarthritis, polymyalgia rheumatica, giant cell arthritis. And female patient, most common causes are SLE, rheumatoid arthritis, gonococcal arthritis. And in male patient, ankylosing spondylitis, reactive arthropathy, atrophic spondyloarthropathies are the common causes. Next, we have to ask about the characteristic of the pain. If the pain is present at rest and with motion, and it was at the beginning then at the end, then it might indicative of the inflammatory arthritis. But if the patient only occurs during motion and it improves with rest, then it signifies non-inflammatory arthritis. Next, we have to assess for stiffness. It's a sensation of the tightness when attempting to move joints after a period of inactivity. It typically subsides over time. Its duration also distinguishes inflammatory and non-inflammatory joint pain. In inflammatory joint pain, it occurs early morning and it may last for more than 1 hour. And in non-inflammatory joint pain, it occurs after resting and it lasts only for a few minutes on movement. Next approach includes presence of swelling assessment. In inflammatory joint pain, the swelling may be because of the synovial hypertrophy, effusion, inflammation of the periarticular structures. And in non-inflammatory joint pain, the swelling may be because of the formation of the osteophytes or soft tissue swelling. Then we have to assess for any limitation of motion is there or not. The limitation of movement because maybe due to the structural damage, inflammation, contracture of the surrounding structures. Patient may complain of restriction on their daily activities like difficulty in cutting nails, combing their hair, climbing stairs. Then we have to assess for weakness. If the muscle strength is often diminished around an arthritic joint due to disease atrophy, the weakness with pain suggests a musculoskeletal cause rather than pure myopathic or the neurogenic cause, and manifests like decreasing in grip strength and difficulty rising from a chair. Then next come the fatigability assessment. With inflammatory polyarthritis, it is noted afternoon or in early evening, and with psychogenic disorder, fatigue is often noted on arising in the morning, and it is related to anxiety, muscle tension, and poor sleep. Next important steps in the approaching is that historical features to differentiate for differential diagnosis that includes assessment of the onset, duration and temporal pattern of the arthritis, number of joint involvement, symmetry of the joint involvement, distribution of the affected joints and musculoskeletal involvement. So onset, patient may complain of abrupt onset within minutes to hours, which may signify of trauma, synovitis, crystal-induced arthropathy, or it may be insidious in onset. It may take weeks or months to develop the pain that occurs in rheumatoid arthritis and osteoarthritis. Next, the duration of the arthritis, whether it is acute or chronic. Acute is less than 6 weeks of presentation, and chronic, which is more common, that is more than 6 weeks. Then the temporal pattern of arthritis, there are three patterns: migratory, additive and intermittent. In migratory, if the joint symptoms resolve and then reappear in different joint, it may indicative of Lyme disease or gonococcal arthritis. In additive or simultaneous pattern, symptoms in one joint persist with addition of further joint involvement that occurs in SLE, rheumatoid arthritis, osteoarthritis. And in intermittent pattern, episodic involvement with intervening period that is free of the joint symptom. That is indicative of gout, pseudo-gout, reactive arthritis. Then we have to assess for how many number of joints involved. There are three types: monoarticular, where only single joint is involved; oligo or posse, 2 to 4 joints involved; and polyarticular, where more than 5 joints involved. So types of joint involvement is also important. Predominantly, if it is larger joints involved, it may indicate the spondyloarthritis group. And if small joints are predominantly involved, it may indicate of rheumatoid arthritis, SLE, parvovirus diseases. Axial joint involvement indicative of ankylosing spondylitis, rheumatoid arthritis. And characteristic involvement and the sparing of the joints also indicate different conditions, like in rheumatoid arthritis, where the metacarpophalangeal and the PIP joint involved, but the DIP joints are spared. And in osteoarthritis, the carpometacarpal joint involvement is the first joint, and it involves the PIP and DIP, but the metacarpophalangeal joints are spared. And in gout, the metatarsophalangeal is the first joint to be affected. Then comes the symmetry. Symmetrical conditions like in rheumatoid arthritis and SLE, the number of the joints will be similar on each side of the body. But in ankylosing spondylitis, psoriatic arthritis, and reactive arthritis, in this condition, the involvement of the joints will be asymmetrical. So in this picture, we can see the conditions where there is symmetrical and asymmetrical joint involvement. This is the table that mentioning the conditions of symmetrical and asymmetrical joint involvements. Then distribution and pattern. I have already mentioned that the involvement of the joints also indicate in different conditions, like in rheumatoid arthritis, the DIP is spared, but the metacarpophalangeal and the PIP joints are involved. Osteoarthritis, the metacarpophalangeal joints are spared, but the DIP and PIP joints are involved. So the pattern and distribution also narrow down the differential diagnosis. Then we have to look for any extra-articular manifestations are there or not. like the constitutional symptoms, skin lesions, and ocular symptoms. On physical examination, we have to examine the patient about their general condition, presence of fever, and the vital signs. Then joint examination like inspection, palpation, and a range of motion assessment, and articular and extra-articular features, signs of any inflammation, and functional impairment, like passive and active movement, presence of crepitus, instability, and joint deformity. So these are the pictures showing the extra-articular manifestation in different types of arthritis. We can find malar rash in SLE, then the laceration slaps cheek in parvovirus infection, oral ulcer in rheumatoid arthritis, scleritis in rheumatoid arthritis, and psoriatic plaque in psoriatic arthritis. So here we can see in the upper pictures the gouty tophi presence in the metatarsophalangeal joint, in the fingers and the earlobes, and in the lower picture we can see dactylitis and dystrophy of the nail present in the psoriatic arthritis. So we have to look for these extra-articular manifestations also. Then we have to assess for types of crepitus. In bony crepitus, if there is fracture, the two fragments, they are moved against each other. In bursitis crepitus, inflammation of one or more bursa of synovial fluid in the body will be present. And joint crepitus, the affected joint is passively moved with the one hand, while other hand will feel the crepitus. And crepitus of tenosynovitis, inflammation of the fluid sheath that surrounds the tendon. Systemic examination includes all the system, respiratory system, CVS, CNS, GIT, genitourinary system, and many conditions, they are associated with many findings, systemic findings. So we have to look for all the systemic examinations also. So this is the physical examination of a joint. This is a four-point palpation of a small joints to look for any swelling, pain, redness, and warmth. So always we have to document the number of the swollen joints and the tender joints. This is another test, that is quiz test of the metacarpophalangeal and metatarsophalangeal joint to assess any underlying inflammation in presence of any invisible swelling. So these are the other findings we may get in rheumatoid arthritis, like the buttonary deformity of the thumb, ulnar deviation of the metacarpophalangeal joint, then rheumatoid nodules, hallux valgus, and Heberden's nose and Boucher's nose in osteoarthritis. Then comes the range of motion. So if there is increased range of motion, it signifies unstable joint, and if it is decreased, then it may be because of any underlying effusion, capsule fibrosis, or any bony abnormality. Then most importantly, we have to look for red flag signs that includes fever, weight loss, night pain, neurological signs and symptoms, and poor response to conventional measures. These red flag conditions occur in septic arthritis, gout, pseudogout, fractures. So these patients usually require early hospitalization, undergoing arthrocentesis, injection, or all other investigations. Then comes the investigation for diagnosis and to evaluate the arthritis. That includes laboratory tests, blood tests, so all the hematological tests. It may gives neutrophilia, neutropenia pictures, lymphopenia. So we have to look for the platelet count also. Then the biochemistry tests include uric acid level, ESR, CRP, which are the markers of inflammation and infection, and the CRP is more specific than ESR in an inflammatory joint pain. It's an article published in the European Journal of Rheumatology. They have advised to do this one, rheumatoid factor and anti-cytolipin compound protein antibody, anti-nuclear antibody in critical diagnosis of rheumatoid arthritis, SLE, and also endonuclear antibody and anti-neutrophil antibody should be studied. Rheumatoid factor, it has poor specificity. Only 70% case will be positive, but normally also it can be found in 5% of healthy adults. So high titer associated with more severe disease, and ANA, it is high sensitive for SLE around 100%, but low specificity 10 to 40%. A negative ANA virtually excludes SLE, but positive result does not confirm it. Next comes synovial fluid analysis, that is arthrosynthesis. If the patient present with any warm red joint with effusion, and when trauma is excluded, we have to do synovial fluid analysis, where we have to look for 3 C's: cell count, crystals, and culture. So this table, here we can see the findings in different conditions. In normally, synovial fluid contains less crystal-induced arthritis, we may get uric acid or CP crystals also, but it may be negative in septic and inflammatory conditions. And the culture may be positive in septic conditions depending on the organism before starting the antibiotic. Next diagnostic modality is the imaging. Different modalities are there that includes plain films, ultrasonography, X-rays which are less expensive, useful to clarify the nature of joint abnormality, and it also shows obvious fracture, osteophytes, malalignment, etc. And ultrasonography to evaluate soft tissue, tendon, bursa, ligament, and also useful for joint aspiration and injection. The next modality will be the CT scan, radionuclide scanning, MRI, and PET-CT. Arthrography is another technique. It distends the joint for better separation and visualization of the structures. So this is the flow chart showing the approach and evaluation of patient coming with joint pain. Now briefly about the diagnostic criteria. According to the ACR and ULR classification criteria for rheumatoid arthritis, there are different scores that include joint number involvement, serology, acute phase reactance, and duration of the symptoms. If the score is more than 6 out of 10, it signifies rheumatoid arthritis. And this is the diagnostic criteria for axial spondyloarthritis according to the ASAS classification criteria. I will not go into details. This is for the peripheral spondyloarthritis. This is the Casper criteria for diagnosis of psoriatic arthritis. Then SLICC, SLE Collaborating Club classification criteria for SLE diagnosis. So my take-home message are: joint pain has a wide range of etiologies like infection, inflammation, degenerative condition, paraneoplastic and metabolic diseases. So commonly associated with the systemic disease, and hence important to look for any extra articular manifestation or systemic features. Basic workup includes CBC, ESR, CRP, rheumatoid factor, anti-CCP and ANA. And imaging should be used judiciously to support the diagnosis. UAG and MRI can pick up early erosion better than X-ray. Thank you.
So, any questions? I think, thank you. I welcome next speaker, Dr. Sudhakaran, to tell about more USC guided SIJ intervention. Dr. Sudhakaran is HOD, Intervention Pain and Spine Specialist in Coimbatore, Muthu Super Specialty Hospital, and CU many laurels to him, MD, PDCC, and research publications in many national and international journals. And his special interest in musculoskeletal ultrasound. So I think he is a good person to tell us SIJ ultrasound.
Okay. I thank the organizers and the audience who is having limited time. So greetings from Coimbatore on behalf of my working place, Dr. Muthu Super Specialty Hospital. So as USC is catching up, I am going to rush through these topics. First is the USC ultrasound feasible. What about its accuracy and what about its efficacy? Head-on studies with fluoroscopic models. And then anatomy. The landmarks you need to know to do this procedure. And bone water model. This bone water model can be used for practice purpose, or just to pinpoint what is the target, or what is the target, whether the target is intra-articular or peri-articular in the sacroiliac joint, or which drug to use. The steroid is effective or platelet-rich plasma, which is the best, and a 2-minute short video and summary and result response. So is ultrasound, the feasibility study was first done on 2005, that means 2 decades back. At the time, the accuracy was just 40%, and the recent study in 2023 So with the advances of the ultrasound imaging, the accuracy part has improved, and also the technical skills as pain physicians we are improving on that. That has also helped in improving the accuracy. And second thing, efficacy. Efficacy, there are so many studies, head-on studies exactly comparing the ultrasound versus the fluoroscopy, and they claim they have good efficacy both with ultrasound and fluoroscopy. Both, it's not only that, they have done studies in inflammatory pathologies and non-inflammatory pathologies. In both type of pathologies, the efficacy, whether you do the procedure under ultrasound guidance or with fluoroscopy, the efficacy that remains the same. I will tell you the reason later. So what are the bony anatomy things if you want to do this procedure under ultrasound? Usually if you do under fluoroscopy, you will target only the joint, the sacroiliac joint, that too at the inferior portion. That's what we are trying to do. In ultrasound, the things you should know before putting the probe and before doing this intervention is this L5 spinous process, the sacrum, and then sacral foramina, as name implies, the sacrum and the iliac, the joint. So another thing that is very important in the sacroiliac joint is the ligaments. These ligaments and the surrounding muscles give stability to this sacroiliac joint. It is important to know these ligaments for two reasons. One, these ligaments, when you are using regenerative medicine, you should target these ligaments around, and that while needling or needle jogging, the tactile sensation while putting the needle, while piercing the needle, will gives the depth judgment. This is the image of CT images. It looks like a flying bat. This normally when we choose that fluoroscopic guidance, we choose only the inferior part of that sacroiliac joint. But in ultrasound guidance, either you can do upper level sacroiliac joint intervention or lower level sacroiliac joint intervention. Though as we compare to, if we want to put the needle in the intraarticular, we can choose this portion where this comes at the level of the second sacral foramina. You can see in the ultrasound by seeing the height of the ilium and the sacrum. It would be like in the same level. However, because of the technical difficulty or any osteophyte's old age, if it is not possible to put the needle at this target point, you can choose to put the needle at the bit upper part. So at this level of the sacral foramina S1, where the sacral iliac joint is bit wide, and you can find in the ultrasound by having a iliac at a higher shadow, casting shadow. This imaging anatomy is given pretty well in the picture. Our target point is here between the lateral edge of the sacrum and ilium to pierce through the muscles and the ligament and deposit the drug here. Next is the bone water model. This one, when the probe is the anatomical, the bone model can be placed inside the water, and you can put an ultrasound probe. And you can see this one from when you put the probe from the L5 spinous process and track it down, you can see slowly, and the probe is made from medial to lateral position. This is the sacroiliac joint, and the near to that hollow structure is the sacral foramina. This is the deeper part is upper part of the sacroiliac joint, and the lower in the level of the sacrum and the ilium at the same level is down. It is at the level of this lower part of the sacroiliac joint. You can these both can be targets. Before doing any ultrasound procedure, do a scout scan. The same like the bone water model, L5 spinous process, patients. It is the probe is moved out inlet. This is the inferior part of the sacroiliac joint. Now I come to the upper part. This is the upper part of the sacroiliac joint. This is the target. Then in the lateral edge of the sacrum, this is the ilium, casting hypoacute shadow, and the needle should come from medial to lateral to pierce this ligaments and target here. So preparation. So make yourselves comfortable and also the patient comfortable. You make yourselves comfortable by keeping, by following the ergonomics, by keeping that ultrasound opposite to you, and make the patient comfortable by keeping a pillow and with the arms by the side, everything. And the pillow should be kept under the pelvis to straighten out the lordosis. And you can have that CM ultrasound also if you want during early days, if you want fluoroscopic guidance also, if you want to check the intra-articular placement, you can use the ultrasound. And follow asepsis. View. As already told, the curvilinear probe is scanned from up to down towards the sacral addus, and the probe is moved from medial to lateral position till you visualize the ilium. Our target point, the sacroiliac joint, is at the lateral border of the sacrum and the ilium. Here you will be able to visualize the joint. These are the two ligaments, intraosseous ligament and posterior sacroiliac ligament. After anesthetizing the skin with local anesthetic, you can target, you can put the needle from the It is better to use a blunt tipped needle with the markings. The blunt tipped needle gives you a sensation of piercing the ligaments and entering the joint. That would be more compared to the 22 gauge normal spinal needles will be using. And also you can sometimes this block is comparatively not for beginners. It is in even with studies they are saying you need at least 13 to 30 procedures to have comparatively bit of accuracy in achieving the intra-articular position. Because the transversal position most of the times it won't be in the transverse position, it will be bit to oblique where the needle visibility would be a problem. So for improving the needle visibility, you can use either hydrodissection with saline or you can jab the needle so that you can see the tissue movement and point out where the needle is. Once the needle is in the target position, you can give either diagnostic purpose local anesthetic plus steroid mixture, or you can give platelet-rich plasma for as a regenerative medicine. So with ultrasound, what we more achieve, whether we place the needle intra-articularly or peri-articular. As such, as I already told, the accuracy rate initially was with previous studies was 60%. Now with the dual hybrid imaging, it is improved up to 85% to 95%. But doesn't matter because the new studies are coming up. They said peri-articular is more better or equal efficacy compared to intra-articular. Whether you put the needle in intra-articular or peri-articular, the result is going to be the same. Even they are saying with newer studies, they are claiming mainly in that post-pregnant woman or musculoskeletal cohorts like the peri-articular drug works better than intra-articular ASI. So next, whether to put inside the PRP or steroid. Steroid mainly inflammatories gives immediate relief along with local anesthetic. If you put choose to put platelet-rich plasma, it is going to take definitely a lot of time. So it will take at least 3 weeks to 4 weeks to start, and the peak effect total comes only on third month around. But the advantage is you will get a more longer lasting pain relief. So evidence at present is grade 4, that means it is very limited. Summary, so to choose ultrasound compared to fluoroscopy is a safe, cost effective and efficacious in terms of pain reduction and disability. It is a good modality for sacroiliac medicine. Thank you. Thank you.
Wonderful presentation, and I think this is the only presentation which is finished before time. So, Dr. Sudhakar, can you tell me, have you performed both the procedures under fluoroscopic guidance and ultrasound guidance, and how you think that one is superior to other, or both are equal?
Sir, mainly the cost effectiveness, sir. And also I can target for if you are putting steroid, because the most studies are putting peri-articular is good. So if you ask me, there is OD time, there is a need of 2 technicians to show me this, and the costness is comparatively once you first you learn with both hybrid, with ultrasound and fluoroscopy. Once you are confirmedly accurate, you will refine your techniques. Mostly the oblique part and the needle visualizing part is the most difficult part. Once you get accustomed to it and see the depth, and then you can get away with USG only. So at present, if I am sure, if I have 3-4 differential diagnosis, if I want to rule out, because sacroiliac joint, it is there is no single diagnosis. Even MRI would be normal. Then only thing I can do is put a needle and see if the patient is relieved. So I have 2-3 things I had a 75-year-old patient who had done bipolar arthroplasty, but the primary surgeon advised a revision hip. He came to me. My diagnosis was SA joint pain. The only way I can differentiate is that put a needle in it. So first time I'm going to put under fluoroscopic guidance, that is more confident, because their accuracy is, I can say with the dye it is 100%. So ultrasound it is good 95%, but still I do not like the second time if he comes to me for RF or the PRP, I will definitely do under ultrasound only. So that cuts the cost, radiation, everything. So like also pregnant 2 months, the difference will be L5 no root SA joint. Then first diagnostic 100% accuracy. Then second, then it will, because SA joint it doesn't go away immediately or not with a single shot. Okay, thank you.
Thank you.
So we call on last speaker, Dr. Shashank Kumar, for the lecture on approach to a case of knee joint. He is an associate consultant in Medanta Hospital, Lucknow. He has done PDCC from KGMU, Lucknow, and CCEPC Palliative Care. Welcome.
A very good evening to everyone, respected faculty members. It gives me immense pleasure and pride that the institute from where I graduated and did my PDCC, I am presenting here as a faculty member. So my today's topic is basically approach to a case of knee joint. So it will be basically a case-based approach. So I will begin with the case presentation. A 67-year-old female patient, which was apparently asymptomatic 2 years ago, when she then developed pain on the left knee, which was insidious in onset. The pain was pricking in nature with pain score of 3 on 10, no radiation, which aggravated by walking and climbing stairs and relieved by rest. However, the pain increases to the score of 7 by 10 for the last 2 months. The pain is associated with limited range of motion of the knee. Currently, the pain is reduced to 2 by 10 on medications. She also had similar complaints in her right knee, but it was milder compared to the left knee. Otherwise, she has no morning stiffness, no history of trauma or fall, no fever, no knee swelling, giving way or locking. She is able to ambulate without walking aid and use walking frame if there is pain. There is no other joint involvement. As far as the past medical history is concerned, she is having hypertension for 8 years on tablet amlodipine 10 mg OD, no history of diabetes mellitus, ischemic heart disease, tuberculosis or bronchial asthma, no relevant history of family, past surgical or personal history. As far as socioeconomic history is concerned, she is married and having 3 children, lives with her husband and son, previously working as a government teacher, right now retired. She is financially stable, pensioner. In general examination, the patient is lying comfortably in semi-recumbent position, alert and cooperative. She is moderately built and well nourished. Her BMI is 31.4, obese. Vital signs were stable. Pulse rate was 70 beats per minute, regular, normal volume, normal volumic character. BP was normal, 145 by 92, respiratory rate 18 breaths per minute, afebrile, no pallor, no pedal edema. In systemic examination, cardiovascular examination, respiratory and abdominal examination were all normal. As far as the local
In the standing position anteriorly, both hips are extended and adducted, knee and ankle at neutral position. There is genu varus deformity of the left leg, that is deviated outside the medial part, and the ankle is pushed inwards. There is muscle wasting at the left thigh and the left calf. There is apparent shortening of the left lower limb. There are no scars or swelling. Laterally, there are no deformities, scars or swelling. Posteriorly, there is no swelling on the popliteal fossa or scars. The gait is antalgic due to pain. In supine position, in the anterior attitude, hips both are flexed at 30 degree, knees both are flexed at 5 degree, both are neutral position ankles. There is muscle wasting at the left thigh and left calf. There is apparent shortening of the left lower limb. There is no deformity of the left leg. There is no scars, no swelling. Laterally, there is also no scars, no swelling, and no deformity. There is local rise in temperature that the joint is probably inflamed. There is tenderness of the medial joint of the left knee. Crepitus is felt upon moving the left knee joint. As far as the movement is concerned, right side the movement is normal. On left side the extension is 0 degree and flexion is approximately, the range of motion is restricted to 0 to 90 degree on active as well as passive. As far as the measurement is concerned, the apparent length of right side is 104 cm and left side is 102 cm, which is from the umbilicus to the medial malleolus, and the true length is 85 cm on right side and 84 on left side, which is from ASIS to the medial malleolus. Above knee, the length is 44 cm both sides, and below knee, right side is 41 cm and left is 40 cm. As far as the neurovascular examination is concerned, the peripheral pulse is palpable and the capillary refill time is less than 2 seconds. Distal pulsation were felt on both the sides, that is the dorsalis pedis artery and the posterior tibial artery. The neurological examination was also intact on both the lower limbs, and the patient was able to dorsiflex and plantar flex for left ankle joint. As far as the spatial tests which are concerned for the knee joint, the varus stress test was positive. The valgus stress test was negative. The patellar grinding test was positive. Patellar tap test was negative. McMurray test cannot be elicited due to pain of the knee joint, left side. In the X-ray view, the AP view, there is a narrowing of the medial joint space. The subchondral sclerosis is present and the osteophytes are present. In the lateral view also we can see there is narrowing of the patellar space. The joints is basically coinciding, and there is subchondral sclerosis. As far as the blood investigations are concerned, the CBC was normal, ESR is raised to 45 mm per hour, and the CRP is also raised to 7.2 mg per liter, and the RA factor came to be negative. Now, this was a case presentation which is pointing towards osteoarthritis of the knee of the patient, and what should be our clinical approach to a knee pain we will be discussing now. Supposedly the patient is complaining, hey doc, my knee has been hurting. So we begin with the history. History says the Socrates pain questions approach, that is the site, onset, character, radiation, aggravation, timing, exacerbating factor, and the severity. The inflammatory symptoms like the patient is having fever, the localized warmth and tenderness, history of any trauma or surgery, there is instability, functional loss, or the patient is having any prior treatment. Next we go to the physical examination, that is the vitals, the BMI, palpation, isolate tenderness, whether there is any effusion in the joint, the crepitus is present, bony crepitus, decreased range of motion, measure the degree of flexion, whether there is stability in the joint ligaments and menisci, alignment, that is the genu varus or valgus deformity. The gait is antalgic gait due to pain or duckwaddle. These are the tests which are applied for to test the knee pain. Valgus test. Here the patient is, we are on the lateral side of the patient, and we use our right hand as for applying pressure toward the medial side, and left hand for the below the knee and applying pressure to the lateral side to see any instability. and the opposite is done for varus test. Similarly, Lachman test is done. In McMurray test, we externally rotate the hip joint and push the knee joint in the lateral direction and see for any tenderness or pain. Duck waddle is done, the patient is asked to sit like a duck, and we are basically testing the stability of the knee joint. Now, as far as the investigations are concerned, we go for the hemogram, that is complete blood count, ESR, rheumatoid factor. If any effusion is present, we can go for arthrocentesis, X-ray, 3 views, weight bearing, AP view, lateral or tangential, patellar sunrise view. Or we can go for MRI in the extreme cases. The differential diagnosis of knee pain include, according to the sites, medial, lateral, diffuse and anterior. Osteoarthritis pain is common in all. Medial pain can be due to MCL, meniscus or bursitis. Lateral pain can be due to lateral collateral ligament, meniscus, iliotibial band syndrome. Diffuse pain can be infectious arthritis, gout, pseudo-gout, rheumatoid arthritis. And anterior pain can be due to patellofemoral syndrome, pre-patellar bursitis and quadriceps mechanism. The diagnosis of knee osteoarthritis is basically established by the classical clinical criteria, which was established by the American College of Rheumatology in 1981. The sensitivity is approximately 95% and specificity 69%. So basically the criteria includes, that is knee pain plus at least 3 of the 6 characteristics. First is age greater than 50 years, morning stiffness lasting less than 30 minutes, bony crepitus, bony tenderness, any bony enlargement, and no palpable warmth. So the classification tree is mentioned here. So initially, beginning with the X-ray findings, if there is X-ray spurs that is are present, then it is definitive of osteoarthritis. If they are absent, we can go for the synovial fluid signs that are WBC less than 2000 per millimeter cube, clear in color and high viscosity. So if the synovial fluid sign is 0 or 1 and age is less than 40, then it is not pointing towards osteoarthritis. If there are 2 or 3 signs of synovial fluid criteria and the age is greater than or equal to 40, we will look for morning stiffness. If it is greater than 30 minutes, then it is not osteoarthritis. If it's less than 30 minutes and crepitus is present, it is pointing towards osteoarthritis. The X-rays will be showing the osteophytes, loss of joint space, subchondral sclerosis, and cyst may be present. The gold standard technique is for diagnosis is arthroscopy. So in these 3 X-rays, we can see the basically normal knee, then there is narrowing of the joint space, bony spurs and osteophytes are present, and in the very severe category, very limited space is present between the joint space. So osteoarthritis, it has become very common, so it's been suggested whether it is a part of life or a curable disease. So first of all, beginning with the information and advice that should be elicited in the very beginning stage before even diagnosis is confirmed. And to begin with, we will modify our lifestyle and self-management like weight management, exercises, simple analgesics, topical NSAIDs for local application. Then we will be beginning with the simple non-surgical, that is oral NSAIDs, COX-2 inhibitors, braces or inlays, other aids. Then switching over to interventions, that is injection, intra-articular corticosteroid, platelet-rich plasma therapy, prolotherapy or genicular nerve block. And the last option in the very severe cases is the surgery. So basically coming to the algorithm, the basic principle and concept, that is the combination of treatment modalities includes non-pharmacological and pharmacological therapies. Initially begin with the information and education, weight loss, exercise program. If symptomatic, we will begin with the supplements, that is the glucosamine sulfate and the chondroitin sulfate, and paracetamol if needed. If still symptomatic, we can add on the topical NSAID. And if referral to the physiotherapist is advised, we can do it accordingly. If symptomatic, we can add the walking aids, thermal agents, heat and cold application, mechanotherapy, bandage tape, hydrotherapy. Advanced pharmacological management if persistent, intermittent or longer cycles of oral NSAID. If the patient is having normal GI risk, that is GI
Non-selective NSAIDs with PPIs, Pentop, COX-2 selective NSAIDs, preferably with concomitant PPIs. If the patient is having increased GI risk, we will prefer COX-2 selective, that is celecoxib with PPI. Be mindful of complications with any NSAIDs. If increased CV cardiovascular risk is expected, we will limit any use of NSAID, and treatment duration should not be exceeding more than 30 days in celecoxib and less than 7 days for non-selective. In increased renal risk, we will be avoiding NSAIDs. If the patient is still symptomatic, we will be proceeding to intra-articular injection. And if still not improving, we can add on duloxetine and short-term weak opioids, then can switch over to higher opioids, and last option is the surgery. As far which I have already discussed the management, the lifestyle part. Initially begin with the glucosamine and chondroitin sulfate. The dosing is 1500 mg or 1200 mg daily. Glucosamine are building block for glycosamine glycans and glycosamine glycan in articular cartilage, and the patient is satisfied. The dosing for various osteoarthritic pharmacotherapy intervention are acetaminophen from 325 to 650 to 100 mg for 4 to 6 hours every day. Duloxetine 60 to 120 mg once daily. Celecoxib 100 mg per hour BD or 200 mg once daily. Diclofenac, meloxicam, ibuprofen, naproxen sodium, and tramadol. Now coming to the interventional management according to which pain physicians after giving the pharmacotherapy prefer are the intra-articular injections. That is the glucocorticoids. To start with the triamcinolone acetate, hyaluronic acid, prolotherapy, that is the hypertonic 25% dextrose, platelet-rich plasma, and the genicular nerve block. So basically, the steroids are indicated in inflammatory stage and local flare, and the other ones have different mechanism in building and making the patient basically dealing with the pathology of the osteoarthritis, that is regenerative properties. Thank you.
So again, this is good presentation. So can you tell me how the prolotherapy works in joint pain?
It basically causes the localized reaction in that particular joint space, which leads to regeneration and basically proliferation of the growth factors, which leads to healing of the joint space, localized cartilage of that particular joint.
Okay, and now there is like combination drugs which contain hyaluronics and steroids. So have you used, and what is your experience with that?
Hyaluronics?
With steroids.
Usually I have written in this, but mostly that was my thesis topic as well. I used prolotherapy and steroid and platelet-rich plasma. I haven't practiced hyaluronic acid.
Okay, so tell me your experience.
As far as my experience is concerned, the steroid gave instant relief to the patient, and when compared to prolotherapy, the results were almost similar, but the instant pain relief was possible with steroid, and for a longer term of duration, slightly prolotherapy was much better. And same applied with platelet-rich plasma, that the onset was delayed, but it gave a prolonged relief for longer duration. Approximately 3 to 6 months.
And which stages you are seeing better result?
In the initial ones, stage 2 or stage 3.
Can we repeat it? And for how many months?
Platelet-rich plasma.
PRP or prolotherapy?
Yes, we did repeat it after 1 to, depending on the patient's response, we did repeat after 3 months. If the patient responded to it, we repeated after 3 months.
Actually, there are no guidelines for any repetition amount. So different regimes are being practiced in the.
Depending on the condition and depending on.
We can repeat in 1 month for 3 doses, and within 15 days they are repeating. So कोई guidelines नहीं है, कोई protocols.
So anyone want to ask the last question for today?
Do you use ultrasound for diagnosing knee condition?
We can use ultrasound for performing intra-articular injection, but what I usually practiced was C-arm guided or blind.
Which approach you use?
Anterolateral.
No, superior or inferior?
Inferior.
I am asking, thank you Dr. Sasan for the nice presentation. I was actually asking, do you use ultrasound for diagnosing the condition? Because it has many times happens to me that I examine with ultrasound, there is effusion, there is synovial hypertrophy, but the inflammatory markers like ESR, CRP, they are normal. So how do you proceed for those cases?
My experience is limited in that case. I would suggest the experienced faculty members should respond in that case.
Ultrasound screening you should do in every patient. Sometimes there are effusion and patient present with pain, but minimal effusion आपको दिखेगा भी नहीं, बहुत ज़्यादा उसका intervention में आप aspirate भी नहीं कर पाओगे, 4-5 ml allotment से आ जाता है तो मिल जाता है, but you can't aspirate that. In that case PRP करके उसको tight bandage करके knee caps बनवा देते, तो वो अपने आप धीरे-धीरे absorb हो जाता है. अगर ज़्यादा है और आपको उसके अलावा भी meniscal tears दिख जाते हैं, क्योंकि that is causing whole knee pain. Agar if there is meniscal tear, you can give at that site also.
Yes, thank you, ma'am. Ma'am, actually I want to ask, it suggests inflammatory condition, like there is huge effusion with synovial hypertrophy, and the third thing is like vascularity, increased vascularity, but I don't get much proof with increased vascularity.
In which cases? In arthritis patient, RAF cases?
Ma'am, there is a patient with knee pain, age around 40-50.
In PRP we can give in RA patient also. There is swelling and vascularity increase. They have symptomatic relief.
Okay, thank you.
Thank you.
So I think we end the day, and this was wonderful. We meet you in the dinner. Thank you.
Yeah. Dr. Navdeep Sokal, Dr. Shivani Rastogi, Dr. Suman Sokal, Dr. Ruma Thakuria, and Dr. Sudhakaran Ramsay, Dr. Shashank Kumar. Please come for one group photograph. Yeah. Dr. Nitesh. Dr. One for the group. नहीं, sir, first come for the group.
हाँ यूट्यूब पे किस नाम से ये इसी नाम से डाल दीजिए किससे पूछें ये मेरे में है शायद यही आप नीचे डाल दीजिए ये क्या बोलते हैं ISPCCON हाँ
अरे तुम लोग भी आ जाओ भाई बृहस्पति शुभेंदु तब आएंगे बेचारे दहशत नाले बदनाम करते हैं मुझे जो है हम लोगों को जो है हम लोग जो धमका के रखते हैं इसलिए आ जाओ जल्दी से ये केस बनाना चाह रहे हैं कि देखो कितना अत्याचार हो रहा है हम लोगों पर
भी खींच देगा। हमारा लाइव चल रहा है, हम इसका कैमरा नहीं हटाते ऐसे वो पैसे बता देगा तो बिल भैया कौन सा दिखता है। रवि ऊपर परेशान होता है।
To facilitate Dr. Navdeep Sukha.
अभी है तो ऑफ नहीं करें है गुलदस्ता देखिए।
I invite Dr. Anurag sir to felicitate Dr. Navdeep Sukha. I invite Dr. Amitesh Pathak sir to felicitate Dr. Shivani ma'am. I invite Dr. Sudhakaran sir to Dr. Anurag wants to felicitate Dr. Suman Sokal. Dr. Navdeep Sokal sir to felicitate Dr. Roma Thukuria. And Dr. Sudhakaran Rams.
आप ऋषिकेश में तो थे ना? I'm in Mumbai. I was never in Rishikesh.
Dr. Shashank Kumar.
ये तो कॉन्फ्रेंस हुआ था पिछली बार उस वक्त आप नहीं
सर एक मिनट
ऋषिकेश में नहीं ऋषिकेश वाली कॉन्फ्रेंस में
लाइव चल रहा था ना इस चक्कर से बोला।
Dr. Amitesh Pathak sir to felicitate Dr. Vishnu. Thank you everyone.
ये फोटोग्राफ्स अपलोड करेंगे, ये वीडियो भी अपलोड करोगे?
यूट्यूब पे चल रही है,
चल रहा है, सब
लिंक तो
यू आर इन चांदनी एज वेल नाउ
सर ये सामने तो है सर, सामने लिखा है।
कहाँ सर?
ये बता रहे
क्या हुआ? ISP कौन?
ये देखिए
देखो बेटा, हम इसको डाल है ना,
नहीं डालना है।
बहुत सारे क्लास छूट गए हैं। एक सेकंड
Got the bet.
You received this back? हाँ, not yet got the back. No, I will get it tomorrow.
नीचे जो लिखा हुआ है 2023 बस ये